Good
morning, sir. Dr. Akbar Shah.
Dr. Akbar Shah, good morning. और डॉक्टर लोहिया सर, ऑर्गेनाइजिंग कमेटी जो सिलेक्ट करती है स्पीकर्स को, वो भी इम्पोर्टेंट है सर। ऑर्गेनाइजिंग कमेटी को भी धन्यवाद जरूरी है सर।
बिल्कुल सही है, पर
प्रोफेसर लोहिया इज एट बेस्ट।
मोस्ट इम्पॉर्टेंट है स्पेंडिंग टाइम, और वो जो सर बहुत करते हैं, दैट्स वेरी वेरी इम्पोर्टेंट बिकॉज टाइम इज द रियली कंस्ट्रेंट फॉर अदर्स।
डेडिकेशन इज, जो आप कमिट तो ओनरशिप और डेडिकेशन से जो आप काम करते हैं तब देन रिजल्ट उसके हिसाब से।
तो एक मतलब अगर जरा सा भी डिले हो तो इमीडिएटली वी गेट द कॉल और मैसेज।
He has not left anyone, sir.
ये अपना धीर सिंह जी अपना एक्सपीरियंस बता रहे हैं।
ना इट्स इम्पोर्टेंट। अक्सर आजकल क्या होता है ना, जो ऑफिशियल में है वो जूम की वजह से आजकल मीटिंग्स बहुत हो गई है। एक्चुअली जस्ट हाफ एन आवर दे सेंड ए लिंक, प्लीज ज्वाइन। अर्लियर प्लान करने में टाइम लगता था, अब वो इतनी मीटिंग हो रही है सब, हमारी समझ से इट्स मल्टीपल हो गया, बहुत मल्टीपल।
और लेकिन हो जाता है कितनी बार कमिटमेंट्स जो हैं तो दिक्कत हो जाती है। ये अप्रिशिएट।
But Zoom has, means the Corona has also teach us actually. I think that the TA is not going to be used now, and most of actually this meetings they are going to be cut. Government is also going to be very, क्योंकि अगर ये seriousness ने कोरोना नहीं होता डॉक्टर साहब, इतना मीटिंग इस पे कोई एफर्ट करता नहीं। Somehow वो कहते हैं होता नहीं है डिस्कशन, तो वहां पे पहुंचता नहीं। अभी तो everyone is है।
अभी उम्मीद करते हैं कि नेक्स्ट टाइम अपन सब लोग आपस में मिल सकें।
नहीं सर, फिजिकल तो देखो, फिजिकल कैन नॉट बी रिप्लेस्ड विद वर्चुअल एट एनी कॉस्ट।
बट लेकिन एक बात है कि धीरे बिकॉज ऑफ दिस पेंडेमिक वी गॉट सम टेक्नोलॉजी जिससे हम कनेक्ट तो हो सके, शक्ल तो दिखाई दी, वरना तो बैठे रहते भाई, शक्ल भी नहीं दिखाई देती लोगों की।
या दैट्स
so at least the technology came in the right time and we use the technology. कॉमन हर आदमी के पास मोबाइल में भी पड़ा हुआ है, यू कैन टॉक एंड बात कर सकते हो, मीटिंग कर सकते हो, ऑन वे पे कर सकते हो, जो पहले संभव नहीं था। लेकिन फिजिकल इज फिजिकल, उसका तो कोई मैच है ही नहीं। दैट इज ऑल राइट।
ये ना, वी हैव टू बी ऑलवेज केयरफुल। सम ऑफ द इंडस्ट्री गोइंग, हॉस्पिटैलिटी इंडस्ट्री इज बैडली अफेक्टेड।
Oh yeah, that's right.
Sir, we used to have the video visual rooms for the meetings earlier. A lot of setups used to be there. Nowadays with mobile we are able to do that.
Yeah, that's right.
चतुर्वेदी साहब, Professor Michael Aruldas is not available, so
ज्वाइन नहीं करेंगे सर, वो ज्वाइन नहीं करेंगे।
kindly handle this session yourself.
या वो आगे मैसेज देख लिया मैं उनका, वो ही इज नॉट ज्वाइनिंग।
Okay. For that, I think Professor Ansari and our Dr. Barkha, they are communicating
perfectly.
communicating.
That is why I complimented the organizing committee, na, कि the each and every manner detail they are communicating it well in time. That is the what purpose is. Technology है, उसको समय से यूज कर लेंगे तो बहुत बढ़िया है।
बिल्कुल। ग्रुप बनाया जैसे day 1 day 2, तो that is a very convenient way of.
That's right.
Professor Akbar Shah is seen now.
Sir, you are in mood, sir. Dr. Akbar Shah, please unmute.
Yeah.
Good morning, sir.
Good morning, Professor. Morning.
Good morning.
Very nice seeing you, sir. And Ansari.
Good morning.
Good morning, Ansari. Good morning.
Their seating is very good, sir. Dr. Ansari and Professor Lohia.
Yeah, yes, exactly. I wanted to say that.
Yeah.
Yeah.
We need some exercise,
Oh,
and the banner which you see behind us, we
yeah.
thought that there is some reflection that also was discussed, and finally we thought that the arrangement made will serve the purpose. So
It looks as if it is opening offline, right? Yeah. It's nice.
That was the
Good
table.
morning. Very good morning.
Good morning, Dear Singh. Nice.
Good morning.
Very nice to see you after a long time.
Yeah, sir.
How are things? You're still in Karnal?
Yeah, I'm still in Karnal.
Nice.
So,
Very nice. Great.
but right now we have some
Good morning.
responsibility, even as
Okay.
a joint director research.
Good. Yeah. Some career advancement. That will be
Yeah,
nice
so-
to see you in
Dr. Basha, good morning. Chaturvedi
Good
here.
morning, Dr. Chaturvedi. How are things in AIMS?
Yeah, it's fine, sir. Fine. Okay.
Very
better.
nice. Very nice to see your face after a long time, perhaps.
Yeah.
Yeah.
yeah,
Thanks to Professor Lohia for giving this wonderful opportunity of seeing the faces of all friends, long time friends.
Yeah, the pre-session chatting is good, sir.
Yeah.
Once this meeting should be into the Tiruchirappalli, because this is Rameswar very close actually. I think that's
We should do that. We should do that. Why not? You can do
Yeah.
that. Yeah.
सर एक बार लोहिया सर एक बार देखिए उधर जो है ना ये भी साउथ उधर भी जानी
Really, we'll try it next year. No, there's no issue. I'll be so happy to do that. Yeah. I think
wonderful. In fact, in the afternoon, we would discuss about the venue for the next year,
yeah.
and all proposals are welcome, and it would be a good idea to have it in the south.
South, yeah. We'll find it either in Tiruchirappalli or any other place.
Tiruchirappalli
is also very nice
Not the
place.
host, definitely.
Very nice place actually.
Yes, it's a small city, and therefore
But I think everything is there and very
everything is
calm and
there.
quiet.
Everything is there. It's all facilities, all accommodation, good hotels, transport. Well,
Well connected, well
everything
connected.
is there. Yeah, Manivandan's native place.
Now it is well connected, sir.
Yeah, it is.
In all road.
Yes.
No, but we have a flight also.
Flight.
That's why I'm saying.
Flight from
It is
Hyderabad,
connected.
Bangalore,
It is
Delhi,
connected.
well connected.
Yeah, we had actually project in the Tiruchirappalli collaboration. So I like that place, very calm and quiet. And
Calm, yeah, that's more important. No traffic jam.
No
Very,
traffic
very
jam.
beautiful roads. Yeah. Climate also not bad.
We recall of meeting convened by Professor Pradeep and Dr. Malini,
Yeah.
and everybody greatly enjoyed.
Yeah.
So we still cherish the memories, and we wish that the next annual venue should be something like that, where the people after 2-3 years of virtual communications and meetings will meet personally and enjoy each other's greetings personally. And yesterday we were talking that there are many celebrations getting due. Like Professor Madan said yes, then Dr. Taru said yes, and like Dr. Dheer Singh said yes, because he also would like to give a treat.
Namaskar, Lohia Sahab.
Good morning, sir.
So nice.
Good morning, sir. Good morning.
Morning.
Very good morning.
डॉक्टर साहब का जैसे नाम आया वैसे डॉक्टर साहब का जो है वाइन
I think
10 minutes will come. 10 minutes will come.
Hyderabad next year. Hyderabad next year. And we will travel.
There. So nice to see Dr. Deepa.
Good morning, all of you.
Morning, sir.
Good morning, Dr. Deepa. After a long time.
How are you?
I'm fine. I didn't know that you have retired and joined other companies. I never feel that you are going to retire. It's so.
Yeah, now I've retired from NIRLH.
Oh, that's everyone has.
Morning, Dr.
Good
Good morning,
Good morning, everybody. Good morning.
Good morning.
Ranjit Singh.
Nakvi.
Morning, Dr.
Good morning.
Good morning, sir.
Good morning, sir, everybody.
Madan sir's son was with us in Bikaner, sir, for 1 year.
Okay.
Piyush. Where is he, sir?
Welcome, welcome.
Dr.
How are you,
Deepa,
Rahul?
Dr. Deepa,
Yes.
before you joining, I was complimenting Dr. Vikas.
Hmm.
I said that the newsletter is being greatly appreciated by everyone.
Yeah.
Great efforts put in by both of you.
Thank you, sir.
It is uploaded on
Print लेने के पहले थोड़ा minor changes हैं. Before we take the hard copy, na, we'll make those changes. But it has come out very nicely.
जो हार्ड कॉपी की आप बात कर रहे हैं, ये हार्ड कॉपी है.
Oh, बन गया already.
This is hard copy.
अच्छा, डॉक्टर अंसारी मेरे को बोल रहे थे हार्ड कॉपी अभी रेडी नहीं है.
नहीं, अभी आप अगर इसको देखें, because this exercise was done to see that it is properly released. So if you look into it and see yourself, you will see that it has come up so beautiful. Wherever it will go, it will be appreciated.
So is there now this? You have made all the copies, or still there are?
Initially for release, we don't have so far decided how to go about, because there are another second newsletter.
Yes.
This newsletter which we are talking about is HITA.
This is also very nice, very impressive.
Very nice. So both the newsletters we wanted that should be properly released, which has been done, and we will work out that if we have to go for print, maybe large number, about 2,000 prints we have to go for, and that we will work out economics of it, and it's that way utility. Otherwise, we plan to send the PDF of the newsletter to everyone. We are restarting, just for a minute. There is a technical.
Yes.
There is a technical issue.
Okay, sir.
We have about 3-4 minutes to go.
Good morning.
We'll start sharp at 10 o'clock.
Okay.
ऐसे करते करते दिन बीत जाते हैं. मैंने फिर विन्नी को ही बुला लिया. विन्नी को ही बुला ली. जैसा करती हूँ.
Am I audible?
Yes, sir.
Yes, sir. Yes, sir.
Am I audible? This is just a.
Yes, yes, you are.
Because there was some technical issue, so we were just trying to resolve it.
Audible, sir.
That is perfect. ठीक है. 10 बजने में 1-2 मिनट और. हाँ, ये that you can say, certainly. इसको म्यूट करो.
We'll be starting in 2 minutes, like shortly. Thank you.
Good morning, Dr. Lohiya, Dr. Dheer Singh.
Sir, very good morning, sir. Good morning, sir.
Welcome, Kambo sir.
Good morning.
Good morning.
Good morning, Dr. Ansari. Good morning.
Good morning, sir.
Good morning.
Good morning, sir.
Good morning. Good morning, sir.
Good morning. Gitanjali, you didn't join yesterday?
Sir, I was there for short time.
Okay.
I was attending it. How are you, sir?
Fine.
मुदगल सर, ये फोटो बहुत अच्छा लग रहा है पीछे आपके जो लग रहा है.
अच्छा.
Very nice photograph. It keeps you young. नमस्कार धीर सिंह जी.
Yeah, good morning. Good morning.
Should I start?
Yeah. हो गया? 10 बज गए? Yes. Sure. Sure.
So a very good morning to all of you on the from ISSRF. Just a second, sir. Okay. So a very good morning to all of you on the from ISSRF team. We welcome you to the second day of this exciting conference, which is on reproductive healthcare and 32nd annual meeting of the Indian Society for the Study of Reproduction and Fertility, organized by ISSRF, Department of Zoology, University of Rajasthan, Jaipur. I hope everyone had a good sleep, as we had a long day yesterday. So we'll start with our first oration, which is oration 4, Professor N.R. Mudgal Memorial Oration. And for this session, we have our chairpersons, Dr. Dheer Singh, who is the Joint Director, ICAR, National Dairy Research Institute, Karnal, NDRI, Karnal. And Dr. Dheer gave an excellent talk yesterday. So welcome, sir. And the other chairperson is Dr. Gitanjali Sachdev, who is Director and Scientist G, ICMR, National Institute for Research in Reproductive and Child Health. Dr. Gitanjali's interest is on mechanism contributing to endometrial receptivity, early pregnancy, implantation failures, and endometriosis. So I welcome you, ma'am, and we request the chairpersons to please continue this session. Thank you, sir, and thank you, ma'am.
Thank you very much. Thank you. So good morning to everyone. And the most respectable, the President ISRF, Professor N.K. Lohiya, the Professor B.P. Kambo sir, Dr. M.L. Madan, and all the distinguished participants, fellow, and society members of this ISSRF. So once again, very good morning, and it is our pleasure to be announced the first 2 days N.R. Mudgal oration. I think as far as the N.R. Mudgal sir is concerned, he has a very distinguished, actually, the professor in reproduction. Let me share it here, because sometimes the practical application is, of course, very important, but the basic science is also important, and sometimes new area. And it is to recall all of us that Professor N.R. Mudgal, the significant contribution reproduction is well established. One thing I would like to remind all our distinguished the ISSRF member, that he is the one who is the first, actually, in India started that hormone interaction with the immune, means the hormone is produced the immune response. Today we know that not only hormone, but all the immune response and immune biology is going to be interacted with this immune response. Because like today, there is a TLR receptor, which earlier we know that they are going to be work in terms of only for immunity. But today we know there is a lot of actually hormone and the hormone molecular ingredient. They also interact with this actually TLR receptor and regulate hormone. So hormone and immunity is well established and very early by Professor Narman Mudgal. And that's an area of research. Hormone interaction with and produce the immune response is worldwide recognized by professor. So I think it is I would once again appreciate, that ISSRF recognizing his work and started the oration. It is my pleasure that I have also actually happened to get an arm of the oration back in 2020. And I feel proud to be because they have started into the basic research. Sometimes the basic research is also very important and the open new area to in different angle. So with this I once again thanks organizers to give me opportunity to be chair this and our very prestigious oration, the lecture. And this oration lecture, I think Professor Lohiya has already shared, that is going to be selected by this very highly competitive, because this is very prestigious oration. And there is a lot of application and there is very senior people committee is made, and that's selected Professor Dr. Rahul Gadjah. So I congratulate Dr. Rahul Gadjah for getting this very prestigious oration award. Now I request our co-chairperson, Dr. Gitanjali, to share the brief and this resume of Dr. Rahul Gadjah.
Okay,
Gitanjali, please.
Okay. Thank you, Dr. Deep Singh. Before I introduce the speaker for today's very prestigious Professor N.R. Moudgal Oration Award, I would just say that I'm doubly pleased. The first reason I'm pleased is because it's always a pleasure to be associated with ISSRF meetings in any capacity. So I would like to thank Professor Lohiya sir, Dr. Ansari and ISSRF organizing team for inviting me to co-chair this session with Dr. Deep Singh. Another reason why I'm especially pleased is that the orator for today's oration, Dr. Rahul Gadjah, comes from National Institute for Research in Reproductive and Child Health. He is a colleague, collaborator, and very bright scientist from our institute. And in recent years, he has contributed immensely to the field of women's health, besides addressing other areas like tribal health and male infertility. So Dr. Rahul Gadjah is currently a scientist and also a principal investigator of PRECOV registry that was established 2 years back at the institute. And this registry is very, very important in the sense that the inferences which we drew from this registry or still drawing from this registry is the very basis of vaccination in pregnant women in India. Like his work was kind of provided impetus to this decision on vaccination in pregnant women. Besides these achievements, he is also a recipient of DBT Wellcome Trust Alliance Clinical and Public Health Intermediate Fellowship. He also availed this INSA Fellowship to get trained at Australia, and he's also a fellow from Frontiers in Reproduction course. And he's also a grantee of Indian patent from his work on endometriosis. And currently, as I was talking about this registry, he has collected data in association with other collaborators from stakeholder from 8,000 pregnant and postpartum women with COVID-19. And he has more than 75 publications to his credit and 20 in last 1 year. So I congratulate Rahul for your wonderful work in recent years. And now the floor is all yours.
So can you see my slides?
Yes, Dr. Rahul.
So thank you, Dr. Gitanjali Madam and Dr. Deep Singh Sir for the kind words. Respected Professor N.K. Lohiya, the organizing secretaries of the ISSRF conference, respected dignitaries and the delegates who have joined this conference online, a very good morning to you all. And it's truly an honor to deliver the prestigious Oration Award in the name of Professor N.R. Moudgal, And today I'm going to talk on the impact of the COVID-19 on the pregnant women and their newborns. And I will share the experience which have generated from the pre-COVID registry. So we know that COVID-19 pandemic is one of the worst pandemic which is witnessed by the mankind. And in the past 2 years, the entire world is fighting with the public health emergency of COVID-19, and India seems to be one of the worst hit countries contributing to nearly 5 lakhs deaths. And this is the data which is obtained from the John Hopkins site till today morning. And from the first case of the COVID-19 was detected on 30th January 2020 from Kerala. And since then, there have been a constant rise of the COVID-19 cases in the country. And these are the different timelines of the first wave, second wave, and the third wave. And these are the interventions provided by the government to mitigate these virus in the country. So when we looked at why the pregnant women are at increased risk of COVID-19, we looked at the literature, available literature. So the earlier the pandemics of the influenza and the Ebola, they suggested that the pregnant women are at increased risk of developing the viral infections and the serious complications. We also know that the maternal immune system constantly adapts and changes at different stages of the pregnancy. And we also know that during the pregnancy, there is a high estrogen and progesterone, which leads to edema of the upper respiratory tract, which makes these pregnant women susceptible for the SARS-CoV-2 infection. Also, as the pregnancy advances, there is a restricted lung expansion, especially during the third trimester, which predisposes these women for the risk of SARS-CoV-2 infection. So these physiological changes in the respiratory system and the immune system predisposes these pregnant women for risk of COVID-19. During the early phase of the COVID-19 pandemic, there was very little information available. The data on the impact of COVID-19 on pregnancy was mainly from the China, and that too limited to the case series. So we decided to undertake a study for understanding the impact of COVID-19 on pregnant women in Indian context, and therefore NIRCH launched the pre-COVID registry in joint collaboration with the Medical Education and Drugs Department, Government of Maharashtra, and the BYL Nair Hospital of the Municipal Corporation of the Greater Mumbai. Since Maharashtra contributed to nearly 1/3 of the total COVID-19 burden in India, we decided to focus on the Maharashtra state, and these are the total 19 study sites of the pre-COVID registry, which are spread across the Maharashtra state. And these are the different timelines, what we see here of the pre-COVID registry. The government of Maharashtra issued the notification of the pre-COVID registry on 13th of April 2020, and we registered this study with the CTRI, and these are the ethics committee approvals obtained from all the study sites. So the objectives of the pre-COVID registry are to understand the socio-demographic, clinical presentations, the reproductive characteristics, the pregnancy and the fetal outcomes, and also understand the mother-to-child transmission of the SARS-CoV-2 in pregnant women. The electronic patient case record form was developed through a stringent consultative process of consulting several experts from different disciplines, and the electronic case record form captures the detailed information on several parameters from the mother as well as the newborn. And the data of the mother and the newborn is then entered into the online registry, online portal. We have a separate portal for the capturing the data from the mother and the neonate. And we follow the stringent quality control guidelines at 3 different levels. And currently we have more than 8,000 pregnant and postpartum women who are registered in this pre-COVID registry. And we all know that ICMR has been on the forefront of giving technical support during this public health emergency of COVID-19. The first testing strategy for pregnant women was given by ICMR on 20th April 2020, and which suggested the universal screening of the pregnant women. So we wanted to see what is the impact of these ICMR testing guidelines on the pregnant women in Maharashtra state. So we collected the data from 15 participating hospitals of the pre-COVID registry in Maharashtra. And out of the 1,140 pregnant women who were screened by this screening strategy, 12% of the women, they were detected with the SARS-CoV-2. And out of these, majority of the women, that is 88.5% of the women, were asymptomatic, and only 11.5% of the women were symptomatic, suggesting that there is presence of one symptomatic woman to every 9 asymptomatic women in the community. And since these asymptomatic women were identified and they were isolated, and this screening strategy was useful for not only protecting the newborns and the other patients, but also useful for protecting the healthcare workers and limiting the spread of the infection to the community. We then looked at the co-infection of the malaria and dengue in our cohort, and in the early phase of the pandemic, we reported 3 cases of pregnant women who were infected with the SARS-CoV-2, as well as they were infected with the Plasmodium vivax, and 1 patient with the dengue. And this patient number 2, she had IUFD, and there was retained product of conception. So what we observed that there is an overlap of the clinical presentation of malaria, dengue with COVID-19, which pose several challenges in the diagnosis of these cases. The misdiagnosis could also be life-threatening to mother as well as fetus, as we see here in this patient number 2. This women had undergone IUFD, and if the diagnosis of malaria was done at an earlier stage, this adverse outcome could have been prevented. And therefore, we suggested that the physicians, the obstetricians need to be vigilant for early detection of the co-infections, especially in the areas where the malaria and dengue are endemic. Another important co-infection we studied was the tuberculosis. And as we all know that the COVID-19 and tuberculosis, they both involve the lungs, they share the common risk factors, and they also present in a similar way. So we looked at the cohort of the pregnant and postpartum women from the Bovine hospital from April to September 2020, and we found that there were 6 concurrent pulmonary tuberculosis cases with COVID-19, and there were 12 cases of past history of tuberculosis with COVID-19. Majority of the women with pulmonary tuberculosis and the COVID-19 were symptomatic, and the oxygen saturation on admission was low in the active PTB and the COVID-19 group. 2 women with active pulmonary tuberculosis with COVID-19, they developed ARDS and they required the ICU admission. 1 patient with extensively drug-resistant tuberculosis, she died due to the complication of the COVID-19. So based on this study, we suggested that the pregnant women with symptomatic COVID-19 need to be tested for tuberculosis, especially in the countries with high burden of tuberculosis. Right from the beginning of the pandemic, we observed that the pregnant women with COVID-19, they had anxiety and they were under severe stress. So we looked at the mental health impact in our study cohort, and we reported 3 cases of the postpartum psychosis during the early phase of the pandemic. All these 3 patients were asymptomatic for COVID-19, and they developed the postpartum psychosis within the 7 days of delivery, and the diagnosis of postpartum psychosis was based on the presence of the psychotic symptoms in absence of any organic or the mood disorders. All these women, they were treated with haloperidol and olanzapine, and they recovered well. This was the first case series from on the postpartum psychosis, and we reported this case series in the Asian Journal of Psychiatry. Another unusual case we came across was the altered mental status with delirium in a 30 weeks pregnant woman. She had no other symptoms of COVID-19. Her agitation started 14 hours after the admission, and she delivered vaginally 6 hours after the first episode of agitation. It was very challenging to manage this patient, especially wearing the PPE kits, and the diagnosis of delirium was secondary to the obstetric comorbidities. She recovered fully and then discharged after a month of admission. And this was the first documented case of delirium in pregnant women with COVID-19. And now the delirium has been included as one of the presenting symptoms of COVID-19. So based on our experience, we recommend that there should be training of the healthcare workers, especially for the early recognition and appropriate treatment of the psychiatric emergencies in pregnancy. We then looked at the impact of COVID-19 on the multiple gestation pregnancy. So we compared the data of 859 singleton pregnancies with the multiple gestation pregnancies from the cohort recruited at the Bovine hospital. And it was observed that nearly 55% of the multiple gestation pregnancies were conceived by ART conception. And we found that the pregnant women with multiple gestation pregnancy, they were at increased risk of spontaneous abortions, preterm delivery, and the preterm labor, suggesting that the multiple gestation pregnancy with COVID-19, they need a special attention with a multidisciplinary approach. We also looked at the impact of COVID-19 on pregnant women with heart disease, and we found that there is an adverse outcome in pregnant women with COVID-19 who have the heart disease of rheumatic heart disease or the peripartum cardiomyopathy. And therefore, we recommended that the healthcare system need to be strengthened for the management of both the heart disease as well as the COVID-19. In our study cohort, we also came across a case of Guillain-Barre syndrome, and this was the first case reported in the literature in a pregnant woman with COVID-19. She was 31 years old with 12 weeks of gestation age, and she had a comorbidities of the rheumatoid arthritis, systemic lupus erythematosus, and the antiphospholipid syndrome. The diagnosis of Guillain-Barre syndrome, which was like acute inflammatory demyelinating polyneuropathy, which is one of the variant of the GB syndrome. She received the IVIG therapy and recovered. But unfortunately, she aborted spontaneously within the 10 days of developing the weakness, and we reported this case report and the case series in the European Journal of Obstetrics and Gynecology. We know that the central India is also considered as the sickle cell belt of India, and some of the study sites from the pre-COVID registry, especially from the Vidarbha, there is an increased incidence of the sickle cell disease. So we wanted to see what is the impact of the sickle cell, impact of the COVID-19 on the pregnant women with sickle cell disease. So we compared the data of women with sickle cell disease versus non-sickle cell disease, which was recruited from the same study sites during the same study period. And we observed that the pregnant women who had sickle cell disease and the COVID-19, they were 2 times at increased risk of symptomatic presentation as compared to the non-sickle cell disease. And the gestational hypertension, IUGR, blood transfusion, and the non-invasive mechanical ventilation were significantly higher in women with sickle cell disease as compared to the non-sickle cell disease. The maternal death was also higher in the sickle cell disease group, suggesting that there is an increased risk of pregnancy complications and the adverse outcomes in pregnant women with sickle cell disease as compared to the non-sickle cell disease group. We then looked at the impact of the first wave on the pregnant women in Maharashtra state. So we analyzed the data from all the 19 study sites with a sample size of 4,203, and majority of the data was contributed by the BYLNR hospital. We are representing the population from the Mumbai metropolitan region. Nearly 40% of the cases were from the MMR region, followed by the Vidarbha, Pune, Marathwada, and Khandesh. And this is this is what the data suggested from the first wave. The cases of pregnant women with COVID-19 started rising from April, and it reached the peak in the month of September 2020. And after that, the cases started declining. So we compared the data of first wave, and we observed that the 92% of the pregnant women from our cohort were infected during the 3rd trimester. We looked at the clinical presentation of the pregnant women with COVID-19, and we found that 13% of the women were symptomatic. Majority of them had a mild disease, 21% had moderate disease, and 7.5% women has a severe disease. The fever and the dry cough were the most common presenting symptom in our study cohort, and these are the other symptoms which are reported in the pregnant women with SARS-CoV-2. When we looked at the pregnancy complications, the preterm delivery was the most common pregnancy complication, followed by the hypertensive disorders of pregnancy, and these are the other pregnancy complications reported in our study cohort. So we wanted to understand what are the risk factors for developing the severe COVID-19 disease. So we analyzed the data of severe cases with the moderate to severe, mild to moderate cases, and we observed that the pregnant women who were more than 30 years of age were 2 times at increased risk of developing the severe disease as compared to the mild to moderate group. And the hypertensive disorders of pregnancy, the shortness of breath, diarrhea, tuberculosis, anemia were significantly associated with the severe COVID-19 disease as a risk factor. So to summarize the impact of the first wave of COVID-19 on pregnant women, majority of the women in our cohort recruited during the first wave were asymptomatic. There was a pregnancy loss or stillbirth in 6% of the women. The hypertensive disorders were reported to 10.1%, and 3.8% of the women, they required the HDU or the ICU admissions, and majority of them required the ICU admissions due to the COVID-19 complications. Only 4% of the women who required HDU or ICU admissions were due to the obstetric reasons. The case fatality rate was 0.8%, and there was a regional variation in the case fatality rate. The CFR was higher in the Pune and Marathwada region as compared to the Vidarbha and the Mumbai metropolitan region. So this was the largest cohort on the impact of COVID-19 during the first wave, which suggested that a large proportion of pregnant women can be infected, and if they are symptomatic, they have a higher risk of developing the mild to moderate or a severe disease, and therefore they require the urgent attention. We then looked at the impact of the COVID-19 on the newborns. So we analyzed the data of 524 neonates born to 514 SARS-CoV-2 infected mothers admitted at the BYL Hospital, which is a dedicated COVID-19 hospital. And these are the testing guidelines we followed. And out of the 523 neonates who were tested by RT-PCR, 33 neonates were infected with SARS-CoV-2, and out of that, 9 required the NICU admissions, and 3 died. Among the 490 SARS-CoV-2 non-infected newborns, 124 required the NICU admission, and 10 neonates died. So the risk of death in the infected newborns group was 4 times higher than the non-infected group. We then looked at the complications of neonates born to mothers with COVID-19, and we compared the SARS-CoV-2 infected neonates with the non-infected neonates, and we found that the sepsis, poor feeding, and the respiratory distress were significantly higher in SARS-CoV-2 infected neonates. So to summarize the impact of COVID-19 on the newborns, we detected the SARS-CoV-2 infection in 6.3% of the newborns of the mothers with COVID-19. The risk of sepsis was 4 times higher. The poor feeding was significantly higher in the SARS-CoV-2 infected neonates, and there was a risk of neonatal death in SARS-CoV-2 infected newborn. So the study demonstrated that there is a higher risk of adverse outcomes in neonates born to mothers with COVID-19, and this study has been published in Journal of Tropical Pediatrics, which has been recently included in the public health headlines of the Oxford University Press. During the early phase of the pandemic, there was very little information available on the placental transmission. And so we conducted this study in collaboration with the ESS hospital. My colleague, Dr. Deepak Modi, he conducted the experimental work of the study. And this patient was detected with SARS-CoV-2 at 8 weeks of gestation, and she was asymptomatic. On 13 weeks of gestation, her transabdominal ultrasound showed extensive subcutaneous edema and the pleural effusion, and there was absence of cardiac activity, suggesting that the features of hydrospitalis and the fetal demise. Dr. Deepak then carried out the experimental work, and he showed that the SARS-CoV-2 is was present in the placenta, amniotic fluid, and the fetal memory samples. And this is what we see here, the S1 and S2 localization in the placental villi of the first trimester placenta. So this is the evidence on placental infection in the women with COVID-19. And this study and this case report has been published in the Human Reproduction. We then looked at the impact of the second wave, and we know that during the December 2020 and early January 2020, the cases of SARS-CoV-2 were declined, and we thought that the the COVID-19 pandemic is over in the country. But suddenly there was a rise in the cases, especially from the Vidarbha, and this SARS-CoV-2 variant of concern, Delta variant, was responsible for the rise during the second wave of the COVID-19 pandemic. So during the second wave, the cases started rising from the March 2021, which reached to the peak in the month of April, and then the cases started declining. So we compared the data of first wave of 1,143 pregnant and postpartum women who were admitted at the Bovine hospital, and from the same hospital we compared the data during the second wave, and the admission policy of the pregnant and postpartum women during both the waves was uniform, and this comparison was carried out, and what we observed that the severe COVID-19 cases were 5 times higher during the second wave, and there was also 5 times increase in the ICU and the HDU admissions during the second wave of the COVID-19 as compared to the first wave. When we looked at the case fatality rate, the maternal mortality was 8 times higher during the second wave as compared to the first wave. And when we looked at the comorbidities and the pregnancy complications, the anemia and the gestational hypertension was significantly higher during the second wave as compared to the first wave. So the study demonstrated that there are higher rates of severe COVID-19 disease, increased incidence of HDU and the SU admissions, and there is a higher risk of maternal mortality during the second wave. So these findings suggested the importance of vaccination of pregnant women. Although during the time of publication of this manuscript, the pregnant women in India were not eligible for vaccination of COVID-19. So this landmark paper we published in the Green Journal. We then looked at the comparison of the stillbirth rates during the first wave and the second wave, and we observed that the stillbirth rates were 2 times higher during the second wave as compared to the first wave, and the symptomatic COVID-19 patients were also significantly higher during the second wave as compared to the first wave. So based on this data, we suggested that the pregnant women, they need to be counseled about the risk of SARS-CoV-2 infection during the pregnancy. We also looked at the spontaneous preterm births during the second wave, and we compared this data with the first wave and the pre-pandemic period of 1 year. And what we observed that the preterm deliveries were higher during the second wave as compared to the first wave, and the spontaneous preterm births were significantly higher during the second wave as compared to the first wave, and also the spontaneous preterm births were higher as compared to the 3 years of pre-pandemic data from the Nayas hospital. And we observed that there was unusual change in the spontaneous preterm births during the pandemic, during the second wave of the COVID-19. We then looked at the miscarriage rates during the second wave of the COVID-19, and we compared this data with the first wave and the pre-pandemic period. And what we observed that the miscarriage rate per 1,000 births as well as the miscarriage rate per 1,000 admissions was significantly higher during the second wave as compared to the first wave. We also looked at the intrauterine fetal demise during the first and second trimester, and the IUFD during the first and second trimester were higher during the pandemic period as compared to the pre-pandemic period. So the data suggested that the risk of miscarriage during the second wave is 3 times higher than the first wave, and also it is 2 times higher than the pre-pandemic period. And this important observation has been published in the Ultrasound in Obstetrics and Gynecology, which is now the part of this policy document on management in obstetrics and gynecological settings, which is published by the White Journal. So this is the summary of the impact of second wave of COVID-19 on pregnant women. We observe the severe COVID-19 disease increased during the second wave of pandemic. There was 5 times increased risk of HCU and HDU and ICU admissions. The maternal deaths were 8 times increased during the second wave. The stillbirth rates, spontaneous abortion rate, very spontaneous preterm birth rates, and the early onset preeclampsia were also higher during the second wave of the COVID-19 pandemic. And now the COVID-19 has been established as a risk factor for preeclampsia. So after publishing these data on first wave and the second wave, several national and the international agencies they approach us, and this data was shared with them, and the publications we shared with them. So that's how the ICMR also recognized our contributions and included this pre-COVID registry on the COVID-19 timelines. And we were also instructed by the Director General ICMR to submit a detailed report on the observations and the publications from the pre-COVID registry. Subsequently, we were also asked to submit the evidence on the impact of the second wave of COVID-19 for the review by the chairman NTAGI. And finally, the Ministry of Health and Family Welfare accepted the recommendations of the NTAGI, and that's how the pregnant women in our country became eligible for the vaccination of COVID-19. So we are very happy and satisfied that the efforts of our pre-COVID registry for the past 2 years have been useful for facilitating the policy decision on pregnant women with COVID-19 in the country. So it was very essential to document the observations from the pre-COVID registry as it is a public health emergency, so that these observations will be useful for the clinical management and also to the policymakers. So we published several important observations from the pre-COVID registry. I have listed out all these publications here, and you can visit the website, pre-COVID registry website, for the updated publications. So this pre-COVID registry not only gave us an opportunity to contribute or influence the policy, but also helped us in providing the mentoring support to the medical colleges. We provided the guidance to the interns, resident doctors, faculties in 19 medical colleges in Maharashtra state, which is one of the mandate of the ICMR. And several national and the international media also disseminated our research findings in the print and electronic media, which helped the general population to know about the updated information on impact of COVID-19 on pregnant women. And so finally, I would like to thank the Director General ICMR and the team from ICMR for providing the guidance and support. It was extremely challenging to implement this pre-COVID registry during this pandemic period, and I must thank Dr. Smita Mahale's mentoring support and for this registry. And the same support is being continued by the present leadership, Dr. Gitanjali Sachdeva. I would also like to thank Dr. Gitanjali Sachdeva for the continuous support and guidance to the pre-COVID registry, so that we take it ahead and generate the data which is useful for the clinical importance as well as to the policy makers. And I thank the contribution of my colleagues, Dr. Deepak Modi and the Suchitra Survey, and other colleagues from the Institute for the implementation of the pre-COVID registry. This is the team from the COVID registry, and we received the support from the Secretary, Medical Education and Drugs Department, Government of Maharashtra. Dr. Rakesh Wagmare is the principal investigator from the Medical Education and Drugs Department. Dr. Neeraj Mahajan is the PI from the BYL Nayar Hospital. Dr. Neeraj not only contributed in implementing the registry, but also provided the clinical support to more than 1,700 pregnant women with COVID-19. And we thank the BYL Nayar Hospital team, Dr. Joshi, former Dean, BYL Nayar Hospital, Dr. Bharmal, the current Dean of Nayar Hospital, and Sushma Malik, the head of the Department of the Pediatrics. We also acknowledge the efforts of Dr. Padmaja Keskar and Mangala Gumare from the Executive Health Officer from the BMC. And I must acknowledge the efforts of all the interns, the resident doctors, the faculties, the head of the departments of the OBGYN and the pediatrics from all the 18 government medical colleges of Medical Education and Drugs Department, Government of Maharashtra, and the BYL Nayar Hospital, Mumbai, for providing support to the pre-COVID registry. Without their support, it would have been impossible to conduct this study. And finally, I thank all the study participants of the pre-COVID registry. And I once again thank ISSRF for providing me this opportunity. And thank you very much for your kind attention. Thank you.
Thank you very much, Dr. Rahul. I think it is a well evident, and let me congratulate you on behalf of ISSRF, on behalf of myself and all the fraternity of ISSRF, to congratulate you for the very excellent work. And particularly your work is very much evident that how important for not for actually our research purpose, but also the immediate need of this COVID pandemic to the policymaker to frame the guidelines, and that's you have very excellently. And I would also like to be thanks ISSRF for choosing a very excellent and I think could be real dedication to the oration lecture of N.R. Mudgal. With once again, thank you very much, Dr. Rahul, and really appreciate on behalf of all that you have a very excellent work. I think all must be evident and must be agree with me that it is a really, really very excellent work and talk for on NR oration lecture. Thank you very much.
Thank you.
So
Sir.
with this, I also thanks on my behalf ISSRF for giving me this opportunity to be, and I would request if you have any, the organizer, if any have a presentation of award to the professor, to Dr. Rahul. So any ceremony presentation for the award, this ISSRF organizers, I would request if you have, or I would request Dr. Gitanjali.
I think with the award plaque and the medal and all that being formally sent to the awardee, and we planned this way that we can project this on the slide to let every person who is participating could see that this is first time being done. When we see on the plaque the person, the scientist in whose name this award being instituted also is reflecting along with the recipient. So that is a thing where the this is, if it is being made available to the awardee, it will be lifelong memories of the person in whose name the award is being instituted, and for him to realize that how important was the event for which he was selected by the ISSRF. So compliment to Dr. Rahul.
Congratulations.
Thank you, sir. Thank you very much.
And IRRCH for this honor. Thank you so much.
Thank you, sir. Thank you. Thank you very much. Now I would request Dr. Gitanjali to close the session of this.
So I would just echo what Dr. D Singh and Dr. Lohia said. So Dr. Rahul, you richly deserve this very prestigious oration. So congratulations once again, and I thank all participants for their attention, and thank you all. And with this, we can sign off.
Thank you.
Thank you. Thank you, sir. Thank you.
So I thank our chairpersons for chairing this session, and many congratulations, Dr. Rahul, for this prestigious award. Now we move ahead with our first session, which is session 5 on male reproduction. And the chairpersons for this session are Dr. Pradeep K. Chaturvedi, who is a professor at Department of Reproductive Biology, All India Institute of Medical Sciences, New Delhi. And his research interests are on male infertility, prostate cancer, EMF, radiation on male infertility. Welcome, sir. And the other chairperson for this session is Dr. M. Michael Aruldas, who is at University of Madras, Chennai. And his research interests are on thyroidology and reproductive endocrinology. I welcome both the chairpersons, and I would request both of them to chair this session. Thank you, sir. Over to you. I think Dr. Ajit Saxena is not available today, so we will skip to the next lecture. Thank you.
Okay, I thank ISSRF, Dr. Lohia, Dr. R. Sharma for giving me this opportunity to chair this excellent session. And I will introduce our first speaker, Dr. Reema Das, who is professor in anatomy, AIMS, New Delhi.
Dr. Pradeep.
Yeah. Can you hear me?
वो unmute नहीं किया हुआ.
Hello.
Unmute है.
Am I audible? Hello. Hello.
Yes, sir. You are audible, sir. You are audible.
Okay, great. So I thanks ISSRF, Dr. Lohia, Dr. Sharma for giving me this opportunity to chair this session. And first speaker of this session is Dr. Reema Dada, Professor of Anatomy, AIMS, New Delhi. And she has an interest in genetic of reproduction disorders, ocular disorders, and various childhood cancers. She has won various awards in national conferences, ICMR Shakuntala Amitchand Award, GP Talwar Gold Medal, Rashtriya Gaurav Award, and International Award for her work on genetic aspect of the infertility. She had publication, 65 publication, both national and international journals, and has over 15 chapters in the books and 12 chapters in DBT NMS workshop manual. So I asked Dr. Rima to present her work, and 20 minutes is presentation time, 15 minutes you present and 5 minutes we will have a discussion on that part.
Okay.
Go ahead.
They have to allow sharing of the slides. It's disabled.
We are doing that, ma'am. Just 1 second. Yeah.
Can you see my slides?
Can see your slide, but it's not in the presentation mode.
Actually, here it is on presentation mode. Now is it okay?
No,
No.
it is still in that.
Actually, no, but I have made it presentation mode.
You can close it, Dr. Rima, and then put it on again. So
just 1 minute. Can you see it now?
Now, yeah, but it's still in the.
Yeah, yes, visible.
Okay.
But not in presentation mode. Anyway, go ahead. And
Acha, in my screen set is showing presentation mode.
No,
Maybe
no,
it is
no.
a little slow. Okay, I
go
think
ahead,
it is
go
a
ahead,
little
Rima.
slow.
Go ahead, Rima.
I think there is some problem here. Just one.
Yeah, it is visible, madam.
रीमा आप करो, शुरू करो, नहीं लेट होगा. Dr. Rima.
Slides?
Yeah, go ahead, Rima.
Okay, so I would be talking on what is the role of paternal factors in embryonic development. Though it is usually believed that sperm's function ends at fertilization, but it's important to understand that the role of the sperm extends beyond fertilization, and they're important determinants of embryonic viability and developmental competence. And this has led to the new concept about the paternal origin of health and disease, and how that there is a preconceptional origin of diseases due to the exposures and lifestyle of the father. And in this talk, I would also show you that how social habits, diet experiences can impact the sperm. And this is the only cell in the body which is not able to clear the damage that it ensues. And therefore, it modulates the epigenome, the unhealthy social habits and the lifestyle, and how yoga, a mind-body intervention, is very important in dealing with all the various factors which result in recurrent implantation failures, recurrent pregnancy losses. It could be early, pre, post implantation losses, as well as recurrent spontaneous abortions and congenital malformations. Though it is believed that after fertilization, all the factors that are actually resulting in there's some problem.
The slides are not moving.
So I think I'll do it in this mode, then it will be a little faster. Just 1 minute.
Yeah, go ahead, but this, yeah, okay, go ahead.
Okay. So initially it was believed that there were the mutations in the sperm and the oocyte which actually resulted in your disease and health state. But now it's known that there is something operating above the genetic landscape, which is actually determining your phenotype, the health and disease states, and the embryonic development, which led to the concept of developmental origin of health and disease. And it was actually believed that it was the maternal exposures which occurred in utero, exposure to environmental chemicals, toxins, fever, drugs, use of drugs, nutrition nutritional status, as well as psychological stress and depression, which impacted the development of the embryo and the fetus. And there was also poor outcome when there was early exposure, which led to congenital abnormalities, obesity. But recently, there has been a concept that rather than just the maternal factors, because the oocyte is able to clear majority of the exposure damage that occurs, it's the paternal factors which are actually resulting in health and disease, and which has actually led to the concept that biological parenting begins much before conception. It actually begins when parents themselves are conceived. And this has led to the phenomena that of the preconceptional origin of disease, that through the totality of paternal exposures, it is now believed that because the sperm undergoes various changes, various exposures, for example, unhealthy lifestyle due to smoking, alcohol, or a high-fat diet, these damages are not cleared by the sperm post-spermiogenesis. So there are different studies which have shown of epigenetics and the origin of paternal effects. There is a link between the father's lifestyle, and the link is by the epigenome, which connects the nature and the nurture, and the key factors by where all the factors which are impacting the sperm DNA are culminating is oxidative stress. Also, it has been shown that any experience that the father has, the diet of the father, the lifestyle of the father, impacts the offspring's future health. And there are periods of epigenetic susceptibility. So there are studies which have shown that there are various periods in which the sperm is highly vulnerable. That is, firstly, during the migration of the germ cells from the wall of the yolk sac to the genital ridge, just at the time puberty, when spermatogenesis begins, at the time of meiosis, as well as post-fertilization, when there is erasure just after fertilization, and then re-establishment of the epigenetic marks. Now, there is this very famous study which is on the impact of the environment, the TIGA study, the impact of the environment on the gamete epigenetic reprogramming, which tells that a father's unhealthy diet can actually reprogram the epigenome and result in chronic diseases in the offspring. So at the time of fertilization, the sperm does not transmit the DNA. It transmits a huge number of other factors, the oocyte activation factor, the centriole, and a large number of transcripts. So though the sperm is transcriptionally and translationally silent, but certain genes of developmental importance are transcribed, and these are long-lived mRNA, these transcripts, and they are transmitted at the time of fertilization and play key roles in early embryonic development. In addition to that, it also transmits microRNA, which play a regulatory role during early development. So the effects of the father are classified into the early paternal effects. These are the effects which occur prior to the the activation of the paternal genome. Late paternal effects, which are occurring after the activation of the paternal genome. And it's been seen that when there is high level of DNA damage, it actually delays the embryo kinetics. There is poor blastocyst morphology. There is developmental arrest resulting in pre-post implantation losses. There could be early pregnancy losses, increased mutation rates, and also impairment of embryonic development. If the impairment of embryonic development is extensive, it usually results in pregnancy losses. So when you look at the sperm, this is the only cell which is not able to clear the DNA damage, because majority of the DNA is packaged by protamines and therefore is transcriptionally and translationally inert. But some part of the DNA which is bound by histones remains active, and this is the part which contains the telomeres and also the promoters of genes of key developmental importance. Now, why this is important is because when there is oxidative insult and oxidative damage which is not cleared by the sperm DNA, because majority of the antioxidants are shed, the telomeres become shorter, and this can affect the rate of cleavage. And when there is dysregulated levels of various transcripts, which we have studied in different categories like recurrent pregnancy losses, recurrent implantation failure, as well as in cases of recurrent spontaneous abortions, we find that these levels of various transcripts are dysregulated. So our studies have shown that a huge number of preconceptional factors, exposures like firstly, like smoking, alcohol consumption, excessive use of cell phone, psychological stress. And as you delay the age of marriage and parenthood, for example, the age of parenthood has increased from 27.4 to 30.9. It actually culminates in oxidative stress, which is not cleared by the sperm. It damages both the mitochondrial and the nuclear DNA, resulting in shorter telomeres, accumulation of oxidative DNA adducts, and fragmentation of the nuclear and mitochondrial DNA. Now, when there is such extensive damage, only the oxidative DNA adducts are removed by the sperm. But when the damage is extensive, there are single and double strand breaks. It depends upon the oocyte to actually clear the damage. And studies have shown that as you delay the age of marriage and there is suboptimal repair capacity, and even when the damage is extensive, even with younger oocytes, it's been seen only about 40% of the sperm DNA damage is cleared. And this is actually responsible not only for infertility, but if these cases conceive, it results in recurrent spontaneous abortions, congenital malformations, childhood cancers, complex neuropsychiatric disorders, which have really increased in children like schizophrenia, childhood depression, as well as autism, as well as dominant genetic diseases. So this has led to the concept now that instead of the exposures just being, and the mother being held responsible for the impaired embryonic development, congenital malformations, and abnormalities of embryogenesis, these are basically the paternal exposures, which has led to the paternal origin of health and disease. This concept has now really caught hold because the sperm is not able to clear any of the abnormality, the insults that it faces. There are studies have shown that there is an increased risk of advanced paternal age on spontaneous abortions, and that oocyte can only have a limited repair capacity to repair the DNA damage when it is high. And various studies have shown that unhealthy lifestyle factors, high levels of DNA damage can result in not only recurrent spontaneous abortions, but even when these are used for assisted conception, they result in poor outcome. And they also delay the human embryokinetics and the blasturation and the euploid rates. Now, this is a landmark study which came out by Dr. Aitken, who showed that the oxidative damage, which is the chief cause of damage to the sperm. And these studies are very, very important because this actually showed that the damage is not random, that there are certain areas in the genome which get recurrently have oxidative damage. For example, chromosome 15, which is the chromosome which bears the genes for infertility, genes for neurodevelopment, as well as cancer. And also it has been seen because of oxidative stress, the methylation marks are altered and there is global hypomethylation, making the genome unstable. And so it has been seen that when these germ cells are being processed for ART and ICSI, when the seminal fluid is removed, they are more vulnerable to oxidative stress and damage, and thus they are more epigenetically labile. And studies have shown that children who are conceived by intracytoplasmic sperm injection have twice the high risk of major birth defects. So you can see that these studies have shown that DNA methylation patterns are altered, especially in children who are conceived through assisted conception. And studies have shown, there are numerous studies that smoking, obesity alters the microRNA profile. And in our studies, we have also seen that exposure to a large number of factors like smoking, alcohol, phthalates, endocrine disrupting chemicals not only impairs steroidogenesis as well as spermatogenesis, but it also results in oxidative stress. So large number of infertile men, couples encountering with abnormal embryonic development, congenital malformations, and recurrent spontaneous abortion, a large number of them are having seminal oxidative stress and have a large number of variations in the mitochondrial genome. For example, in the couples who had recurrent implantation failure, they had much higher neat and washed free radical levels, a lower total antioxidant capacity, and higher levels of DNA damage, which was significantly higher than that in the control populations. They had also high levels of DNA damage, which we quantified both by alkaline comet assay as well as by sperm chromatin structure assay. And you can see here that the number of dots, that are sperm with the damaged DNA, are the ones towards the x-axis, which is significantly higher than the number of sperm which are towards the y-axis, which are the ones with the good integrity. So we were able to have the cutoff levels established, and we found that when the DNA damage is above 30, these people are not able to conceive spontaneously. However, when the DNA fragmentation index is between 24 to 27, these couples encounter recurrent spontaneous abortions and congenital malformations. And these are cases in which the female partner is extensively worked out and there is no known cause female factor for these problems. Also, we found that optimal free radical levels are required for maintenance of optimal telomere length, which is very, very important for cleavage, optimal cleavage rate. So we also quantified the level of this adduct, which not only induces mutations and epimutations, and we found that in these people, smoking, alcohol consumption, and exposure to insecticides and pesticides are associated with this adduct, which induces both mutations and epimutations. When we did a microarray, we find that a large number of genes which are of key developmental importance are dysregulated in these categories of individuals with recurrent spontaneous abortions, with recurrent implantation failures due to abnormal embryonic development. And we showed that paternal factors and embryonic development play a key role, and they are responsible for in recurrent pregnancy losses, especially when there is dysregulated levels of sperm transcripts and high DNA damage. We also showed that high levels of this oxidative DNA adduct, not only is it important to actually know that there is DNA damage, but it's important to know what is the cause of DNA damage. And we've shown that high level of this oxidative DNA adduct actually results in de novo germline mutations and epimutations. And we found in children with cancers, we find that this level of this adduct was much higher in these children as compared to the control population. We also did this study in congenital malformations, where we found that there was high level of DNA damage as well as oxidative stress in people who had 3 or more children with congenital malformations. So this is just to show you that in this study with retinoblastoma, these fathers, these were cases with sporadic, where there was no family history. They had higher levels of seminal oxidative stress and DNA damage. And more importantly, it was found that these were usually the last born child when the age of the father was above 35. So when they tend to accumulate DNA damage. And there are studies which have shown that clearly the rates of abortion as well as autism increase when there is an advance in the increase in paternal age. So we also did this study on autism. I know this is a very busy slide, and in the presentation mode I'm not showing, but what we also showed here, that in cases where there are families where you have children with autism, we studied again the quality of the father's sperm DNA, and we also did this methylation study where we found that a large number of genes which are involved in synaptogenesis, developmental processes, sensory motor conduction, and inflammatory pathways were showing hypermethylation in cases with autism spectrum disorder. Now I'll tell you about the impact of yoga on the sperm genome and the epigenome. So in these studies, we found that there was a significant decline in the oxidative stress. There was an improvement in the total antioxidant capacity. You can see here that in the groups that did yoga and meditation, there was a significant increase in the total antioxidant capacity versus the group that did not do. In addition to that, there was a significant decline in the level of this oxidative DNA adduct, which induces both mutations and epimutations. And this is a very, very important finding. And this is the first study to show that this is that yoga causes this independent of intake of any antioxidants. And this can actually reduce the genetic and the epigenetic disease burden, and thus reduce the embryonic malformations which are occurring, which are resulting in abnormal congenital malformations and pregnancy losses. In addition to that, we studied the levels of various transcripts which were dysregulated, and we find that post-practice of yoga, you can see that the levels of these transcripts are getting normalized, but they need to practice yoga on a daily basis. In addition to that, when we studied the fold chain, the gene which is actually detecting the damage, we find there is an upregulation 3.4 fold axis change, and the MTHFR gene, which is helping in maintaining these methylation mark by its donating the methyl molecule, we find it shows an upregulation, a 5-fold upregulation. In addition to that, when we studied the global DNA methylation, we find that post-practice of yoga, as the oxidative stress levels come down, the methylation marks are re-established. And this is very important because global hypomethylation actually results in genome instability and hypermutability, because it exposes these repetitive elements, as I showed you in a slide, which showed that there is unmasking of the repetitive elements like the long interspersed nuclear elements. And in addition to that, the hydroxymethylcytosine levels, which occur due to the oxidation of the methylcytosine, they actually go down post practice of yoga. In addition to that, this was the first study to show that if you practice yoga, you can also normalize the epigenetic marks, and various genes which are helping in embryo implantation, which are helping in chromatin compaction, transcriptional silencing of certain genes, which are helping to maintain the integrity of the microfibrils, which are helping in cell migration, which are having a protective activity on the telomeres, they are hypomethylated, means there is overexpression in certain genes which are causing enhanced apoptosis of the germ cells, which are resulting in inflammatory pathway activation, show hypermethylation, so they are silenced. And this correlates with the levels of oxidative stress as well as DNA damage. In addition to that, to understand how is yoga actually decreasing the oxidative stress other than by upregulating the genes which are coding for the antioxidants, we find that yoga is actually improving the mitochondrial integrity. And this is the first study to show that yoga improves the mitochondrial integrity. And this study was just completed last year, where we showed that there is an improvement in the mitochondrial membrane potential from 53.9 to 89. And we also find this is possible because a large number of genes which are maintaining the mitochondrial integrity, promoting mitochondrial biogenesis, actually increases, and the mitochondrial copy number increases. And in addition to that, we also find that the NAD levels, which are maintaining the nuclear and DNA crosstalk, show an upregulation. Initially, when we began this study, we began it on infertile individuals with rheumatoid arthritis, and then this was carried forward in cases with autoimmune arthritis, in which there's oxidative stress plays a major role. So we also find that the DNA damage post-practice of yoga shows a significant decline, but for that we need to practice yoga for at least 6 months for 2 spermatogenic cycles. And this was important because oxidative stress goes down in 10 days, but 2 spermatogenic cycles mean about 180 days are required to show a significant improvement in the DNA integrity. And this is very, very important because this will actually result in lowering the rate of de novo mutations as well as genetic and epigenetic diseases in the offspring. So I would just like to end by telling you that paternal factors are critical determinants of embryonic viability and developmental competence, and the role of the sperm does extend beyond fertilization and has led to the concept of paternal origin of health and disease, and that preconceptional exposures and the lifestyle of the father are very, very important determinants of embryonic health. And optimal free radical levels, integrity of the sperm DNA, normalization levels of the sperm transcripts and the epigenome is vital for the birth of the healthy offspring. And no modality can target all these factors at one go. But yoga, which encompasses asanas, pranayam, and meditation, not only normalize the free radical levels, it decreased the damage in both the mitochondrial and the nuclear DNA. It positively modulated the epigenome, resulted in normal methylation pattern and the normal level of sperm transcripts, which is vital for the normal embryonic development. Thank you.
Thank you, Rima. Excellent presentation. Now the paper is open for discussion. Any questions?
So I have a question. Can you hear me?
Yeah, please go ahead.
Yeah, this is Malini Rima.
Yeah, Malini, go ahead.
Talk. Rima, you talked about oxidative stress, but you don't tell which is the reactive oxygen species which you are measuring. Because there is a positive role of reactive oxygen species in both fertilization as well as implantation. So I am totally confused. Did these patients also have arsenic in them? How was the DNA adduct formed?
No, definitely. That's what I said, that when the levels are very high, they damage. Definitely optimal free radical levels are required for fertilization, capacitation, acrosome reaction. You're absolutely right.
So in your studies, which is the oxidative stress when you say, which is the reactive oxygen species which you're talking about?
Yeah, when we talk of oxidative stress, we are measuring the global free radical levels using luminol. Right, both the intracellular and extracellular, the free superoxide radical H2O2. We are measuring all these, the global total.
Luminol will not measure all.
No,
and some of the images which I saw, they were green fluorescence. That has to be DC to FDA, right? So
no. This is those are pictures of sperm chromatin structure, say using acridine orange. So the sperm that fluoresce red are the ones with the single-stranded damaged DNA, and the ones with the green are the ones with the double-stranded intact DNA. That's acridine orange.
Acridine orange also measures a proton pump activity for.
Huh?
Acridine orange also is used for measuring proton pump activity, and there is a coupling between the redox system and the proton pump.
Right. But
I'm very confused about this today.
No, but the free radical levels we are measuring by luminol. Okay, and that is we're using a luminometer. We are not using flow cytometry for measuring free radical levels. One thing.
If you inhibit, say, one of the enzymes like SOD and others,
yes,
sequentially, then you will know which is the free radical we are talking about.
Yes, we can do that. Yes,
that would be interesting to know.
But then we also quantify what is the level of damage. For example, the DFI, we are assessing whether it is what is the kind of damage. So when we assess the levels of the oxidative DNA adducts, we know that the damage is chiefly oxidative in nature. By studying the level.
That is why I asked you whether it is the Fenton reaction or the arsenic mediated or some other mediated. Because alone superoxide will not directly form the adduct. It needs a next step, either Fenton's reaction or so iron level.
Manli, your audio gone. Okay, Rima, any other questions? Malini's audio gone. I'm audible? Rima?
Just have a look at the literature.
Okay. Thank you, Malini. Any other questions, please? No. So thank you, Rima, for excellent presentation. We now move on to the second speaker. Rima, can you close your presentation? Yeah. So now we have a second speaker, Dr. Mohammad Kasur Nayas. He is the founder and managing director of Abir Bioservices Foundation, Patna. He has completed his doctoral research in collaboration with National Institute of Cancer Prevention and Research, Noida. He has done his postdoctoral research fellowship in Indiana.
इंटरनेट गया
He has more than a decade of the experience in the education and research with the specialization in development of cancer biomarkers. He is proactively engaged in creating mass awareness about the common disease in women and girls through various public engagements, programs, scientific conferences, and workshops across the country as speaker. And so I ask Mohammad Kasur Nayas to present his work, please.
Good morning, everyone. Am I audible right now?
Audible, please go ahead. 20 minutes.
I hope my screen is also visible.
Screen is visible, but it's not a presentation mode,
Yeah,
but it's
yeah.
okay.
Yes.
Not in,
Go ahead.
I guess it's
Yeah,
presentation
it is
mode.
okay now. Go ahead.
Okay, so thanks for your kind invitation and introduction also. And I just wanted to share my experience in understanding the role of HPV infection in semen and the risk for male infertility. So we all know, this HPV and this genotype distribution is very common in sexually active decade of life. And main impact of this particular virus is cancer cervix globally and in India also. And we are witness to evidence that before pandemic, according to ICMR, every 7 to 8 minutes on average, we are losing one woman because of this cancer cervix, and this is due to the HPV infection. So in most of the countries globally, it's a health crisis because of this particular infection. And whether it's European countries, Asian countries, Africa, or American Central America, we can see there's a wide distribution of this particular virus. So there are more than 200 types of virus that is reported. So today, what I wanted to highlight is there are two aspects of this current study that we are looking also in the male infertility. So I just wanted to give you an evidence in cancer cervix that we have done in tertiary care hospital. So we usually know that 16 and 18 is main causative agent for this cancer, but according to our study that we have done in tertiary care hospital, random population of 166 from age 21 to 65, and we have reported that not only 16 and 18, there are other types also equally responsible for cancer cervix. But the question is, in young population, there is a high prevalence, but at the same time, clearance is really equally good in this area. But the matter of concern is after 31 till 65, where there is high chance of persistence rather than clearance of the virus. So keeping in the concept of this particular model, we wanted to explore what is the genotype distribution in case of male, especially in the case of infertile couple. So according to the evidence, HPV infection in male has been really not a very genuine concern for all of us, and there is no screening model as well as vaccination is still adopted in most of the countries, including India as well. So studies have shown that HPV may infect the semen. In the presence of HPV in semen sample is associated with reduced sperm motility, and there is also evidence that there is a high chance of recurrent pregnancy loss as well as losing the integrity of the DNA once HPV infection is there in the semen sample. So HPV infection has shown significant implication in the terms of estimating male infertility, or at least utilizing this concept in reproductive technology. So we all know the different factors that is really impacting the infertility, and most of the time a lot of debate has been going on other factors like congenital, lifestyle, environmental based hazard, psychological state, we all know. But today I wanted to more focused on STI. So one of the STI that I have briefly shared, that virus that I'm talking about, that is HPV. So what are the other STI that is commonly available in the semen sample? We all know that most of the common bacteria are chlamydia, Neisseria gonorrhoeae, mycoplasma, and treponema pallidum. So we usually do the semen culture and recommend antibiotic according to that. But what about the virus? Viruses are actually present, but it's in the silent mode. And most of the time, these are not routinely screened, except this some virus like hepatitis and other virus. But in case of HPV, it is still not under consideration for the screening. So I wanted to highlight today's presentation that it is one of the concern, and we need to implement this particular viral infection in the screening as well, because I have shown that it's very common in sexually active decades of life. So there are other single cell protozoans also there, like Trichomonas pallidum. So what I wanted to give emphasis on is mainly especially related to HPV and what is the locus of infection and resultant pathology, if any. So if you look at this particular virus, HPV that I'm talking about, so site is mainly urethra, that is an epidermis and the testis. But the problem here is even if there is an infection with this particular virus, but it's unable to detect with really any sign of pathology that is associated with the infection. And that is the reason most of the time this particular infection is skipped, because we don't have any impact in terms of pathology as compared to common bacteria, like it's causing different symptoms like urethritis as well as epidermitis or orchitis. This is not in the case of HPV. So today let me give you a brief, you can say, concept how this particular virus is losing the integrity of the overall sperm DNA. So especially this particular HPV and the other virus also like the same mechanism of the action, mainly fertilized cells. But if you look at the other virus that is also common in semen, like hepatitis and HIV1, they are not the one who is like internalizing at the fertilized cells level. So there is a strong evidence that where this particular HPV is attaching, actually, it's the head and acrosome of the DNA. And we all know this particular part is very important as far as fusion with the egg is concerned, implantation is concerned. So we have seen the various literature that because of this association with this particular, HPV in the semen, it causing a different level of during the entire phase of, developmental phase. So we have seen a lot of pregnancy loss because of this infection. There's enough evidence that has been reported so far scientifically. So based upon this background, we, as per published literature also, this presence of HPV in semen is really one of the concerns where the sperm DNA integrity is challenging. So we have a very, small objective that we have defined to show the prevalence of HPV, especially high-risk HPV infection, and what is the clinical correlation between the impact of infection and the male infertility. So this is very, you can say a small pilot study, and we are looking ahead to explore other factors like, what are the, even if there is a infection rate, what is the prevalence of the infection in given set of population that we adopted in this study. And then after that, what are the genotype distribution? That is the second phase of the study. And if we found that whether this particular infection is integrated with the human genome or not, that is another study that we are looking ahead. So in short, whatever we have studied, these all are taken, in well-informed consent, informed consent from our clinical hospitals. And HPV detection is done on the same real-time PCR as we are doing the COVID testing nowadays. So extraction of the HPV DNA has been done by commercially available kit, and and then after extraction, we do this real-time PCR based to detect whether this particular semen is infected with the HPV DNA or not. So what we have seen in our pilot study is we include 104 semen samples from the infertile couple, and then analyze the DNA in the semen samples. And this surprisingly, HPV positivity rate was really high in infertile couple, that is 19.54%. So this gives us a very alarming kind of data that we need to address right now, because if we do such kind of pilot study at a pan-India level, we wanted to scale up this pilot study so that will help policymakers to come up with the evidence that what should be the ideal strategy to screen and treat model in case of male as well, because vaccination drive is still not in India in case of female or male, but some developed countries they adopted is vaccination drive, and that is the reason they dropped down the infection rate to a significant level. And Australia is one of the good example in front of us. They have controlled this particular HPV infection to the largest scale, and they bring down the cancer cervix mortality to some extent. So another question that I came across is, if HPV is positive in the semen, what next? So with the help of this again beautiful paper that has been reported by Claudio F. in 2020, it's a recent evidence that we have, and we wanted to explore our study also in future to how to get rid of this particular virus, even if there is an infection. So a sperm wash procedure was successfully removed HPV from this motile sperm fraction, which was used for assisted reproductive techniques also. And this kind of a study give us a confidence to go ahead and even if there is an infection, we can get rid of this virus, and that can be used for at least in IVF setup. So HPV screening should be routinely performed on the sperm samples, what he strongly recommended, and upon the positivity, sperm washing should be performed before going for the IVF practice. So I wanted to conclude, in short that, there are some previous studies that I have shown also. And in our study also, we got good percentage of HPV positivity. So further large population-based screening will help to develop the clinical guidelines for HPV-infected infertile couples. And yes, definitely vaccination of the male is what the need of the hour. But due to limited resources that we have, still we are focusing on this HPV prevention in girls. So in continuation of this proposed study, the prevalence of high-risk HPV genotype distribution will be also determined in near future. So today I just wanted to highlight there is a significant role of HPV infection in male as well. So we need to address as well, and we need more and more collaboration to do a study in this area to understand the mechanism of infection and greater impact on the infertility as well. So we are a small group of professionals, and we are working towards bridging the gap between science and society through this particular forum, that is Abir Bioservices. So we are adopting a community across the country, and we are educating them and trying to do the research that has a greater impact on the society, and we are trying to translate the research into the action wherever there is a chance to prevent it. So thanks for listening me, and I'll happy to take any questions, and anybody can connect me through this website, through contact us page. I have given my email ID over there also, kasur.niyaz@bio-services.org. Thank you.
Thank you, Dr. Niyaz. Very good presentation regarding HPV infection in males. Any questions from? Paper is open for discussion. So if there is no question, I'll thank you, Dr. Niyaz, for presentation, and we'll go to the next speaker. Yeah, our next speaker is Dr. Neil Giribabu. He is a senior lecturer, Department of Physiology, Faculty of Medicine, University of Malaya, Kuala Lumpur. He is he has a research interest in male and female reproductive endocrinology, developmental endocrinology, cardiovascular physiology, diabetes and their complication, natural products. He is presenting the work on underlying the molecular and interaction between vitamin D deficiency and obesity on male reproductions. He has a number of publications, 65 publications and chapters to his credit. Okay, now go ahead, Dr. Neil.
Can you see my screen? Hello. Good morning, everyone. So,
yeah, Dr. Neil, yeah, you are audible.
Yeah. Okay, okay.
Go ahead.
Okay. First of all, thanks to committee for giving this good opportunity. So, my name is Giribabu Nelli. Currently, I'm working as a senior lecturer in Malaysia. So, today I would like to present one. Is it audible?
Audible, go ahead.
Okay, okay. Today I would like to present one of my research topic, that is underlying the molecular interaction between the vitamin D deficiency and obesity on male reproduction. So it is well known that it is well known that infertility. So what is infertility? We know that. So to failure to achieve pregnancy within 12 months or maybe more than 12 months with irregular unprotected sex. So globally, nearly 15% couple suffering with infertility, more than like a 148.5 million people affected with the infertility. So when you look at the factors, so many factors may be causing the infertility. So we know that, like alcohol, like and also so many toxic compounds. One second. Okay. So many toxic compounds and also alcohol and smoking also causing male infertility. So coming to the male factor, nearly 20 to 70% worldwide causing the male infertility. So especially during Middle-East countries, nearly 60 to 70% maybe male factors may be contributing the infertility. Coming to the Asian countries, nearly 37% contributing the infertility. So we know that among the recent years, so vitamin D and obesity also contributing the male infertility. So recently, many scientists may be emphasizing what is the role of vitamin D on the male reproduction and also what is the role of obesity on the male reproduction. So when you look at the prevention, nearly 1 billion people affected by the vitamin D deficiency. It is like how the COVID-19 is a pandemic, like even vitamin D also now it is a pandemic. So nearly 13% of the population worldwide is affected by the vitamin D deficiency, and also obesity also nearly 2 billion people affected by the obesity. So nearly 27% people affected by the obesity. So coming to the what is vitamin D deficiency? So in the serum, nearly if maybe in the serum vitamin D levels maybe 30 to 50% nanogram per ml considered as sufficient. Above 50 nanogram per ml considered as excessive. So below 30, so nearly 20 to 30 nanogram per ml considered as insufficient. So below 20 nanogram per ml considered as a vitamin D deficiency. So dietary, if you take dietary intake like 400 to 600 international unit per day, it is sufficient for the vitamin D. So if you take like 1,000 to 2,000 international unit per day, it can maintain adequate amount of vitamin D levels in our serum. So what is the reason vitamin D is deficiency? So we know that the mostly inadequate exposure of sunlight. Recently, the people are daily sedentary life, and also they're close with their the whole body skin with the dresses, and also the people they're using face face like a face shields, and also these are the and also especially in India we have 4 seasons. So especially at the winter season also we are exposing very less sunlight. And coming to the aged people, so some of the engines also lacking. This is also causing the vitamin D deficiency. Come back to the dietary. Some people they're taking a dietary less amount of vitamin D, and also especially who has a problem with the gastrointestinal disorders, renal diseases, and liver diseases, they have a prevalence to the vitamin D deficiency. So come back to our male reproduction. So recently, many studies they found out vitamin D receptor, like a VDR receptor, was found in the spermatids and epidermis and seminal vesicle and prostate also, and also the vitamin D metabolize also found out in the male reproduction. So recently, and also they give the supplementation to the male, so it will be giving increase the sperm quality, and also androgen status also improvement was happen. And also some studies they giving vitamin D. So this supplement also it can increase the testosterone concentration and metabolic parameters, and also the erectile function will be causing. So and also another study it will be vitamin D causing the increased sperm motility. So come back to the next factor is obesity. So what is obesity? So we know that abnormal fat, excessive fat accumulation will be causing the obesity. So according to WHO guidelines, more than 30 BMI considered as obesity. So obesity coming to the worldwide, nearly 27 percentage of people affected by the obesity. Coming to the Malaysia, nearly half of the population obese in Malaysia. So is there any relation between the obesity and male infertility? Yes, so many relation is there. Especially it will be causing the disturbing the hypothalamic hypopituitary gonadal axis, so that LH will be decreased, and also testosterone will be decreasing, and sex hormone binding globulin also decreasing. And coming to the testis, it will be excessive causing the high temperature. So whenever the excessive causing the high temperature, it will be lead to the disturbing the spermatogenesis, and also especially in the obese people, it will be easily converted into the estrogen. The testosterone easily converted into the estrogen, so that hypogonadism also we notice in the obese people. Coming to the sperm, so it will be inhibit the chromosome condensation, DNA fragmentation, and also it will be causing a sperm apoptosis. So my question is is there any relation between vitamin D and obesity? Yes, some relation is there. Vitamin D and obesity. The people nearly who suffering with vitamin D deficiency, so those are nearly 35% people are obese people. And also, when you look at the relation between what is the mechanism means, vitamin D accumulation in the adipose tissue, so that those people, the serum levels of vitamin D is very less, and also some enzymes like alpha hydroxylase enzymes also low, reduced in the obese people, so that vitamin D will be lost less in the obese people, and also vitamin D receptor also will be some mutations will be happen on the obese people. So these are some studies will be telling. So there is a relation between vitamin D deficiency and obesity. So if vitamin D deficiency both will be have a problem, what will be happen to the male reproduction? Earlier we know vitamin D have a problem with male reproduction, and obesity also has a problem with male reproduction. So recent studies also telling they have both have a correlation. If both have a vitamin D deficiency, obesity, what will be happen? Today my concept. So these are my questions. So what will be happen? Vitamin D deficiency with obesity, what will be happen? So look at there. So when coming to my animal experiment, so I make four groups, like a control group with vitamin D. So control group without vitamin D. So high fat diet, because high fat diet we give for the making of obese mice, obesity model. So with high fat diet, and high fat diet without vitamin D. So these are the customized diet. So we bought from the Ultraman from the German. So normally it is high fat diet. Even the normal diet also present vitamin D. So we customize it. We make a 2000 IU per kg, because earlier I told you, so a 2000 international unit per kg. It is useful for the adequately maintaining the serum levels of vitamin D. So even though normal diet also, high fat diet and normal diet also, we customized the vitamin D levels. So okay, coming to my experimental design. So after end of the experiment, we measure during the experiment also, we measure the food and water intake, and also we measure the OGTT and ITTT also. So at the end of the experiment, we collect the blood for the measuring the hormone levels, and also we collect the sperm and also testis also. So the data was analyzed by the ANOVA. So here we're using SPSS. So coming to my research, so here we can see from the picture. So this is the normal rat with vitamin D, normal rat without vitamin D. So this is the obese, both of them with high fat diet, with vitamin D, without vitamin D. So looking for my data, so obese, normal rats, and also normal means standard diet with obese rat, the body weight was significantly increased, but there is no difference between high fat diet with vitamin D, without vitamin D, but there is a significant difference between normal rats and obese rats. So come back to the fasting blood glucose levels in high fat diet and without vitamin D also, both of them, the insulin level, blood glucose levels were significantly higher than the normal rats. So OGTT and ITT also impaired, was we noticed. So it indicates, so metabolic profile also impaired in the high fat diets. It is well known that. So come back to the sperm parameters. This is very important. So in normal rats and without vitamin D, a little bit like a sperm, significantly sperm count, motility, and viability, and HOS toilet coils also decrease. So high fat diet without vitamin D, this is very important. So the sperm count, motility, and viability, and HOS toilet coil sperm also decrease when compared to the other groups. So when you look at in this picture, it will shows a mitochondrial membrane markers, especially ATP PB and COX4 and TOMM20. These are the pictures on the sperm. So we can see here. So when we hit high fat diet without vitamin D, the intensity of the like sperm membrane markers, we can see it is decreasing. So whereas in the like normal control, we can see the intensity is very high, but whereas in high fat diet without vitamin D, the intensity was decreased. It indicates so the mitochondrial markers also decreasing in high fat diet without vitamin D. So even though histopathology changes also we can see normal rats without vitamin D, we can see less number of these like a sperm in the seminiferous tubule. We can notice like a high fat diet without vitamin D, we can see lack of sperm. So the seminiferous tubule we can see it totally disrupted, and also lack of sperm we notice. So come back to the steroidogenic markers like a star and CYP11A. So we can see on the brown color or the like leading cells. So coming to the high fat diet without vitamin D, we can see less brown color. So it indicates steroidogenesis was disrupted on the without vitamin D with high fat diet. Even though like a double immunofluorescent, it will tells the red color indicate the 3-beta HSD like steroidogenic markers. So in high fat normal rats, we can see high red color, whereas in the like a high fat diet without vitamin D also we notice very less 3-beta HSD. So it is also double confirmed with Western blot also. Western blot also telling like a CYP11A1 is significantly decreasing high fat diet without vitamin D. So finally, we already confirmed with like vitamin D receptors on the sperm and also testis also. We notice without vitamin D on the high fat diet, we can see the less expression, and also in the testis on the leading cells also we can see less expression. So finally, we can conclude that so vitamin D is a requirement for the steroidogenesis. So moreover, we need to find out what is more mechanism, what is the reason why vitamin D is required for the steroidogenesis. So we are now currently find out like other molecular mechanisms. So I hope in future vitamin D also prescribed by the doctors like a vitamin C nowadays, and also zinc also prescribed by the doctor. In future, vitamin D also prescribed by the doctors to the infertility patients. So these are my reference. Thank you, friends. Thank you.
Thank you, Giribabu, for excellent presentations. Now paper is open for discussion. Any questions, please?
Well, thank you, sir. Thanks sir, for a beautiful presentation. Sir, I have one question. Before this, I would like to see your first slide. What is the normal or toxicity? Means what is the normal value of vitamin D?
Normal value of vitamin D.
Yes, sir. उसमें toxicity का भी आपने mention किया था.
Can you see this slide?
It's not exact. Yes, sir. Right now it's okay. Fine. Okay, sir. How we can determine the amount of vitamin D in our body? How we can test it?
We can take with the like now.
What is the value of a vitamin D is present in our body at present? How we can check it up?
Very easy, simple technique. You could take the serum, and also now the ELISA kits are available. You can easily check out with the ELISA kits.
Yeah, normally chemoscience based assay is also there. Very sensitive method which can determine the vitamin D easily. No issue.
Yeah.
Okay, sir. So,
hello, Dr. Nelly, can I ask some? Oh, sorry.
Yeah, go ahead, please.
Sir. Thank you, sir.
Please go to the slides of histology that you have shown in the testis.
You're talking about histopathology?
Yeah, that's 23 number.
Okay.
There is complete loss of spermatozoa in ST that you have written. There is complete loss of sperms.
Yes,
so
sir.
Is it only because of that vitamin D thing only, or have you seen any other marker of like cell loss, apoptosis, necrosis, or any other thing? Because only for vitamin D, it seems quite not pertinent thing.
Yes, sir. Yes, I agree with you. I've told you this is not without vitamin D. It is the both model, concurrent model, obesity and also vitamin D deficiency. Okay. So now currently we are working on this so many mechanisms like a START3 and also recent genes like a PLC gene also we're finding out, and also we are looking for the apoptosis also. So hopefully we will next within few months we can find out what is the real mechanism.
So there is a clear washout of the sperm. So this cannot be only because of vitamin D. Apoptosis, like obesity is there, so obviously that testicular temperature has gone up.
Yes, sir. Yes, sir. Yes, sir. That is some interesting is there. Some we
lot of other markers have to be seen. Okay,
yeah,
thank
we are
you.
finding out, sir.
Okay, any other question? No. Okay, thank you, Giri Babu, for excellent presentations.
Thank you, Prof. Thank you for.
Yeah, we go to the next speaker. Can you just close your presentation, please?
Sure, sure, sure.
Yeah, we have our next speaker, Dr. Kovic Day. He's Assistant Professor of DBT, Ramalanga Swamy Fellow, Manipal Center for Biotherapeutic Research, Manipal, Academy of Higher Education, Manipal, Karnataka. His research interests is reproductive biomedicine and on better understanding of the biochemistry of the gamete function in mammalian systems and exploration of the translational aspects for treatment of infertility issue in humans. He has been awarded Ramalanga Swamy Re-Entry Fellowships, NIS Travel Grant, conferences in to attend USA, Award of Senior Research Fellow, Medical Research ICMR. He has more than 15 publications and chapters in the books. Over to you, Kovic.
Yeah. Hello and good morning, everyone. So first of all, I would like to thank all the members of ISSRF 2022 organizing committee for providing me with this opportunity to share this platform and share my research work. So I would like to go to the slides now. Are the slides visible now?
It's visible, go ahead.
Okay, thank you. So the topic for today is PKC alpha 2, PP1 gamma 2, PPP3R2CC, that is calcineurin, and GSK3 alpha, so that is glycogen synthase kinase 3. This forms a quad to regulate male fertility in mammals. So basically what I'm going to do, I'm going to describe a lot of research work within a schematic format, because it is not a particular research study. It is the fruit of last 10-12 years research, and that has been published in more than 5 to 6 international journals. So basically, I will try and summarize the total data we obtained. So this is a very common structure of testes. And epididymis, as you can see, the sperm are synthesized here, and from here they migrate to the epididymis from caput to cauda, where they actually mature, and during ejaculation through vas deferens, they are ejaculated through the female reproductive tract. And this is the life of spermatozoa. So here you can see the testicular developmental phase, that is the spermatogenesis, all the DNA replication, gene expression, everything happens there. Then you have the epididymal transit, where actually the maturation and motility initiation takes place. And finally, inside the female reproductive tract, there is two main events: capacitation and hyperactivation, essential for penetrating the egg. And finally, the fertilization takes place. And these are some of the events that happen during this phases. So here you can see that we start basically with millions of cells in the semen, but in different stages you can see that through cervix and through uterus, finally only a handful number of sperms reach the egg. So, and this journey is governed by the motility status of the sperm. And finally, the sperm, initially they have this forward motility first, and finally they have this hyperactivated pattern, that is a whiplash movement required to penetrate the egg. So no wonder why low sperm count or poor sperm motility contributes to 90% of the cases related to male-specific infertility. So there have been at least 2,000 genes which are involved in spermatogenesis, and of them, 175 genes have been identified so far, deletion or silencing of which can lead to male infertility. But not all of these are Y chromosome specific, so not all of them coming from the father side. So many of these ubiquitous genes have isoforms specifically expressed in testis or sperm, or they have certain isoforms or paralog. Those are highly expressed in testis sperm compared to other tissues, and they are not functionally redundant. So we have chosen 4 such isoforms of some functional proteins present in sperm. So one is PP1 gamma, another is GSK3 alpha, and then you have the calcineurin, and finally you have PKA. So the first one is a phosphatase. So, and the PP1 gamma 2 isoform only is present in sperm. In testis, you will find both gamma 1 and gamma 2 to a low amount, but in sperm you will find only gamma 2. And if you knock out the gamma 2, what happens, we will find in the next slide. So this is the basic structure of GSK3 alpha beta, both are present in sperm, and also PKC alpha 2 and alpha 1, both are present, but deletion of only alpha 2 actually lead to male infertility. So why does it happen? So initially we can see that GSK3 alpha expression in testis is quite high. But here you can see this is calcineurin regulatory subunit. This is not present anywhere. PPP3R2 is not present in any tissue, only in testis and sperm. Similarly, gamma 2 is very highly expressed in sperm, but compared to that in other tissues, its expression level is very low. Same case with PKC alpha 2, which is only present in testis and sperm. So what are the functional attributes they provide? So if we compare the progressive motility in alpha knockout and in calcineurin catalytic subunit knockout sperm, you will see that the average path velocity, curvilinear velocity, and this kind of progressive motility parameters are compromised. Same thing happens in case of PKC alpha 2 knockout animals. But in case of PP1 gamma 2, spermatogenesis itself is like retarded. The testicular size is very low and sperm synthesis is very low. Only few sperms you can find if you try to isolate sperm from the epididymis, because it is very small. The morphogenesis itself is retarded. So there is mid-piece abnormality observed in both GSK3 alpha and calcineurin knockout with rigid or bent mid-piece. The sperm count in case of GSK3 alpha and calcineurin knockout are 30 to 50% lower, suggesting that GSK3 alpha and calcineurin both may be having function in spermatogenesis. In case of gamma 2 knockout, I have already told that without gamma 2 there is no sperm synthesis, almost no sperm synthesis. And you can see in all these 4 cases, the male, fertility status is infertile. So little detail look in this thing. Here you can see that this is the actual gene PP1CC from which this gamma 1 and gamma 2 is produced. So if gamma 1 is rescued, like transgenic gamma 1 replaces gamma 2, even then some are only subfertile. But Here, without gamma-2, they are infertile, and without the entire gene, they are also infertile. Similar thing, alpha knockout, but with beta knockout, the conditional beta knockout, you can see this male are fertile. In this column, you can see that in case of all these knockouts, females are not affected in terms of their fertility status. It is only the male which is affected, they are infertile. So I cannot describe all the properties and data of all these 4 isoforms, but what I will do, I will take one or two property of each of the isoforms and describe that. So this is basically PP1 gamma 2. So initially from the PP1 gamma pre-mRNA, there is splicing, and from that gamma 1 and gamma 2 mRNA are expressed. They are sequence in terms of the sequence very similar, only there is little difference towards the C-terminal nail. This is how PP1 gamma 2 actually is regulated inside any cell. There are 2 regulators of PP1 gamma 2, which when bind this phosphatase actually inhibits its activity. So this is a detailed look at how PP1 gamma 2 is related with GSK3 alpha. Here you can see that GSK3 itself has a particular mechanism based on its serine phosphorylation. Its activity is higher when this serine phosphorylation is removed. Okay, serine 9 and serine 21. And then we have this PP1 gamma 2, another regulator of PP1 gamma 2, I2, that is actually phosphorylated by GSK3. So when I2 is phosphorylated, it binds with gamma 2 and inactivates it. Okay, when gamma 2 releases the I2, is released from the I2, it becomes activated. Manganese ion plays a pivotal role in the activity of gamma 2 because without the manganese ions, this cannot function. So this is the 3 regulators of PP1 gamma 2 and how they are actually modulating the function of PP1 gamma 2 in these different knockouts we have already described. So, and this is with maturation, you can find both in caput and caudal, the binding pattern actually changes. Here you can see that in caput it is not bound, that means the PP1 gamma 2 activity is higher, but in caudal it is bound. So that means the PP1 gamma 2 activity will go lower. And same is the case for others. So now I will move to GSK3 alpha and how it relates to sperm motility. So what is that? Yeah. This is wild type sperm motility and this is GSK3 alpha knockout. You can easily see the difference. In case of alpha, the midpiece, the alpha knockout, the midpiece is rigid and the overall motility parameters like velocity is very slow. And this is the morphology. In normal sperm, you see this kind of morphology. In case of alpha knockout, you see either this bent midpiece or this kind of morphology. So in case of calcineurin knockout, we see almost similar morphology. So then this is a data from our calcineurin study where we actually used wild type mice and then got their eggs and sperm and then inhibited sperms with FK506, which is a prominent calcineurin inhibitor, and only 20 nanomolar is required to inhibit. Okay, there you can see the difference in the IVF result. There are so many 2-cell stages, here only few. So it completely actually inhibits the fertilization. And this is the change in motility with inhibition with calcineurin. You can see that this midpiece is very flexible, which is required for the hyperactivation. And here the midpiece is very rigid. Only the principal midpiece is moving. Similarly, we use GSK3 alpha and beta specific inhibitors for our IVF experiment. And here is the result where you can see micromolar doses of GSK3 alpha inhibitor, BRT 0705, can almost nullify the IVF efficiency, but GSK3 beta inhibitor BRD3731 have not much effect on the IVF efficiency. So GSK3 alpha but not GSK3 beta is required for fertilization. So further, we actually check the conservation of these genes and their proteins in different species. So we initially did the same for gamma-2, and we found out in all the mammals, almost in all the mammals, specific exon 7 and exon 8, which actually differentiate gamma-2 from gamma-1. This differentiating fragment is actually highly conserved in most of the mammals. So if we go to the GSK3 alpha data, here we can see that the N-terminus of GSK3 alpha, in case of non-mammalian vertebrate, you can see that there is so much of inconsistency in their amino acid sequence. But in case of mammals, it is highly conserved. So it just goes to show that these proteins have been selected by evolution for a particular function. N-terminus of GSK3 alpha is tightly conserved in different species of mammal. Okay, now this is calcineurin. Here also, you can see in different species of mammals, the N-terminus of calcineurin regulatory subunit is highly conserved. This is about PKC alpha 2. So there, C alpha 1 and C alpha 2 has very similar sequences, only that in the C alpha 2 starts as a splice variant from 15 amino acid later, and it is expressed as a splice variant. And here you can see that in mammals, in different species of mammals, it is highly conserved. So PK catalytic subunit in somatic cells is the C alpha 1, but in testes and sperm, it is the C alpha 2. It is derived from the alternate exons. This is one of the most interesting data that we have. Here we have compared all these sperm proteins anatomy or localization inside the sperm. So this is for calcineurin, Alexa 488. You can see it is mainly present in the sperm midpiece. In case of PKC alpha 2, it is present in sperm midpiece, little bit in the principal piece, but also in the head and anterior acrosomal, anterior portion of the head. In case of gamma 2, it is present throughout the sperm flagellum and also in the anterior portion of the sperm head. But in case of GSK3 alpha, it is highly present in midpiece and a little bit in the principal piece, but very thin layer you can see fluorescence here in the sperm head. GSK3 beta, it is not at all present in the flagellum. It is only present in the anterior head portion. Okay, so GSK3 and GSK3 alpha and beta have different localization. That actually explains why these proteins are required and their isoform or paralog cannot do the job if these isoforms are deleted, because sperm, unlike other cells, are very compartmentalized. Not that any protein can like migrate to any location of sperm, because the sperm head, the midpiece and principal piece all are differentially compartmentalized. So if certain protein is only present in sperm midpiece, then deletion of that protein can adversely affect its motility and fertility status. That's what we can see in this figure, that all these proteins are present in different parts of sperm, but it is the midpiece where all the 4 isoforms are present. That's why we call it a quad, that these 4 isoforms are only present in midpiece where they overlap with their presence and also functions. Gamma 2 actually is only active initially during spermatogenesis and early phase of sperm maturation, but all the other proteins are more or less active throughout the sperm life. Okay, here you can see the qualitative expression.
You have 2 minutes to come.
Okay. Yeah. A qualitative expression of these proteins inside the sperm based on this fluorescence data. Okay, so this is a schematic how basically GSK3 alpha and calcineurin interact with each other, and this is the mechanism how calcineurin can activate GSK3 alpha. When you use AK506 to inhibit calcineurin, so then this GSK3 alpha activity also goes down, and these are the related molecules with GSK3 alpha, which we have shown in our papers how they actually interact through proteomics and biochemical studies. And this is the overall scenario. You can see in immature sperm, in mature sperm, and in hyperactivated sperm, how these things are interacting with each other, how all these proteins are interacting with each other. And this is the summary. And you can see that gamma-2 is involved in spermatogenesis, sperm maturation, but presence of gamma-2 actually inhibits motility initiation. So in the caudal sperm, you will find less activity of gamma-2. And during capacitation, hyperactivation, also there are some function of gamma-2. And you can see GSK3 alpha being involved in spermatogenesis, maturation, and also in capacitation, hyperactivation. Similarly, PKC alpha and calcineurin is involved in capacitation and hyperactivation that lead to the fertilization process. And out of this work, we have published 6 papers in last 7-8 years. Some of them actually are here listed. And finally, what are the application of these studies? Basically, this study gives this signaling enzymes, GSK3 alpha being a substrate of calcineurin, have key roles both during epidermal sperm maturation in the male reproductive tract and during fertilization in the female reproductive tract. Calcineurin may still have independent essential roles in regulating the ability of sperm to fertilize eggs. These findings should lead to a better biochemical understanding of the basis of male infertility and lead to novel approaches to contraception targeting the epidermis and or sperm in the female reproductive tract. Actually, we already got an international patent where we have used this FK506 to formulate a male contraceptive that can be used topically with a reversible function. And our results should enable the development of reversible male contraceptives targeting one or both enzymes, like in this case, calcineurin and GSK3 alpha we have targeted. So I want to thank my lab mates and my supervisor, Dr. Vijay Raghavan, during my postdoc times, and our present departmental head, Professor Ravi Raja in MCBR Mahe, and my funding agencies, DBT, NIH, my university, present institute, and thank you for your attention.
Thank you, Dr. Dave, for excellent presentations. Now, paper is open for a discussion. Any questions, please?
Pradeep sir, you have to unmute yourself.
Oh, sorry. Yeah. Now, this is just to summarize, Dr. Rima Dada has presented a very good presentation, role of yoga, importance of role of yoga and parental factors. Dr. Nayas has presented HFB infection for affecting the male infertility. Dr. Swastik Day has presented isoforms of regulate the male fertility. And Dr. Giri Babu has identifying the molecular mechanism of vitamin D and affecting the male fertility. It is an excellent presentation by the speakers, and we are able to finish in time. I thank you all speakers for finishing their talk in time. And I thanks for ISSRF, Dr. Lohia and Dr. Sharma giving me an opportunity for chairing this session. Thank you very much. Over to you, sir.
Thank you so much, sir, for wonderfully chairing the session. It was great. And thanks to all the invited speakers and oral presenters. So we are moving ahead to our next session, which is on omics in reproductive health. And it's my great pleasure to introduce Dr. Prashant, who is my current mentor. Dr. Prashant is a principal scientist at School of Biotechnology, Amrita Puri University. Dr. Prashant is system biologist who has wide interest in functional genomics, transcriptomics, and protein informatics. Welcome, Prashant. And the other chairperson for this session is Dr. S.N. Kabir, who is former Deputy Director of Indian Institute of Chemical Biology, IICB, Kolkata, and presently he is at ATGC Diagnostics Private Limited, Kolkata. I think due to some reasons, Dr. Kabir will not be able to make it today. So over to you, Prashant. Thank you.
Yeah, thank you. Thank you so much, Nidhi, for your kind introduction. Yeah. So we have in this omics and reproductive health, we have 5 wonderful speakers. The very first speaker is Professor Ashok Kumar Mohanty, who would give a talk on genome and proteome-wide analysis of genes and proteins to understand fetus mother crosstalk and pregnancy biomarker discovery in bovine. Professor Mohanty has large interests in the functional genomics of mammary gland development, sperm biomarker development, and proteomics of animal viruses, largely associated with milk from different species and their health attributes. He received several accolades. Is a recipient of Jawaharlal Nehru ICAR Award for outstanding postgraduate research work in the area of animal biotechnology. He's a fellow of National Academy of Dairy Sciences, India, an associate fellow of National Academy of Veterinary Sciences, India, and he has been awarded Visiting Scientist Award for DVT Government of India, and he has served as consultant for Food and Agricultural Organization IAEA 2014, also United Nations in Vienna. He has more than 200 peer-reviewed publications to his credit. Over to you, Professor Mohanty. We are grateful, sir. Please, here. And
thank you.
Keeping in view of brevity of time, I would probably request all of you to stick on time so that we will have an ample room set aside for Q&A. Thank you so much.
Thank you. Thank you so much. Good afternoon, everyone. I thank the organizers for giving me the opportunity to speak on this occasion. And I'll share my slides.
Yeah, please.
Yeah. So you can see my slides. My slides are visible?
Yes, please. Yes, please. Yeah. Yes, please. Yeah, please go ahead. Yeah.
Yeah. So I'll just do the. Yeah, just to begin with, I'm just going to speak on the genome and proteome-wide analysis of genes and proteins to understand fetus mother crosstalk and pregnancy biomarker discovery in bovine. So I am located at Indian Veterinary Research Institute, Muktesar. It's located in the district of Nainital. So we have this a very old research institute goes back to 1893, and the mother campus of Indian Veterinary Research Institute. A couple of Nobel laureates also have visited, and the center has a lot of contributions. So without wasting much time, I'll just speak that when we are talking of the assisted reproductive technology advancement in this field in human, so still now the pregnancy miscarriage remain a common and major concern. And the same is the case in case of livestock. In fact, the pregnancy mechanism is kind of little different because of separate placentation system, but still the overall mechanism is similar. So we are facing a lot of problems also in livestock. And also, unlike in case of human being, pregnancy detection at early stage is very crucial in improving the reproductive efficiency of livestock, which actually defines the economic profitably to the farmers. And the successful pregnancy actually depend on the synchronous embryo environment. But if there is asynchronous embryo development and poor interaction between mother and developing embryo, then the pregnancy is going to fail. So the endometrium and embryo undergo highly dynamic and complex molecular crosstalk for successful completion of embryonic development. If there is early embryonic development which is perfect, then only there will be prolongation of pregnancy. So for a pregnancy to be successful, the first thing is the placentum, where the fetal cotyledons and maternal caruncles are the two anatomically distinct structures that play a crucial role in successful pregnancy. So when there is a pregnancy, say in case of animals, because we are working in animals, the post-pregnancy rapid changes actually takes place at the level of transcripts, mRNA. So the early pregnancy cotyledons in comparison, so we did an experiment. Actually, when there is I told the cotyledon and the maternal caruncle crosstalk. So we took distinctly two stages. One is a non-pregnancy caruncular reminiscence of uterine buffalo versus the fetal cotyledons. The picture you can see, this is a small fetus where this is growing, and this is the placentum, and this one is the fetal cotyledon which is attached to the maternal caruncle. We knowingly did not take the pregnant caruncle because there will be intermixing of genes. So we took distinctly reminiscent of uterine non-pregnant buffalo along with a pregnant caruncle and extracted the RNA, and this is the integrity of RNA which was checked by reading value, and subsequently went for a microarray experiment just to check what are the differentially expressed genes. So here in this case you can see four control and 4 treated. 4 pregnant samples and 4 non-pregnant samples are taken, and subsequently went to see what are the differentially expressed genes which are expressed. These slides actually we used Zealand bovine whole genome gene expression microarray, where you can clearly see that there is a total of 37,194 upregulated genes. You can see identified probes and 28,341 total identified probes which are downregulated. So this was divided two distinct classes where highly upregulated and highly downregulated genes were found out. But all those genes, even if there, some of the genes has to be distinctly separated, then only we can go for further analysis. So subsequently, we just tried to discover some of the biological significance of the complex interaction and prediction of the pathway among differentially expressed genes. So what we did is, we had 2 approaches. The genes with a fold change of more than 3, which was constructed using cytoscape. So in this case, the highly connected network searched for a densely connected regions using plugin M-code to form a subnet mask of cluster of genes. The second approach was to go for more than 10-fold upregulated and downregulated genes, where we have a statistical significance, and we went for the protein-protein interaction network using these bioinformatics things like Biograd, KEGG, and Reactome databases just to see the interaction. So third one that was used was cytoscape plugin Plugo. This was to decipher in a functionally modulated network the biological implications of fetal maternal proteins interactions during early pregnancy and various enrichment terms. So all these target genes which were found in this M-code were imported to Plugo and visualized the non-redundant biological terms of large cluster of genes. We saw very interesting observation. If you see this one, same volcano plot, very nicely represented here in this case, and you can clearly see 2 things. we came down to around 8,587 gene probes, where 4,298 were downregulated and 4,289 genes were upregulated. And clearly you can see two clusters. One cluster C figure you can see, and the another cluster is PAG in the right side, upregulated, or one cluster is highly downregulated. Subsequently focused our attention to this field. So this is the volcano plot showing the distribution of all the differentially expressed genes and robustness of microarray experiments, where you can see in the left side downregulation showed immunological response proteins, top downregulated proteins, and top upregulated proteins were rather aspartic proteinase class, which are known as pregnancy associated glycoprotein in good numbers, which are highly enriched. And subsequently, we went for the gene ontology enrichment analysis toolkit in order to see their bar cluster functional classification, molecular functions, biological processes, and cellular components, whether either upregulated or some are downregulated. In this case, you can see clearly VEGF signaling, PDGF signaling, integrin signaling, these are clearly demarcated. We went a little deeper without wasting much time here in this case. We'll say that these are the various specific pathways which were common pathways observed, which are distinctly represented. Towards the right, you can see there will be very clear. I'll come to the summary of all those things. Subsequently, we went for biological processes, then cellular components, you can see common pathways, and molecular functions. So the identified molecular function in Go analysis showed the involvement of the genes embryo attachment and its growth. So, and these are the protein classes. So to summarize the overall transcriptional landscape of cotyledons and coruncular tissue, these are some of the points. Multiple pathways are affected, either overrepresented or downrepresented, because genes are interconnected among various pathways. In cotyledons, for example, angiogenesis process, more than 30 genes were upregulated because this is a highly vascular process for development, and 50 genes are downregulated. Other pathways you can see apoptosis, cytoskeletal regulation, and so many different pathways. Some of the important pathways are PDGF pathways, vitamin B6 metabolism, or WNT signaling, but 4 major pathways which were actually there is significant difference where vitamin B6 metabolism, VEGF pathways, vasopressin synthesis, and cytoskeletal regulation. So these suggest strong evidence that sudden fluctuation in the transcription cotyledonary side cells influences the crosstalk and guide the placentome for the maintenance of pregnancy. So these Go analysis revealed many important pathways and biological processes involving the development of embryo during pregnancy. We saw the heat map there. From the heat map is very interesting. It was divided, initially we took only 2 clusters, which entirely divided into 7 different clusters, and the top cluster was taken non-pregnant versus the pregnant. So here you can see the identified cluster represent true biological and molecular changes induced during pregnancy. And in pregnancy itself, there are a lot of genes and proteins which are highly enriched, and many of them are PAG and other kind of proteins which had very good relevance in terms of their pregnancy status. Then we thought of, okay, there are so many thousands of genes and more than 3 times upregulated genes. What we did, we went for a biological path analysis interpretation. This is very difficult to analyze anything. So we use this Genmania, BioPack string, and Reactome in order to get 2,307 nodes. And subsequently, we came down to more than 10-fold, where we could find out some very good pathways which are interacting very well. Of 10 interesting pathways, these are cell cycle, aurora, extra, neutrophin, metabolism, GPCR, PI3, RAP1, and all those things were highly enriched. So just to get some biological context out of it, out of these 10 times upregulated genes, 1074, 497 are upregulated and 577 are downregulated. This is upregulated one. This is protein-protein interaction network. You can see interactome analysis, where some of the proteins, you can see these are the nodes which are highly enriched. Similarly, these are the proteins, some 577 are downregulated proteins, also highly enriched, which we again went for further analysis. So to summarize this finding, increment in signaling of phosphatase, inositol, IL-2, P53 amino acid transporter, and these are phase cycle protein and aspartic protein are found increased concentration. So the cotyledons cells generate active amino acid transport as well as increase the peptidase family, because many aspartic peptides are there, mainly pregnancy associated glycoisoforms, for providing a generous atmosphere to the embryo. Similarly, these pathways, you can see WNT, RAS, RAP are downregulated, hedgehog and calcium, and these results suggest alteration in this path are responsible for immunosuppressive environment that is necessary to avoid rejection of the fetus. So from this, there are two messages. One is aspartic proteinase protein PAG. The other one is immunosuppression rejection. So immunosuppressive environment is necessary to avoid rejection of the fetus. We'll go a little deeper here. You can see the entire PPI network we categorize into T: WNT signaling, immune response, cell cycle, and cell adhesion molecules, because they are very much important, which are highly enriched, which has relevance during the pregnancy process. So to come to the overall observation, the two pathways which we saw, two things in the beginning. One is the downregulation of bolas in pregnant buffalo is essential to present. These are the immunosuppression, associated immunity are essential to present an immunosuppressive environment necessary to accommodate semi-allogenic fetus and successful pregnancy. Immunosuppression in the mother during pregnancy seems to be a local event. This is very important. So rather than a systemic immunosuppression, this is rather a more local event happening at the implantation juncture, and inhibition of complement system also is a prerequisite for the maintenance of normal pregnancy. This we suggest because the fetus has to thrive. The second one, the aspartic proteinase, number of pregnancy associated glycoisoforms. We saw the PAGs are aspartic endopeptidase. The trophoblast cells show temporal and spatial expression of PAGs. And the role of PAG is not yet very clear. And bovine and porcine PAG2 have proteolytic activity, and they have definite functions. And they may have a role in bridging the molecules. They have also made immunomodulator actions, and they also have luteotropic in action in cattle and buffalo and sheep in order to thrive the pregnancy. So just to summarize the overall observation, we investigated whole transcriptome, cotyledonized cells in comparison non-pregnant. The differentially expressed genes contribute towards maintenance of immunologically congenial environment for fetus and regulate various vital functions of embryonic development through oxygen transport, adhesion, nutrition. The cotyledon seems to remotely control fetal development through regulation of various pathways. And a systems biology, this kind of system biology approach are great significance, which discovers a large number of novel genes, and that corroborates many of the existing knowledge in bovine pregnancy. And many transcripts are identified in addition to those which are already. So with this background, if you come to PAG, can be pregnancy biomarker? Answer is yes. So quickly what we did, we designed some primers and extracted RNA, amplified the various different isoforms of PAGs, pregnancy associated glycoproteins, which was subsequently cloned, and we sequenced them. Is there any specific enrichment, a specific PAG interestingly, more than 40, almost 43% of the transcript were isoform buffalo pregnancy associated glycoprotein 7. Because our target was to develop a marker, biomarker. What we did, we selected this one. All other isoforms we cloned and expressed. And we saw, you see, PAX7 is highly expressed. So it took this one, cloned that, and subsequently expressed in the expression vector. And subsequently, we express PAX7 and PAG18 with very expression, and these were purified. And we generate antibody against this using mice and rat, and subsequently we try to see their antigen, whether it is interacting or it's very nicely interacting with the immunoblood. And then we developed a kind of ELISA for this protein, which we subsequently used to screen the pregnancy in case of large animals, like cattle and buffaloes. Here you can see sample, pregnant sample, non-pregnant sample, there is a very clear-cut signal. And subsequently also we did that in another groups and in buffalo also. And ELISA was developed where you can see as the days of pregnancy increases, we can see the increase in the concentration of buffalo-specific pregnancy-associated glycoprotein 7. Subsequently, we also did trial in case of buffaloes, and it also gives similar results. You can see non-pregnant, we cannot see, and in pregnant, we can see many positive. They are coming as positive. So overall conclusion is, we just try to see what are the various genes which are expressed and how they are cross-talking with each other so that the pregnancy survive with a message that there is immunosuppression locally so that there is no allogenic rejection and the embryo can sustain. At the same time, the pregnancy will continue because of overexpression of some molecules like PAG and other kind of molecules which sustains along with the progesterone and other things so that the pregnancy goes on. Not only this much, there are so many thousands of other genes which are making a crosstalk and making networks in order for the pregnancy to continue. And thank you so much. With this background, I conclude my talk. Have any questions?
Yeah, thank you. Thank you very much, Dr. Mohanty. The room is open for Q&A.
Should I share my slides or it will be?
Yeah, you may just keep it, for a brief minute. Yeah.
Okay.
Any questions, please? You may raise your hand or please feel free to unmute. Yeah. Dr. Mohanty, I just have, a couple of suggestions. The log to fold change greater than 3 is way too stringent, even if you get so many differential express genes. Basically, the idea here is even if you take the PAGs or even if you get, some other biomarkers of interest, probably the whole idea of, doing or performing RNA-seq is defeated here. The thing is between 2 and 3 or between 1 and 3 or between 1.5 and 3 log to fold change, you might get a lot of non-coding RNAs which might fall amid those particular log to fold change. So maybe if you can be less stringent enough, that would probably allow you to identify better biomarkers than taking the whole lot of taking the stringency level to greater than 3. Yeah.
Yeah, that is very true. Whatever you are telling, that is very true. We focus because our approach was two. First thing, if you get very some of the genes or proteins are very highly upregulated, probably they can be one biomarker. And second thing, as you're telling, there are many proteins which may be unique, which may be expressed a little low level, and they can be good biomarker. I accept. Thank you. Thank you for this.
Yeah. Thank you. Thank you so much. And I have few other suggestions, but keeping in brevity of time, we'll just move to the next thing. So let's thank the speaker, with a thumping round of applause, please. Thank you so much, Dr. Mohanty. Moving to the next, I just take a great pleasure in I take a great pleasure in introducing Subhanakar Ure. I'm sorry for this background noise. I'm sorry for this background noise. I was also logged in other screen as well. Yeah. So Subhu is an associate professor at Lovely Professional University, and he has been. I'm really sorry. I'm getting a lot of echo for some reason. 1 minute. Could you please stop sharing your screen, Professor Mohanty? I'm sorry, I don't know why it's meeting all 1 minute. Yeah. Yeah, so I just muted all. So I'm really sorry for this. So I take great pleasure in introducing Subhanakar Ure, who is my friend as well. Subbu is a PhD from Osmania University Department of Genetics from 2006. And then he went on to gain his postdoctoral years of experience in Korea. And he was also a kind of an ICMR postdoctoral fellow. He received several accolades and awards. The best, we could think is the best post presentation during Association of Microbiologists of India in 2020, and Centenary ICMR Postdoctoral Award, and Best Teacher Award during 2006 at BR Engineering College in Mohinabad. He has more than 25 publications till today, and his main forte is clinical cancer genetics, cancer epidemiology, and translational genomics. He's also a secretary of BioPlus. Subbu, over to you, please. Yeah.
Thank you, Prash. I'm not able to share it. I think there is some.
How about now? You're already a co-host.
Yes, yes. I'm trying to share my screen. It's asking for system preferences. Prash, can I just share the PPT with you so that you can present? Is it fine?
Yeah, please, yeah.
Yeah, I'll just do that. Just give me 1 minute, please. I'm sorry for the delay.
Yeah, basically, you should be able to share your screen, so I don't know why. Yeah.
Yeah, that's the problem.
So Subbu is going to give his talk on whole exome sequencing of cervical cancer. Reveals interesting mutations, which his lab has been doing.
Yeah, just 10-15 seconds, Prash. I'm sorry for the delay. I don't know, like, what's the problem. Yeah. Yeah, Prash, I've sent you. Thank you. Yeah, sorry for delay.
So I'll make it full screen, Subbu. Just keep telling me, okay? Yeah.
Yeah, please. Thank you so much, Prash. Yeah. Thank you, President ISSRF, Dr. Nirmal Lohia, sir, convener, Ansari, and then Organizing Secretary Barka. Thank you so much for patiently waiting for my abstract. And thank you, Prash, for allowing me to present myself. Yeah, so when we just try and understand with regard to my topic would be on whole exome sequencing of cervical carcinomas, identifies and activating mutations with regard to cervical cancer. Now, which are part of the therapy, targets therapy. Now, when we try and understand with regard into this concept, I would like to just have a brief saying that despite having an effective prophylactic vaccines, cervical cancer remains the second most common diagnosed cancer in women. It accounts for more than 250,000 deaths worldwide every year. So it's like there is a persistent infection. When you see the etiology, more than 90% of cervical cancer is like a persistent infection with a high risk human papillomavirus types. This is HPV. And when we talk about high risk, we talk about the most prevalent is HPV 16 and HPV 18 that basically looked at. And it progressively will leading to a kind of genomic instability and the accumulation of molecular alterations. When you try and see about cervical here, there are genetic and epigenetic aspects. The abnormalities that includes dysregulation of DNA repair system, failure of cell cycle checkpoints, failure of apoptosis, failure of tumor suppressor genes. So it's all about failure and activation of oncogenic mutations, which will predispose in the development of the cervical cancer. And it's a combination of all the things that taken into consideration. Now, the transformation of precancerous to cervix to cancer development. Now, screening is like it's an important point to be designed to detect the early precancerous lesions so that some kind of biomarkers can be identified. So we try and did some work, a pilot kind of study with regard to the whole exome sequencing. Yeah, next slide, please. Yeah. So when we look at according to the WHO and the Globocon, we're able to see with respect to the females, like the incidence, the mortality. Worldwide, to see the fourth place with regarding to, and then in India, we see 96,902, which stands second from Indian perspective. And the mortality rate is also very high when you see the worldwide as well as, and from Indian point of view. Worldwide, it's fourth place in India, second place. So we are trying to understand this preview, like worldwide, globally, when we see every 8th minute, a person with cervical cancer is leading to death. Yeah, next slide, please. So we are trying to do something based upon to address certain aspects. We have recently published a paper with Advanced Cancer Biology, a kind of a comprehensive review where we try to show what are the treatment strategies, treatment modalities that can be taken care. Now, as I said, like according to World WHO, every 8 minutes a woman dies of cervical cancer globally, which is quite alarming. So thank you. Next slide, Prash. Yeah, there are multiple risk factors which are associated, like having HIV virus that causes AIDS or another condition that makes it more harder for your body to fight off. So it's more like susceptibility, that kind of environment that basically helps in developing this particular cervical cancer per se. So taking of birth control pills for a long time, 5 or more years, having several sexual partners, no hygiene and cleanliness, that this eventually basically leads to a kind of STDs. Yeah, thank you, Prash. Next slide, please. Yeah, so as a part of the study, we have tried to take samples with regard to the cervix from a hospital, where we have 5 tumor cervix samples and 5 surrounding tissues. They are formalin fixed tumor tissue samples and the surrounding tissue as well. And then it has been subjected for DNA isolation, then to whole exome sequencing, and then followed by the data analysis that has been carried out. Now, this is a schematic view to represent like what exactly has been done as a part of the study. Yeah, thank you. Next. Yeah, so this is a kind of a bioinformatics pipeline that has been benchmarked like with the Prash, where we're trying to do something based upon NGS data pre-processing, then talking about the variant discovery. Then we try to do some kind of prioritization where we used the raw reads then followed with a quality check, then the alignment has been subjected. The same pre-processing data has been sent for the variant discovery, which have been used a pipeline where we did from SAM to BAM, then sorting has been done, indexing, and then prepare for BAM files, then we went for variant calling. And it's all about prioritizing the kind of the important various variants that is being required. So we try to use something called as sure select, the NGS enrichment workflow, which is being taken from NGS technologies. Like the genomic location of interest was taken into consideration. Then we try to design the target sequences by using the capture library. We use a kind of V5 UTI target enrichment analysis. Then further, next slide, please, Mash. There's some kind of raw rates of tumor samples of the tumor as well as the surrounding tissues that we have taken into consideration by using a command line, Linux command line based work. So there are the FOSQ files that are being used for processing of the files, where we have seen 100x coverage to get the best possible variants. Thank you. Next slide. Next slide. These are a few kind of studies which we have done from surrounding tissue and then from a tumor tissues as well. So we got a better read when we tried to see that, and we got excellent reads, read length as well. So these are kind of samples that we taken with regard to the GC percentage, the sequence length. So the base quality have been checked thoroughly, like per sequence duplication levels. Everything was as per our, but fewer samples were like we could not get a better coverage, and the variants could not be seen in one or two samples. Next slide, please. So after variant calling files has been taken, we have both the tumor and surrounding tissues. Then we are subjected for the downstream analysis with regard to SNP nexus, where we try to see those particular variants, which trying to see the clinical significance of the molecules that is being taken into consideration. So in this particular aspect, hello, Prash, is audible? Where we
I'm sorry for the background noise, and I'm just muting my microphone. 1 minute, please.
Fine, not a problem. So when we try and go through the SNP nexus, then we moved on to doing Guillain-Barre to see the clinically significance of the samples. Then we move on to GURP score, which talks about the evolutionary point, and CAT score, so that we get a kind of hello, is I'm audible? Hello?
Yes, please.
Oh,
please
sorry. Thank you, because I was a bit confused. So we try to use something called as GURP, where we try to do the rate profiling. It's like a method for for producing position-specific estimates of evolutionary constraints using maximum likelihood method. So then we moved on to something called as CAT score, more than 10. Then it is combined annotation dependent depletion phenomena that scores the predicted deleterious the single nucleotide polymorphisms, the variants, or the insertions or deletions which are present in the human genome. By integrating the multiple annotations, including the conversation functional information into one. Then we further move on to know what are the common variants that has been come by using Venni to see the common variants. Then we visualized by using IGV browser, integrated genome viewer, to view our things. Prash, next slide. So this is to just look at the common variants which are being seen in both the surrounding tissues and with regarding to the tumor tissues, where you could able to clearly see here we got around 6 to 7 variants which have been seen in the tumor tissues, with regard to T1, T3, and T5 samples. T5 was excluded from the study because we could not get the best coverage possible. So these are the kind of samples that we take with regard to the GURP score that what I was talking about. So there are different kind of variations. We're taking the positions of the chromosome positions by using ensemble and related tools to validate the study. So as a part of that, you can able to see the gene list, which are shown some novel mutations, pathogenic variants across some genes. Talking about KM2C and ORI41 and F41 PDPR2P. So they shown a kind of more pathogenic variants which might be which are also present in the coding regions of the sequences. And we have seen with regard to the populations, like the Mendel frequency was taken into consideration where it is less than 0.05 significant. So that's where we try to confirm from genome AD. Okay, and then we checked with the CleanWare to confidently say whatever that the molecules have been taken into consideration has shown some excellent results. So the significant exome variants were observed under this particular study. It's something like KM2C, a lysine methylase transferase, which is a protein encoding gene has been seen, and you have a list of other genes as well. So due to the brevity of time, I'll be more talking about KM2C, which is also known as MML3. It is part of mixed lineage in leukemia. It has been observed for the first time. There are a lot of studies has been done, but from an Indian perspective, I think it's first of its kind to work on this particular study type. And I'll be more focusing on KM2C in the coming slides. Yeah, thank you, Prash. Next slide. Yeah, so as a part of the interactome, as I told you, we have taken all the set of genes which are shown some pathological variants with regard to the particular gene. Then we try to see how this, we try to build a kind of interactome network by using Gene Mania. Then you can able to see whatever the genes that have been taken. So they underwent very well co-expressed genes which are present at 76.10%. And you also see some kind of physical interactions within it's around 14%. And then we moved on to look at what are the associated with respect to KM2C. We try to see the kind of variants which are being available. We see something like they are associated with proliferative signaling pathway. We see something based upon inflammation related pathway. We have seen tumor necrosis factor pathways which are being associated, and the physical interactants within the KM2C is passed around 70+% has been seen with regarding to KM2C. It shows that it's a most important potential biomarker that can be really targeted upon. Yeah, next slide, please, Vash. Yeah, so these are the kind of studies that we basically seen how the proliferation is being associated with the KM2C. So when you see something called as PAK3C, the mutations, the mostly frequent oncogenic mutations has shown the presence of this particular KM2C along with the KM2 family as well. And you see these are all more like epigenetic markers which are most impacting the growth of the disease. And further, we also see some kind of studies where we have seen, as I said, it's a protein coding gene. We see something kind of when we observed this variant is basically present in the missense mutation, and obviously missense mutations will always alter the protein, and it may be a kind of more burden that is being shown on the disease development. Now this is a KM2C structure that we're trying to just show. And it has got a catalytic unit of this complex and involved in acute leukemogenesis, bladder, breast, colon, and cervical. And it has also involved in a kind of developmental disorders. Then it contains around 60 exons and span more than 216 kb. It is preceded in 5' region by 1.5 kb in CpG islands. The isoform 2 of ML3 lacks the first 14 exons. So we try to take a best possible fit of this particular structure to do a kind of docking with regard to this, with what are the possible tools that is available. Yeah, next slide. And when you try and see with regard to the hallmarks of cancer, basically KMT2C, it basically promotes proliferative signaling, it promotes suppression of the growth, and simultaneously it is also responsible in the cell replicative mortality, then move on to invasion and then metastasis, and then which leads to genomic instability and mutations. So which depicts like the kind of mutations that is basically seen, the mutation, the number of copies, number of studies that have been done in Cosmic database. It shows very evident that KMT2C, which also reports say that it's basically acts as a tumor suppressor gene as well. So this might be one of the important marker that need to be taken into consideration. Yeah. So these are a kind of a small docking that has been performed like today, like just recently. We have seen based upon the binding energy of the kilocalories per mole, we've seen like busulfan A, butylene, and scopostatin has shown a better binding affinities with regard to KMT2C. Yeah, thank you. So there are kind of images that has been docked. Yeah. Thank you, Pash. Yeah, this is a kind of expression profiling that has been done to see the significance of this particular gene, KMT2C. The expression profiles across all the tumors which are and the paired normal tissues. So expression of KMT2C with cervical carcinoma, it has shown a larger scale, larger expression profiling and interacting point with regarding to the elevated expression of a gene which has been seen across almost in all the tumor types that has been seen here. So it might be one of the marker that can be taken care with respect to some kind of immune related aspects. Yeah, next slide, Prash. Because it is associated when we're trying to see with regarding to KMT2C, it is also shown to be associated with something called as tumor mutational burden. Recent publication, I'll just come to that point. Yeah, this is with regarding to a kind of IGV that we basically used. KMT2C is the most common SNV that across been seen with regard to this chromosomal number. It's proved to be a novel mutation and a pathogenic, which of course it's a coding region. It's a missense mutation which may alter the mutational type. Yeah. So yeah, next slide, Prash. So this is a slide which I was talking about. The Journal of Clinical Oncology says that there is an association of KMT2C mutations with a favorable outcomes with immune checkpoint inhibitors across multiple tumor types. So the study has been conducted in China, in Chinese population. It's a cohort study, which they try to look at this harboring of this particular mutation. And one more study which has been done at Memorial Sloan Kettering Cancer Center. Even they had got a more like a similar kind of the mutation ratio which has been seen. It's more like a TMB. We talk about tumor mutational burden that is basically been observed with regarding to the sensitivity to immune checkpoint inhibitors by modulating the immune environment. So KMT mutation shows an impressive association with the efficacy of ICICs, and it has it's a mutant that group that has got a higher TMB and PDL1 expression that has been seen into the study, and even it has been shown association with microsatellite instability with regard to colon cancer as well. Now we try and say that the pattern of the intratumor heterogeneity is a consequence of how the tumor grow in general, and KMT2C has shown an influence as a potential biomarker in solid tumor carcinogenesis, cancer development. It is indicated that KMT2C mutational may serve as a good prognostic marker for doing the ICI benefit in patients with multiple cancer types. Multicentric study needs to be done to establish a significant to establish from Indian perspective. It is important that we need to work on a larger sample size that may give a more inputs to study on this particular marker. Yeah, with this, I thank you one and all for this wonderful opportunity, and I acknowledge ISRF for this wonderful opportunity, especially President Dr. Nirmal Lohia sir, then Convener Ansari, Organizing Secretary Barka, and all my mentors who've been teaching me from my MSc, and Prashant Suravarjala, my friend, my guide. I can say a lot more things about him, but yeah, for his completely unconditional support in the data analysis, whatever the bash command line, what have been used, was being supported by Prash, completely relentlessly working with me and my PhD student. So thank you Prash, for your wonderful inputs. And then he's a principal investigator at Amrita University and is a founder of BioClues, the society which talks about mentor-mentor relationships and trying to bring bioinformatics in India. So thank you so much, Prash. And my PhD scholars, Santosh Kumari, who's basically working on this particular study, and Sadbir, Buman are part of my PhD scholars. And my MTech student, Anprit, is also part of this particular small study that she has able to do. And my great regards to my university, LP, for the constant support. And thank you one and all. So this is the last quote which I always remember. And the more I study, the more I learn and observe, the more I realize how too little I know. So it's been given by Steve Marabole. It's one of the things that I always admire, and I look forward to learn certain things in life. Yeah. Yeah, thank you.
Perfect. Thank you. Thank you so much, Subbu, for sticking on time. The room is open for Q&A, please. Yeah. Any questions, please? Yeah.
One thing is that they understood, they have not understood something. Yeah.
If not, thank you, Subino, for the wonderful talk. Dear participants, now please give a thumping round of applause to Subbu. Thank you, Subino, for this scintillating talk. Yeah. So we move on to the next speaker. So we have Professor Luna Samantha, who is a professor in zoology at Ravinshaw University in Cuttack, Odisha. Her research interests coalesces redox regulation and proteomic markers of male sterility. She has been awarded visiting facultyship at American Center for Reproductive Medicine in Cleveland, Ohio. Raman postdoctoral fellowship USA between 2014 and 15 in the same institute. Commonwealth Academic Staff Fellowship in 2012 from Imperial College London. She was a recipient of ISCA Young Scientist Award in 2003 by Indian Science Congress Association. She also received prestigious KKNI Prize for Outstanding Research Publications in 1999 from University of Kerala, and also Young Scientist Award in 1997 from Government of Odisha. So she has more than 60 publications to her credit, and she's going to give a talk on semen proteomics in understanding the male infertility as a women's health issue. Professor Samantha, please. Yeah.
Thank you, Dr. Prashant, for this nice welcome, and I'm really humble. So at the outset, I would like to convey my greetings from Ravinshaw University to all the organizers, Professor Nirmal Lohia, Dr. Ansari, Dr. Barka, and the esteemed chairpersons, Padmashri, Dr. Madan, and yourself, Dr. Prashant, and all the participants who are attending this webinar or the conference in the webinar mode. So let me present my screen. Yeah. Am I visible to all? Are my slides visible to all?
Yes, please make it full screen. Thank you.
So, yeah. So Actually, when everyone is speaking on either side of the story, it is something unusual title to discuss about. So where we wish to look into our women's health issue in terms of male infertility. So when you talk about infertility, it is never one-sided. So that's why we wanted to analyze what is the difference and how to address it. So if you look into the potential infertility diagnosis and treatment, it is always biased towards the women. That is because of the close association of the conceptus with the mother. So if you see anything out of the, whether it is a tubal factor, okay, it's a women's problem. But if it is varicocele, azoospermia, or when you're normogospermic patients, or oligospermia, or asthenospermia, so what happens? People advice for TACI or PISA or microsurgical sperm aspiration. But at the end of the day, when you follow the IVF or ICSI protocol, the woman is in the suffering end. She has to undergo through so much of hormonal stimulations, and sometimes even may succumb to ovarian hyperstimulation syndrome. So for that, it is always biased towards the women. Why is it so? Because of our poor understanding of male infertility. So men are as likely as women to contribute to the infertility problem. So that's why all the leading policymakers of the world are now asking the same question. Are the semen tests other than the WHO parameters useful in evaluating male infertility? Because WHO parameter only gives an idea about the sperm structure, motility, and its concentration. It doesn't give you any insight into whether a good-looking, highly motile sperm is actually able
Dr.
to
Samantha,
fertilize the
I
ovum.
apologize for interrupting you, please. Your screen, maybe kept as a full screen, please.
It is
And the
already in
slides
a full screen.
No, unfortunately not. We cannot see your screens now moving. Yeah.
It's moving?
The slides moving. No.
Yeah. But I have made it full screen.
No, now we could see. No, it's not full screen. Yeah, it's not full screen. Yeah, it's okay. Yeah, you can just move. Yeah, you can just
it's
move
a full screen now? Yeah.
No, it's not.
Is it a
It's
full
not full
screen
screen.
now?
It's still slide mode. It's only slide sorter mode, but it's okay. You can just go ahead. Yeah, you can just move the up and down arrow button, to move to the next slide.
Yeah.
Thank you.
So both the International Priority Setting Partnership for Infertility, which is an ISRA initiative for focus on reproduction, as well as ISSRF and the National Institute for Excellence in Health, Clinical Health, is from UK, and Michigan Action Plan for Fertility and ART, all of them have recommended for an in-depth analysis of main factor infertility to address this problem. So then why we choose, and what is the best thing to do about this women's disease? So we chose idiopathic recurrent pregnancy loss. Why? Because for a mother, losing a baby midway through the pregnancy is so traumatic that only those who have experienced this can explain it in a better way. So spontaneous recurrent pregnancy loss is defined as 2 or more pregnancy loss during the first 20 weeks of pregnancy, and it includes embryonic and fetal losses, both embryonic and fetal losses, and it affects 2.5% of the women, and up to 50% of these cases do not have any clear defined etiology. And RPL is often investigated only in the women's perspective, where sometimes it is actually a combination of different things, like your antibody, apolipoprotein antibody screening, your paternal or maternal karyotyping, then the karyotyping of the expelled conceptors, like that. But except barring where there is a chromosomal anomalies, in no other way you are able to analyze the real cause behind the. So are my screen visible? Is my screen visible?
Yes,
is my
please,
screen visible? Yes.
Yes, please, but you're in the third slide, I believe. It says men are as likely as women for infertility.
Yes, thank you. Thank you. So recent evidences show the involvement of the male factor. So this is the histone retention and oxidative predominance from our lab, and that from the Dr. Drew's lab regarding DNA fragmentation. Also, that the paternal factors may be involved. So we started our the background of this work was initially started way back in 2014-15 when one of my PhD students worked on this. So as Dr. Malini has told that you need to know about which free radical is involved in which function. But the sole problem with human sample is that after the ejaculation, the sperm, semen instantly coagulates, and it takes 10 to 30 minutes to liquefy. So by that time, since the free radicals have a pretty small half-life, less than micromilliseconds or microseconds, it is almost impossible. So therefore, we focused on the endpoint assay on all the biomolecules, DNA, protein, lipid, then the protein modification and so on, like the lipid peroxidation, protein and non-protein sulfidal groups, protein carbonylation, along with all the seminal plasma antioxidant enzymes to find out. And then we do a logistic regression analysis, which show that histone retention, protein oxidative modification, and lipid peroxidation in the spermatozoa might play a probable role in recurrent pregnancy loss. But all these things are the consequences, not the causes. So that why the proteomics? Because spermatozoa, despite being transcriptionally and translationally dormant, undergoes several modifications.
I apologize. I apologize for interrupting you. I'm afraid that your slides are not moving, please. I think you're talking about your slide. Can you stop sharing and reshare your screen, please? Yeah.
Okay, sure.
Yeah. Now we could see why proteomics. Yeah.
Is it now visible?
Yeah, the screen is visible, but not your slides. Yeah.
Yeah. Is it okay now?
No, your slides are not visible.
No, your slides are not visible. Yeah.
I don't understand what is. Why? Let me stop again. Sorry for the interruptions. I don't know why. Is it okay now?
Yeah.
Yeah.
Can you simply press full screen or simply press F5? Yeah.
Yeah.
And then please go ahead.
Yeah. So, but besides this limited power of transcription and translation, the sperm protein changes during its passage in the epididymis as well as after the ejaculation event. So the role of seminal plasma proteins were neglected all after the discovery of your ART technologies, because they are only a spermatozoa, on a single spermatozoa which can be injected inside the oocyte, harvested oocytes can do the business. So the people thought that. But despite this technology, also the pregnancy outcome take home baby rate in the ART program is not that improved. So many proteins and RNAs are associated with extracellular vesicles and are known to selectively transfer to and out of the sperm that modifies sperm function. So with this background, we wanted to do a proteomic analysis of the spermatozoa, seminal plasma, as well as seminal extracellular vesicles to find out a probable answer to the question. So the first thing we did, because as the funding resources are available and as the technology developed, so we first started with our in-house 2D electrophoresis system. So where we found more than 22.
Dr. Samantha, I'm really sorry. You're still in your proteomics slide. I don't know, for some reasons, we're not able to see it. Yeah.
Huh? Okay, just a minute, give it few seconds, so I'll move on to another connection so that it may work properly. Just a minute.
It may not be about the connection. I think, it's something to do with your browser. Sometimes, it happens. Maybe, I don't know, when you're sharing your screen, are you making full screen or only a window?
No, I'm making it a full screen.
Don't make a full screen. It will not work. Just remain in the slide mode. It will work.
Okay. Is it working now?
Move it up and down. Yeah, it is working.
Yes.
Yeah, maybe please don't use your keyboard. Maybe you can use your mouse, to move to
Yes,
the next
I'm using
slide.
mouse. I'm using
Now it is
my mouse.
working. Now it
Yes.
is working.
Now, okay. So probably in the full screen mode, it is not working. Yeah. So what we did is that in the first case, when we started with our 2D electrophoresis and then the mass spectrophotometric analysis of the identified protein, we only took, because of the lack of funds, only we took those proteins were highly overexpressed or highly underexpressed from the densitometry, and then found that it is glutathione peroxidase, JIP4, then your JN318, and then transcription factor 3C1, as well as your CCNA molecules. So the first thing is that why is this thing? Okay, glutathione peroxidase 4 and the HSP A2. Okay, those are involved in oxidative stress regulation. But what about the other ones? So here we found that this JIP4, which is a scaffold protein for JNK kind signaling pathway, is also regulated by HSP-A2. So that's what we propose from this differential expression of these proteins, is that the histone retention, the oxidative stress, and DNA fragmentation, which we observed in our previous experiment, is basically due to modification of these proteins in the testicular environment, thereby induces this oxidative stress, which leads to fragmentation of the DNA. And this fragmented DNA containing spermatozoa, when fertilization oocyte, it develops into an abnormal embryo, which is not able to continue till the end of pregnancy. But still, we have in mind. So out of these 22 proteins, we could only mass spec only 7 proteins. So we already always have a back of our mind, probably other proteins could have given us a better idea. So when we had some more number of samples, we moved on to LCMS time of flight mass spectroscopy protocol, where we find 23 differentially expressed proteins, out of which 15 are upregulated, 3 are downregulated, and 2 are unique to the fertile control group, and 2 are unique to the recurrent pregnancy loss group. Out of this, when you focus on oxidative stress and DNA damage, this particular, although there are these 23 differentially expressed proteins, clustering expression was more than 12-fold in comparison to others, which are 2 or 3-fold increase with a probability value of 0.05, as well as the abundance in the assay system. So in this case, what we propose that this clustering, which is a multifunction protein, is capable of protecting the spermatozoa from the DNA damage and epigenetic modifications, which is downregulated in RPL case, and thereby it is not producing a good spermatozoa capable of fertilization and subsequent expression. So subsequent continuation. This clustering also is responsible for apoptotic degradation of the chaperones and all. So probably that is the reason why it is not so. But a single protein or the 7 protein profiling may not be an answer to such a complicated problem of recurrent pregnancy loss. So subsequently, what we did, we tried to know that whether the seminal extracellular vesicle has something to say about it. So because the seminal extracellular vesicles are the vesicles which are generated by the male reproductive tract as well as the spermatozoa, which may carry in and out certain materials, which may be RNA, which may be protein, or other factors as well. So here what we found is that the global seminal extracellular vesicle proteomic profiling shows us that there is a downregulation of proteins which are reported to prevent the oxidative stress, and there are proteins which are principally involved in DNA repair and DNA damage, like DGX1, your HNRNP U and HNRNP-C, RUVVLB1, and all these histones, the testis-specific histones, and then RNA binding protein and SNPO1, which are all involved in DNA damage repair methods, are differentially expressed in these exosomes or extracellular vesicles. So what does it convey? It conveys that, okay, there is DNA damage, and it might be a testicular event, or it might be during the maturation process of epidermal transit, and these are there as remnants of the already happening events. So from there, we constructed a Hop gene analysis, and this Hop gene analysis yielded 3 important DNA damage proteins, that is HNRNP-C, HNRNP-U, and RUBBL1. So, and these expressions you can easily see here, which we validated through Western blot after conducting the gene mania analysis, as well as your IPA in ingenuity pathway analysis, and validated that through the Western blot. So our mass spec data exactly match that with the Western blot data. And here also you can see, when you segregated the differentially expressed proteins and do a principal component analysis as well as a heat map, the RPL group significantly segregated from that of the fertile control group. We use fertile control, not the normogynemic one, just as to know where there is a full-term baby outcome and where there is a pregnancy loss in between. So then, after these things, we wanted to do a comparative proteomics analysis of all the components, that is your spermatozoa, seminal exosomal vesicles, as well as exosome-free spermatozoa. This is seminal plasma. So all the 3 separate components we analyzed so as to find out if there is any correlation between any one of them. So what to us surprise, what we find that most often the immunological pathways, both innate as well as acquired immunological pathways, so as to the toll-like receptor signaling pathway, are all differentially expressed, are the most important significant pathway analysis found through cytoscape pathway analysis. So, and I'm not going to discuss more about it, because this will be discussed tomorrow by my student Dr. Somya, who is the recipient of GP Solver Award for this year. And here we again, from this data, we compare the differentially expressed proteins so as to say whether our mass spec data is matching with our Western blot analysis. Because sometimes what happens, because of the similarity between the proteins, sometimes they don't match with each other. But here we find a concordance with our mass spec data with that of the Western blot data. So here what we found, that in all the 3 experiments, one protein is constant, which is differentially expressed, is your testis-specific chaperone feed subprotein A2 or HSP-A2. And this is not only we find here, in our previous studies as well, with idiopathic infertility in males or the varicocele males, and even while studying the different differentially matured spermatozoa by segregating the spermatozoa in a density gradient, that this particular protein is differentially expressed in all these cases. So therefore, we wanted to know if there is a clue to it, and we did a non-synonymous SNP analysis, and this is the concept data. We saw the highly variable regions or the mutability regions depending upon the structure and function of HSP-A2, and from that we also did a gene mania analysis, where we wanted to show the different pathways those are interrelated or responsible for the mutated HSP-A2 gene. And this, what we find out here is that again, DNA damage, oxidative stress, normal cellular metabolism, morphogenesis, and immunological signaling are affected by this particular differential expression of HSP-A2 gene. HSP-A2 gene plays different roles in the spermatozoa, starting from cholesterol efflux during acrotome reaction to fusion with I-Juno fusion by activating the BAC, or by even your signaling the JNK pathway, thereby modulating the female reproductive tract, so as to accept this allogenic, so as to minimize allogenic rejection of the concept. So with this, we think that it could be a like the clustering, which is also a functional protein, and this HSP-A2, these two can be a good markers for that. So to take home message is that the oxidative stress and DNA damage may be the markers, but they are the endpoint. What are the cause behind that? One of the key findings of the study is that clustering, a predominant oxidative stress protein that takes part in an array of pre and post fertilization molecular processes, which is found to be underexpressed in RPL patients, which was confirmed by Western blot, may be a marker. Besides that, this glutathione peroxidase 4, this is actually the phospholipid hydroperoxide glutathione peroxidase, which is attached with the nucleus of this spermatozoa, thereby prevents these from the DNA damage due to redox phenomena. This is also downregulated, and this scaffold protein for JNK pathway, and this zinc finger protein, which is responsible for transcription and is also reported to be downregulated in other infantile patients by other workers, are overexpressed, while HSP-A2, GST, glutathione S transferase mu type 5, then transcription factor 3C1, and the CC74A, which is actually the CC74A's role in spermatozoa is not yet known. So it could be a good marker to work on further, so as to find out how it exactly works in conjunction with all this differentially expressed protein. So the differential expression of the complement factor 3, 4A, C4B, CFB, and the GDF15. GDF15 may be involved in altered maternal immune response to paternal antigens, resulting in impaired decidualization. Because what we want to say is that all these proteins which are involved in sperm function may not be totally involved only up to the fertilization. Why we think so? All these immunological factors are significant. That is because it is already established fact that this trophoectodome, when the embryo develops from the fertilized egg, from the morula to after the gastrulation starts, you have the trophoectodome formed, which form the extra embryonic membrane, and the embryo proper, that is the inner cell mass, which is responsible for producing the embryo. But the thing is that here, this trophoectodome, all the genes are predominantly paternal. So the paternal expression of the differentially expression of the genes might be responsible for a allogenic rejection in the long run for differential regulation of the female immune system. So therefore the role of your HSP-A2 cannot be ignored, because this is a chaperone which is responsible for maintaining the proper functional entity of the integrity of the protein, and which is also susceptible to oxidative stress, might be responsible for causing all sorts of this type of differential expression of the protein, or at least the differential activity of these proteins, which leads to recurrent pregnancy loss. So before I conclude, I should like to acknowledge the DST, UGC, and the Higher Education Department of Orissa for funding us, and my group members, Gayatri, Nilipta, Somyaranjan, Jasmine, and Shugan. These are all their PhD or MPhil works which I accumulated, so it all goes to them. And my collaborator, Dr. Srijata Kar, the IVF specialist, who provided us with all the samples, and Dr. Ansuman Dikshit from DBT ILS for helping us in bioinformatic analysis by using the Ingenuity pathway analysis software. And I will fail to complete my responsibility if I do not thank enough profusely ISSRF for encouraging our young minds. Gayatri for NR Modkal Young Scientist Award in 2017, Somyaranjan for Best Paper in 2018, and this year again Somyaranjan for the GP Talwar prestigious award, Young Scientist Award. So with these words, I would like to take any questions. Thank you all.
Thank you. Thank you, Dr. Luna, for an excellent presentation. The room is open for Q&A. Dr. Pradeep of IGCB Trivandrum has a question. Yeah, you have raised your hand, sir. Please, yeah.
Yeah. Hi, Luna.
Thank you, sir. You're most welcome.
Great talk. So I thought I will ask you this question. So you had all those seminal plasma exosomal proteins which were differentially displayed in people with recurrent pregnancy loss. So these proteins, are they are any of those proteins present on the sperm?
Yes, sir. We have already done that in our experiment. I can show it to you here.
No,
I have this comparative one.
Go back. Yeah. So they are of so
actually they are different. There are certain proteins which are upregulated in spermatozoa, but they are not present in the exosome. And there are certain proteins which are abundantly present in the exosome, but absent in the spermatozoa.
So do you mean
so we did a complete?
Yeah. So you mean these exosomal proteins, do they have anything to do with pregnancy ultimately?
Yes, sir. What I find that this transfer of histones, because initially when we found that these RPL patients have a more than 30% retention of the histones, because usually histones are 15% in the normal mature spermatozoa. Here we found more than 30% of histones are retained in RPL patients, and there what we found is that the spermatozoal histones are more, but exosome histones are absent. But whereas in the fertile donors, we found abundance of these histone proteins. Probably they are excluded from the spermatozoa during their maturation process in the epididymis. And they are still present in the ejaculated extracellular vesicles. I'm not saying exactly exosomes because it is a mixture because of the size variation. I have not shown that size variation here. So I can show there are microvesicles, there are exosomes, there are, but we didn't find any apoptotic body.
Great, thank you.
Thank you, sir.
Yeah. So I just have a quick comment, Dr. Luna. I mean, assuming that these are all the differentially expressed proteins, I think, there is also a kind of a demand, to check its analogy for the differentially expressed gene analysis as well. That would, probably allow you to, reach a kind of a consensus. Because not necessarily all the differentially expressed proteins could be taken in analogy to their gene expression patterns. That way, the seminal so-called biomarkers that you would probably call them in terms of HSPA, can be checked for the regulation at the gene expression profile level as well. So
we thank you. We are also looking into that as well. And here I was to clarify that we have taken only density gradient purified spermatozoa, which are morphologically perfect and also highly motile. So as to say that only these are capable of fertilizing and moving up. Because here in RPL, there is not a question of fertilization failure, rather a question of maintenance of the pregnancy. So we will analyze that with the paternal gene expression by either from the blood or the saliva or other samples. We are taking up that project. Thank you for your input, sir.
Yeah, thank you. Excellent talk, Dr. Samantha. The participants, please give a big thumping round of applause to Dr. Luna. Thank you so much.
Thank you, Shobha. Thank you so much.
So could you please stop your screen?
Yes. Can I have a question from this?
Yes, yes, sir.
A quick question, please.
Yeah. Nice presentation, madam. Very nice presentation, madam. I just want to know about this exosomes you isolated from the ejaculated spermatozoa, but not any combination like epididymosomes or prostosomes. Like
actually, I didn't segregate into prostosomes or epididymosomes. Most often the epididymosomes are already absorbed by the time the sperms are ejaculated, but we are taking into consideration based on the size of this thing, and we found 2 or 3 of the epididymosomal proteins in this exosome, extracellular vesicles. I don't say that these are exosomes because we have not purified the exosome. It is an extracellular vesicles, which is a combination of many of things, but they are devoid of apoptotic proteins.
So they are basically extracted from the ejaculated spermatozoa, right?
Ejaculated, because in the human there is no other way to do it.
Yeah. Thank you.
Thank you again, Dr. Luna. Thank you so much. So moving further, we have Dr. Trimalrao Talluri, who would speak on multi-omic analysis for bull fertility prediction. He comes from ICR National Research Center on Equines. He obtained his PhD from Hanover Institute of Farm. He has had his postdoc from ICR National Dairy Research Institute in Karnal. And his research interest has been into sperm biology, stem cells, and reproductive biotechnologies. He has received several awards now with various distinctions from ICR, TBR Prize Award from Reproductive Biology Society of Poland, Professor S.S. Guraya Young Scientist Award. He was also a DAD CONICET Fellow, and he received Outstanding Scientist Award from NRC. He has more than 83 publications to his credit. Thank you so much, Tirumala. May I request you to stick to about 16 minutes presentation so that we'll have a quick Q&A. Thank you so much.
Thank you, Prashant. I think you deserve me for sharing. Can you please allow me to share?
Oh, yeah, you already have it. I think, yeah, you can do that. You can do that, Tirumala. Let me see that. Yeah, you could do that. I don't know why you're not able to. How about now?
Yeah, now it's okay.
Yeah, please. Yeah, thank you so much. Yeah.
Hope my slides are visible.
Yes, please. Yeah. Make it full screen, please. Yeah, thank you. Yeah.
Is it okay, Prashant?
Yeah, please.
Okay.
Thank you.
Yeah. Thank you, Prashant, and a very good afternoon to the chair of the session, and very good afternoon to all of the participants who are participating in this oral presentation. And at the outset, I would like to thank the organizers of ISSRF and Professor Lohia, sir, President of ISSRF, for selecting my talk as an oral presentation. And without wasting much time, I would like to discuss about my topic. The topic is multi-omic analysis for bull fertility prediction. So, with regard to livestock, artificial insemination technique is a very vital management tool that has been percolated through grassroots for improving the herd productivity. And in this process, we use semen from the breeding bulls, which were selected based on a particular method and inseminated in the large number of females. So at this stage, the fertility of the bull is very important because the semen from this single ejaculate or from single bull is going to be inseminated in several and thousands of animals, which may, if we make any mistake in selecting the right bull or fertile bull, that may cause colossal loss to the dairy industry. So at this juncture, so identification of a fertile bull or competent bull which has which can produce healthy sperm or competent spermatozoa that can accomplish successful fertilization to further carry on the embryo to the term. That is very important. So currently the breeding sound evaluation technique is there, in which they only select the bulls, breeding bulls based on the physical considerations and very few, by estimating the few parameters like motility and morphology. So the current estimation, semen evaluation methods are like light microscopy, and with the advancement of CASA, we can also measure the kinematic parameters and the morphological parameters. And with the advent of flow cytometry, we can measure some more handful of sperm functional parameters. But unfortunate to say that these combining all these equipments and methods, also we are unable to detect or find out a single method through which we can directly select a fertile bull. So there is a need to, there is an urgency to select a marker or to designate or to select a fertile bull which can have the healthy sperm, that is that it can have the both physiologically, functionally, and biologically active sperm that can successfully accomplish the fertilization. So nowadays, with the upcoming of the novel sequencing platforms, we can through advent of genomics, proteomics, and the and transcriptomics, proteomics, and metabolomics, we can analyze and we can study more comprehensively the biological reactions that are responsible for making the spermatozoa fertile or that can accomplish the fertilization. So for this study, we have nearly selected, procured the semen from the 50 HF crossbred bulls, that is Holstein Friesian crossbred bulls, whose we have divided these bulls into the two groups as high fertile and low fertile based on their conception ratio. And these bulls are vastly used for performing the A, and the A ranges from 841 to 2071 with an average of 1351 per bull. And we have procured the frozen semen from these bulls, and we have assessed the semen quality of these bulls by using the fluorescent dyes like CyberPA for the viability assessment, FCPNA for the acrosome integrity, and JC1 for the mitochondrial membrane potential. And for assessment to the intracellular calcium, we have the flow3 and mitochondrial ROS through the mitosox. And further, we subjected the semen from these bulls, frozen semen from these bulls for the transcriptomics, proteomics, and metabolomic analysis. And we further integrated all these outcomes of the analysis, and we try to come to a conclusion point, or we can develop a marker out of this these three integratomics. So we also analyze these functional parameters through fluorescent microscopy, which we analyze the viability, MMP, intracellular calcium, and this acrosome integrity and ROS and the apoptotic status of these spermatozoa from the high and low fertile bulls. And through flow cytometry also we could evaluate all these parameters. And we found that there is a significant difference between the membrane intactness, acrosome integrity, and mitochondrial membrane potential between these low fertile and high fertile bulls. Further, we subjected this spermatozoa for the transcriptomic analysis, wherein which we got around 18,000 transcripts overall in crossfit bull spermatozoa, out of which 409 are unique to the high fertile and 1,000 are unique to the low fertile spermatozoa. And we again subjected these things to the bioinformatic analysis, through which we could isolate dysregulated genes, which are around 383 were found to be significantly dysregulated between the in the low fertile bull spermatozoa. And we subjected these transcript through the volcano plot also based on this log to fold change expression, in which we found that there is a clear difference between the genes expressed in the high and low fertile bulls. And further, through gene ontology also we could see that various the molecular functions and biological functions and the cellular components which are displayed here, and the dysregulated genes are mostly upregulated in various important activities like apoptosis, sperm motility, and also the protein folding. So through KEGG enrichment pathway also we found that the more dysregulated genes, that is DAG, are mostly expressed in case in ribosomes, or they are part of spliceosomes and the AMPK pathway. And when we plot the network between the geotomes and KEGG analysis, we found the major dysregulated genes are found in regulating the sperm motility and ATP binding and the hormone mediated pathways. So these are the list of the top 10 upregulated proteins which are majorly responsible for ATP binding and actin filament organization and apoptotic pathways. And if you can see the top down-regulated proteins in case of low fertile bulls, which are majorly responsible for biological functions like mitochondrial activity, ATP binding, and protein ubiquitination. So this may be the reason for the cause of the low fertility bulls if you analyze this through a transcriptomic way. And further, we also subjected these samples for the proteomic analysis, out of which we found nearly 5,000 proteins when the crossfit bull for spermatozoa, out of which around 785 were found to be dysregulated. These samples are also processed in the same way, and which we also found that through volcano plot we can differentiate clearly the expression of the low fertile genes response, genes expression in low fertile and high fertile bulls into two different groups. And the gene ontology also revealed that many of the genes which are responsible for the oxidation reduction pathway and metabolic pathway genes are found to be completely downregulated in case of low fertile bulls. This also KEGG pathway also revealed the same thing, and the network also revealed the same thing. The genes which are responsible for sperm motility, like here you can see sperm motility, single fertilization, glycogenesis, and gluconeogenesis. These are found to be downregulated in case of low fertile bull spermatozoa. I'll come to the genes which are actually responsible for this kind of pathways. And this is a list of the proteins that were upregulated in case of low fertile spermatozoa. And this is the list of the genes that are found to be downregulated in case of low fertile spermatozoa, which cause the response for main biological functions like sperm motility and mitochondrial function and protein ubiquitination. So further, we made an integrated omic analysis by comparing these transcriptomic data and proteomic data. So ultimately, we are interested to see how much proteins are translated. So we found that there was around 404,000 proteins were translated, and there were some unique proteins that were also found to the high fertile spermatozoa, and we found there is only 182 significantly dysregulated spermatozoa in low fertile bulls. And we further took this 182 translated proteins, dysregulated proteins, and we further analyzed through GO and KEGG analysis, in which we found half of these translated proteins were representing the metabolic pathways. And through network analysis also, we found that the genes responsible for the signal fertilization and sperm motility and the apoptosis were found to be significantly downregulated, upregulated in case of low fertile bull spermatozoa. So coming to the metabolomic analysis, we found there are 56 common metabolites. Totally, we found around 3,700 metabolites existing in the crossbred bull spermatozoa, and among them 33 were found to be significantly dysregulated, and their pathway shows that these significantly dysregulated metabolites are belong to the pyrimidine, taurine, and propionate metabolism and butyrate metabolism. So if you can see, the acetyl-CoA was found to be a major part of this acetyl-CoA. The metabolites like acetyl-CoA, taurine, hypotaurine, cysteine were found to be the major metabolites which have significant relationship with this transcripts and proteins which can influence the motility of the spermatozoa. So we further made an integrated omic analysis by combining the transcriptomics, proteomics, and the metabolomics. So here we can see the interaction between the transcripts and the metabolites and the proteins and metabolites by taking an example of methionine and cysteine metabolism, where there's a taurine, cysteine, and hypotaurine are this influential or found to be influential metabolites which can target many proteins, and they are responsible for the influencing the motility of the spermatozoa and the mitochondrial membrane activity. So we have further also made a correlation analysis between the genes with the seminal parameters. We found very significant genes like JUNB and BDH, GCDH, SOCS2 are found to have more positively negative correlation with the sperm motility, and they are found to be upregulated in case of low fertile bull spermatozoa. So in order to summarize the study, we found that the transcripts which are responsible for protein phosphorylation, sperm maturation, and spermatogenesis were found to be downregulated, were found to be upregulated in case of low fertile bulls, and proteins which are contributing to major metabolic pathways like this CDK2, CDC25, GNI1, TEKT3, SLC were found to be responsible for single fertilization motility were found to be downregulated in case of low fertile bulls, and metabolites which are involved in purine metabolism, pyrimidine metabolism, taurine and hypotaurine metabolism are found to be significantly downregulated in case of low fertile bulls. So this is the overall picture that we can see, in which I mentioned the transcripts that are downregulated in case of low fertile bull spermatozoa, and these are the pathways that were found to be maybe causative for the response for influencing the spermatozoal function. And these are the altered metabolites like acetyl-CoA, malate, malic acid, taurine, and hypotaurine, which were responsible found to be downregulated in case of low fertile bull spermatozoa. Sorry for that. So with this, I would like to thank my team, Theriogenology, and for ICR for funding me, and NDRI for providing facilities. And at the last, I would like to thank my mentor, Dr. Kumareshan sir. And nevertheless, I would also like to thank the bulls and semen stations for the pain that have taken for us for donating the semen. Thank you.
Yeah. An excellent talk, Tirumala. Thank you so much. The room is open for Q&A, please. Yeah. If not, I think we should, thank Tirumala, for his scintillating talk with a big round of applause, please. Thank you so much.
Thank you, Prashant.
Yeah, thank you, Tirumala. The name of the lab is very nice. Theriogenology.
Yes,
wonderful.
It was the idea of my mentor,
There is
Dr.
one question in
Kumareshan.
the chat box. Can you please check?
I'm sorry. Yeah. Dr. Sudipta Panda asks, did you have chance to check the multigenomic analysis in between young versus age bull spermatozoas? Yeah.
No, madam, sorry. So that's a good idea, but we'll make it first. Actually, we wanted to find out the whole thing, what is happening around it through multigenomic analysis. So this is sorry, can you hear me, Prashant?
Yeah, very much.
Yeah. So that was the answer.
Yeah, thank you so much, Tirumala. So moving further, we have the final speaker for today, Dr. Sitapa Mukherjee. I apologize. and she would speak on differential effect of dietary fatty acids upon murine testicular function. She hails from Department of Zoology, Shiksha Bhavan Vishwabharati, a central university based in Shantiniketan. She has received several coveted awards, the National Scholarship from Government of India in 1998, National Eligibility Test, she cleared in 2000. She received Sachinarayan Bera Memorial Shield Award in 1998, and between 1998 and 2000. And Professor N.J. Chinoy Prize, a prize for oral presentation in 2005. And she received startup grants from UGC FRPS and Sir BST Major Research Grant. And she has over 10 publications to credit. Please, Dr. Sutapa. Yeah. Thank you so much. You can share your screen. Yeah. Dr. Sutapa.
Hi, Prashant, she was there, but I cannot see her right now.
Yeah, I think maybe we can just wait for 1 or 2 minutes. Yeah.
No,
I just
she
made
was
her
there, but right now I cannot see her.
Yeah, I made her co-host as well. Yeah.
Prashant?
Yeah.
I think Dr. Sutapa, I cannot see her right now. She had joined, but
Yeah, we'll just wait for a couple more minutes, maybe.
Sure.
Hopefully she would join. Yeah.
Okay, sure.
I know it's lunchtime, but I think the delay has come for good reasons. Yeah.
Yeah, it's okay.
We have learned a lot of things.
Yeah,
from these
definitely.
talks, yeah.
I think would somebody have telephoned to her whether she is there or not.
Yeah, sir, we are doing that. Yeah.
Please telephone to her.
Yeah. Prashant, I think you can wrap it up because she's having some internet issue. She's not able to join it. So maybe you can wrap the session. Yeah.
I think we have had 4 wonderful speakers, for the second session. In fact, for the third session, Professor Mohanty's talk was well taken, where they identified PAG as perspective biomarkers, and the wonderful differential expression gene analysis that they have promulgated has yielded wonderful aspartate isoforms in the organism of their interest. The second talk was Sugu, where as a pilot study on whole exome sequencing of cervical cancer patients in Indian subpopulation, came to 2C harboring a couple of mutations has been considered as an early prognostic biomarker for cervical cancer disease phenotype from Indian subpopulations. The third one was again a kind of a scintillating talk from Dr. Luna, where the HSPA biomarkers taking the top-down quantitative proteomic analysis was well taken, and the seminal extracellular vesicular proteins in which these particular biomarkers have been discovered play a wonderful role from their lab works. And the final talk from Tirumala, which was absolutely a kind of a beauty, where there's a big coalescence of both next generation sequencing and as well as proteomics. And I'm sure there will be a wonderful spermatozoan proteomic profile that would really come up taking this bull proteomics. I think we should thank all the speakers with a big round of applause again. And they have really made this session scintillating. I thank Professor Lohia, our mentor, and Professor Ansari and Dr. Barka and Nidhi, for a kind introduction. Thank you so much, one and all. I think we have about 8 minutes now before we move to the next session, which would probably get some quick bite, especially for those organizers in Jaipur. Thank you so much.
Thank you, Prashant, for wonderfully chairing the session, and thank you to all the invited speakers and oral presenters. So we'll be moving ahead because maybe Dr. Sutapa can join us later. So we will utilize this time and then we will move ahead to our next session, which is on fetal reproductive health. I'll just wait we are just sharing the screen. Okay, so our next session is on fetal reproductive health. And for this session, the chairpersons are Dr. B.S. Shah, who is from Dayanand Medical College and Hospital, Ludhiana. Unfortunately, Dr. Shah won't be able to make it. So our next chairperson is Dr. Jayanti Manya, who is Scientist E at ICMR, NIRRCH. And her interest is in the development of immunodiagnostic for diagnosis of RTIs, STIs, and to study the pathogenesis associated with those infections. Welcome, ma'am. And I would request you to kindly chair this session. Thank you, ma'am. Jayanti, ma'am, you have to unmute yourself.
Okay.
Yeah. Thank
Am
you.
I audible?
Yes, ma'am. Absolutely.
So there is 7 minutes to 2 o'clock. I don't know whether the invited speakers are already there or not.
I think
so.
They
We'll
are
go
there.
ahead.
Yeah.
Okay, then we can start. So good afternoon, everyone. I should thank the ISSRF organizing committees and Dr. Lohia, Dr. Ansari, Dr. Sharma for giving this responsibility to conduct this session on fetal reproductive health. And here we have 3 invited speakers and 2 oral presenters. And so it's my pleasure first to invite my colleague, Dr. Nafisa Balasinar, who is working as scientist F at NIRRCH. And we have the pleasure to share 2 international conferences with her. We have done the Golden Jubilee celebration of ISSR as well as our own institute Golden Jubilee celebration. And Dr. Nafisa, introducing Dr. Nafisa, her research interests are endocrinology and epigenetics. She has been awarded with Professor G.P. Talwar Middle Career Scientist Award, as well as ICMR Swarnakant Dingle Oration Awards. She is the elected fellow of the National Academy of Science, and she has around 80 publications in peer-reviewed journals. She has also reviewed many books and chapters, written some chapters. So over to Nafisa, please go ahead.
Thank you, Jayanti. And at the outset, I would like to thank Professor Lohia and the organizing team for this invitation. And I will be presenting some of the work which we have done in the lab on the paternal epigenetic mechanisms in early embryo loss. So I'll just share my screen first. Is it visible? Hello?
No, that slide is not visible.
Okay.
No.
I'm sharing the screen, but host disable participant screen sharing. So I think the host has to enable the thing because it is saying host disable participant screen.
Dr. Nidhi, will you do the needful? We are unable to see her presentation.
We have already made you the host. We are just checking. Just give us a minute, please.
Yeah, yes.
Just give us a minute.
And Dr. Nafisa, it will, yeah. Dr. Nafisa, the presentation will be for 20 minutes. You can go on for 15 to 16 minutes and 2 minutes for question answer.
Yeah, no problem.
Yeah, Dr. Balasino, I think you're already a co-host. Kindly check now, ma'am.
How do I do that? Sorry, I'm not so.
Yeah, you have to click share screen. There is a button called and click,
okay.
and then you can see the window.
So advanced.
Yeah, you can share your entire screen if you want. Yeah. You can share your entire screen if you wish. Yeah.
Yeah, but multi can share simultaneously in advanced sharing option.
No, you can just click that, up.
Only host. Okay, only host. Okay.
Yeah, you have to just, press the green button, the share button, and then you'll get a window.
Yes. Okay. So screen. Is it fine now?
Yes, ma'am. Yes, ma'am.
Yeah. Okay. Sorry for the. Yeah.
Yes.
So is it okay?
Yes. Yes. Go ahead.
Yeah.
Yeah.
So
go ahead.
Thank you. I think I have thanked the organizers. I will go on to my presentation. It is well known that pregnancy outcome depends on proper growth and development of the fetus and the embryo as well as the placenta. A number of maternal factors on pregnancy outcome is already well worked, but the little is known about the possible role of preconception paternal factors. And in the morning, Dr. Rima and Dr. Luna, just before the two speakers, they spelled out the role of paternal factors and especially epigenetic factors in embryo development. So nucleotransplantation experiment which were done in mice way back in the 1984s by two groups where they had done it simultaneously showed that both the parental genomes are important for early embryogenesis and are functionally non-equivalent. This experiment demonstrated that while the maternal genome was responsible for the development of embryo proper, paternal genome was responsible for placental development. And these experiments were the genesis of genomic imprinting. So I come to the nuclear transplantation experiments which were done in mice by Surani and Salter group, where they had made gynogenoids which were where two female pronuclears were put, and they had androgenoids where they were two male pronuclei were put, and this was a normal zygote. So what they saw was during mid gestation, there was in the normal embryos, normal embryo development was there. There was normal development of the trophoblast cells, but in the gynogenoids where there were two female pronuclei, there was a development of fetus was fine, but there was very poor trophoblast development. And oppositely, in the androgenoids, there was a development of fetus was embryo was not arrested, but there was the placental development was happening. So this suggested that the paternal genomes are functionally non-equivalent and the paternal genome is responsible for the placental development. Am I audible? Hello?
Yes, you are audible.
Okay.
Yes, you are audible.
Okay. So then this also led to the genesis of genomic imprinting, which is like differentially expression of gene or chromosomal region according to the parental origin of inheritance. Like the expression of the gene depends on from which parental allele it is coming.
So I've just put a small schematic here that if you have non-imprinted genes, it will be biallelic expression, but imprinted genes will be always monoallelic expression. So there would be some genes which will be only expressed from the maternal allele, while some genes will be only expressed from the paternal allele. And this parental specific expression is because of a differential epigenetic marking in the form of DNA methylation, which is happening at the imprinting control region, or it is also called as differentially methylate regions, DMR, ICR or DMR, which happens during gametogenesis, because that is the only time when these two alleles are in separate compartments. And also it is known that these genes play an important role during embryogenesis, mainly in embryo growth and development, as well as placental development. There are, up till now, there are more than 100 imprinted genes which are known in humans and mice, and many of them are involved in embryonic and placental growth and development. And most of these genes occur in cluster. Two well-known syndromes which are known to be because of loss of imprinting are Beckwith-Whiteman syndrome, where there is embryo overgrowth, and Silver-Russell syndrome, where there is embryo growth retardation. So based on this, we had done some studies where while lab was my mentor, Dr. Juneja, was studying the role of estrogen in males. And we had used an anti-estrogen that time, but now we know it is a selective estrogen receptor modulator, which was given to adult male rats at this dose for 60 days, because that is one spermatogenic cycle. And we saw that there was increase in pre as well as post-implantation loss. So way back in the 1993 post-implantation loss given to male rats was like we thought the sperm has a role that it will fertilize, and then you may have pre-implantation loss. But like getting post-implantation loss at that time was like it would be only a female factor. So we try to see what, and in the rat, the loss is in the form of a resorption. So we saw at what stage was this resorption happening by doing Cheney staining, and we saw that it was happening around day 9 of gestation, 9 to 11 of gestation. And in literature, it was known that in the rodents, IGF-2 signaling through IGF-1 receptor during day 9 to 11 of gestation modulates embryo growth. So we try to see the IGF-2 expressions in these embryos, and what we find that in both the control and the tamoxifen treated group, the normal embryos had normal IGF-2 level, but the resorbed embryos, we also saw some resorption in the control. So both the resorbed embryos had the IGF-2 level was affected, suggesting that paternal tamoxifen treatment affects embryogenesis. So later we try to see that now we know that IGF-2 is an imprinting gene, and it is paternally expressed, while H19, the gene which is also regulated by the same ICR region, is maternally expressed. And how is this parental specific imprinting expression regulated is because of this. You have this imprinting control region here. You have IGF-2 upstream around 8 kb upstream to this ICR region, and you have H19 which is near the which is around 1 kb further than the ICR. And on the maternal allele, this ICR is unmethylated, while on the paternal allele, is unmethylated, while on the paternal allele it is methylated. And we saw, and because of this methylation, the enhancers have the CTCF cannot sit on this ICR region, and therefore in the maternal allele, H19 is expressed, while on the paternal allele, because CTCF cannot sit on this ICR region, the IGF-2 is expressed. So we tried to see what is the methylation status in the spermatozoa of this IGF-2 ICR region. And we saw that, so this was the ICR region we have seen, and we had around 15 CPG sites, which we had done by that way back, we had done by methyl sequencing bisulfite sequencing, and you can see the blue dots represent methylated CPGs, while the yellow dots represent unmethylated CPGs. And you can very well see this was done in 4. Methyl seq was done in 4 many animals, but the representative of this 4. And we see that in the control group there was less of there was complete methylation. But in the tamoxifen group, we can see an increase in hypermethylation. So this represents the number of animals per CPG size. Then we try to see what happens in the embryo sired by this control or tamoxifen treated rib. So we had taken one of the C4 as a control embryo sired by C4, resorbed embryo sired by C4, normal and resorbed embryo sired by C4 and T4 group. And what we could see that in the control group, we could see that there is normal, you can see this is the coming from the maternal allele, while this was from the paternal allele. So we could see total methylation here. While in the resorbed embryos in both the groups, we saw that wherever there was unmethylation in the spermatozoa, same sites were unmethylated in the resorbed embryos, suggesting thereby that there was significant reduction in DNA methylation at this region, and methylation imprint error in spermatozoa manifested in the resorbed embryo. Then we want, because tamoxifen was an estrogen, it binds to both the receptor estrogen alpha and beta. We tried to see whether it has upstream to it has any estrogen binding sites. So we tried to look at the estrogen response element, and we found that near the CPG island, there was one estrogen response element, and it was functional. We did a chromatin immunoprecipitation with ER beta antibody in the testicular cells, and we found that there was an enrichment with ER beta compared to the MOG. And with tamoxifen treatment, we found that the percent enrichment had reduced in the testicular cells, suggesting thereby that involvement of ER beta in imprint acquisition or maintenance in the male germline. Further, then when we later when we were able to get some ER alpha and beta specific agonist, we tried to see, because we know tamoxifen can act through both the receptors alpha and beta. So we tried to see do studies with ERA alpha agonist, which was PPT, and ER beta agonist, which was DPN. And what we found was, we did the global methylation, and we find that there is no effect on the ER alpha agonist, but there was a decrease in the global methylation with the ER beta agonist. Similarly, for line 1, which is also a measure of global methylation, we found that there was no effect on ER alpha agonist, but we could see that there was an effect on ER beta agonist. For the H19 region, we found that similarly that alpha did not have any effect, but ER beta agonist had an effect on the H19 methylation at the ICR H19 IGF H19 ICR region. Then we switched on to seeing the experiments and the results in the rodents. We then thought to ourselves what would happen in human in a condition called as recurrent pregnancy loss. And now Dr. Samantha had already expressed that what is RSA's pregnancy loss is loss of 3 or more or 2 or more consecutive pregnancy before the 28th week of gestation, and various factors are involved. Maternal factors as well as paternal factors are known. But still there are around 50% of cases which are unexplained. So we try to study whether genomic imprinting could be one of the paternal factor. So we try to see, this is in a number of, in a sample size of 100 in each group, control and RSA group, RPL group. We saw that global methylation was also affected. There was a decrease in global methylation. There was a decrease in the line 1, some of the CPG sites on the line 1 methylation was affected. And we could also see that IGF to H19 DMR, there were several sites which were affected in the H19 DMR. And this is another gene, which is DLK-GTL to IgDMR, which was also affected. Most of these DMRs in the spermatozoa are methylated, while in the so we could see that there was hypermethylation happening in the paternally methylated DMRs. When we try to see what happens in the with paternally expressed but the paternally unmethylated DMRs, and we could see that there was a hypermethylation of all these genes. These are all imprinted genes, MES, SAC, KVDMR, and PEC10. And we tried to see the DMR regions, methylation of the DMR regions of this gene, and we found there was hypermethylation of all these paternally unmethylated DMRs and PEC10, but we did not find any effect on the SNRP. So we tried to, so this study suggested that DNA methylation changes of imprinted genes involved in embryo development in spermatozoa from couples experiencing recurrent pregnancy loss. When we thought to ourselves, can that be used as a diagnostic marker? So we try to establish a threshold for this, or if we can have a methylation threshold and try to have it as a marker for, so we try to do ROC analysis, and we found that when we took individual genes, some of the 5 individual genes, we found that AOC was around 60%. But when we combine these 5 genes, we found that the AOC was 0.88%, suggesting that, and the sensitivity was 78, and the specificity was also 86, and the Jordan index was around 65. So this suggesting that combination of differentially methylated genes can be used as a diagnostic marker, as a paternal factor which could contribute to RPL. And we are trying to validate this, whether we can use this in more number of samples using single blind studies. So then there was another disorder which is also pregnancy related, and it involves placenta, which is preeclampsia. So we try to see whether it could have paternal factor, could have epigenetic factor, imprinting can have a role in preeclampsia. And preeclampsia, we know that it's a disorder during pregnancy characterized by high blood pressure with either proteinuria or an organ damage. It occurs after the 20 week of gestation in a previously normotensive women. And occurrence is 5 to 8% of pregnant women, and the major cause is maternal and fetal morbidity and mortality. Pathophysiology of preeclampsia is multifactorial, but what is now believed is, and it is known that the presence of placenta, which is responsible for the development of disease. And if you remember, I said placenta is also in the paternal genome is involved in placental growth and development. So what are the evidences of whether there's a paternal influence on preeclampsia, involvement in preeclampsia? So we see that in the diandric hydatiform moles, we see that there is severe or very early preeclampsia is reported. When there is a change in partner, there is a decrease in the recurrence of preeclampsia, while in the women with previously normal pregnancy, partner change increases the risk of PE. So there could be a discussion that this could be because of the paternal antigens, but now we can also say that even the imprinted genes could have a role in these things. So then epidemiological studies have reported that higher rate of preeclampsia in pregnancies fathered by men who were themselves born preeclamptic, suggesting involvement of paternal factors. So we tried to study some of the genes which are important and which we had studied for the RPL group in the preeclampsia group, and tried to study the expression of these genes in the placenta also. So whether the methylation in the spermatozoa correlates with that in the placenta, that is what we wanted to see, that it would have given us a cause effect, some sort of a cause effect relationship. So one of the region which we had studied was KVDMR. It is a imprinted region where this is the DMR, which is called as KVDMR, and methylation of this region controls several genes which are adjacent to it, which is PHLDH, CDKN1, ACL2, and all these genes play a role in placenta development. So what is seen is in the maternal allele, this TMR is methylated, while on the paternal allele, this TMR is unmethylated. And because it is unmethylated, it expresses antisense RNA, which actually blocks the expression of the adjacent genes, which are important for placental development on the paternal allele. So what was seen was an upregulation of, people have seen an upregulation of PHLD in placenta of pre-eclamptic women was observed, but it's what is happening to the spermatozoa was not seen. So, and also that this PHLD regulates proliferation, migration, and invasion of trophoblasts, so suggesting its role in trophoblasts. And there is a PKF mouse where there's a where this region is affected, the CDKN1C, and they have shown that it develops, this mouse develops preeclampsia. So we try to see the KVDR reagents in the spermatozoa and in the term chorionic villi of the female partners. So this was spermatozoa was from the husband and chorionic villi was from the wife. So what we saw was there was an increase in the methylation. Remember that in the spermatozoa, this KVDMR is unmethylated, but we saw that there was hypermethylation in the P group, preeclampsia group. And we could also see that what was there in literature, that there was an increase in the expression of this gene of PHLDU and CDKN1Cs. So we know that elevated expression of PHLDA and CDKN could lead to disruption of and migration of invasion capacities of trophoblasts, leading to shallow placentation, which is observed in pre-pregnancies.
Dr. Nafisa, only 2 minutes left.
Yeah, I have finished. And then we saw another region which was DLK1, and that in literature it is known that in the umbilical veins, this IgDMR, which controls the imprinting of DLK and GTL2, is hypermethylated, and DLK1 is in the placenta is increased, and this is upregulated, and GTL1 was downregulated. What we saw in our thing also was, we saw hypomethylation of the IgDMR, and we saw an increase in DLK1, which was, so hypomethylation was observed in IgDMR in the spermatozoa of preeclampsia cases, and there was upregulation of imprinted genes DLK1 in the preeclampsia. And we also saw for PEG2, which is also involved in placental development, there was hypermethylation, but then we did not find any effect on the expression in the term villi. So summarizing it, demonstrated that the association of paternal imprinting and pregnancy loss in humans and rat model, the condition in which women are usually undergo elaborate testing, because we know BOH test, there's a whole kit of BOH tests, which all involves which is almost all women centric. Then we also observed a correlation of methylation status of sperm DNA with that of in their sire, suggesting methylation imprint error in spermatozoa manifested in the resorbed embryos. We also demonstrate ERBT is involved in the imprint acquisition and maintenance in the male germline. And this has significance because we know some of the endocrine disruptors are estrogenic. They are known to affect male fertility. We also observe that combination of methylation status of 5 imprinted genes in the spermatozoa to be the best diagnostic marker as paternal factors for recurrent pregnancy loss, and the feasibility and diagnostic potential is being validated. We also observe aberrant methylation in the male partner suffering from preeclampsia, and it correlated with the expression pattern, indicating that methylation of this DMR is crucial for placental expression. Proper placental development of the corresponding genes. So the message I would try to give is paternal imprint is involved in pregnancy outcome, suggesting a need for paternal preconception care. And I would like to acknowledge all my students who have played an important role in all whatever I have presented today. and my colleagues, Dr. Dipti, Neki, and Dr. Kushan, and the clinical collaborators without whom we would not have been able to get so the large this, and my technical people also help us in all the experiment works. Thank you.
Okay, thank you, Dr. Nafisa, for the wonderful talk. We don't have, you have already exceeded time. Only one question I can, from the audience, we can have only one question.
Can I ask a question?
Any question? Anyone?
Yeah, can I ask a question?
Yes, go ahead.
Dr. Balasinor, very good talk. My question is this, can you hear me?
Yes.
Okay, in case you know that there is a problem with the paternal imprinting, which is the cause of RPL or preeclampsia, so what would be the kind of suggestion that we will give it to the patient?
Right now we cannot give such suggestions, but maybe in later on we have that, even like there are therapeutics coming into epigenetics, so if that could be, but at least we can suggest there could be a paternal factors, and even if they go with IVF and all, some of the IVF failures could be because of this also. So like repeated IVF failures and all means it would lead to, so that could be prevented. That is what I would.
So in that situation, you will suggest sperm donation from somebody else?
That is up to the person concerned, but yeah, that could be one of the things.
Okay, thank you.
Okay, thank you, Dr. Nafisa. Now we'll move to the second. Now we'll move to the second speaker of the session. I have the pleasure to invite Dr. P.K. Misra, who is the head of Molecular Biology Division of NIR at Bhopal, and his research interests are development of low-cost nanobiosensor for predicting future disease susceptibility using cell-free circulating epigenetic signature as biometrics. He has received several awards, such as Fellow of National Academy of Medical Science, Africa-India Mobility Fellow, Dr. T.C. Anand Kumar Gold Medal Oration Award, Lapsetor Award, Samanta Chandrasekhar Award, Fulbright Nehru Fellowship, Professor G.P. Talwar Gold Medal Award, D.V.T. Young Investigator Award, and J.E.M. Young Scientist Award. He has more than 150 publications and in good journal with high impact factor. With this, I invite you, Dr. Misra, to go ahead with your presentation. Thank you.
Thank you, Dr. Monik, for the wonderful introduction. I'm trying to share my slides. So, unable to do it right now. Or any help from the organizers, because I'm unable to do it.
Dr. Nidhi, please help.
Just a minute, maybe.
You're already the co-host.
You are already the co-host. Please try sharing the screen.
In the meantime, Dr. Pradeep has a question from the previous speaker, please, if the chair can allow.
Just you can ask her over the chat, she can reply it. Because we are going out of time. Hello.
I think he's joining again, ma'am.
Okay.
Yeah. It's visible now, sir.
It's visible now?
Okay.
Yes.
Thank you. Yeah, it's visible. Please go ahead. Your time start now. Please stick to the time. Yeah.
Thank you. Thank you, Dr. Pramanik, for the lovely introduction. Distinguished guests, ladies and gentlemen, listening to this presentation. Let me begin this presentation by thanking Professor Ansari and Dr. Barkha Khilnani for providing me this wonderful opportunity and for arranging this meeting in a much meticulous manner during these unprecedented times of global pandemic we are seeing due to COVID-19 pandemic, So I consider this as a rare opportunity and privilege to be amongst you this afternoon. And I would be basically speaking on the topic low-cost innovations in predicting the future disease susceptibility. So basically, we are currently up. Just let me, I am unable to. Okay, this screen, how I can, please. Okay. So, but basically, I am working at National Institute for Research in Environmental Health, Bhopal, which is basically located in the heart of India. That's Madhya Pradesh, and we are working concertedly under a broader mandate of researching the environment for healthier lives. So, as times have preceded, and we are in the modern century of 21st century, we have understood the very importance of environment on health and diseases. And we are starting to realize that what makes us who we are starting much before our birth, and it may not be all necessarily lying all in our genes. And there must be genes and environmental interactions playing a wonderful and big role, maybe. So during the next 18 minutes of my talk, I would first like to touch upon few generalized aspects before going into the very specifics of low-cost innovations that we are trying to develop at our center at ICMR Nire Bhopal, using nanobiosensors as point-of-care approaches and using cell-free circulating mito-epigenetic signatures as biomarkers for disease screening. First of all, I would like to provide highlights on environmental disease burden, address some of the windows of vulnerability, and then some points and some highlights on development of the disease phenotype. Just I'll touch briefly upon mito-epigenetics, whether it can play a substantial role in the environmental disease burden, and some low-cost innovations that we are trying for a set of non-communicable disease forms at ICMR Nire, and I'm at last discussing the translational perspective of the whole work. Now, in relation to this presentation, I declare that some of the indicative workflows that I've included in this presentation belong to the PCT applications that we have filed. We have filed 3 patent applications in last year and a half, and our lab has received considerable funding support from Indian Council of Medical Research, Department of Health Research, Department of Atomic Energy, Department of Science and Technology, and the Imprint India Initiative grant from Ministry of Human Resource and Development. Now, basically, global burden of diseases studies are conducted by Institute of Health Metrics and Evaluation, which are funded by Bill and Melinda Gates Foundation. Now, they conduct these studies periodically to look at the premature mortality and the disability due to various environmental factors and all sorts of factors per se. But if you go into the latest statistics that is published in Lancet in 2021, the GBD studies suggest that around 23% of the global deaths can be attributable to environmental modifiable factors. That's cumulatively around 13 million deaths. So 13 million deaths caused due to environmental modifiable factors or environmental dependent factors. So in other words, environmental modifiable factors are primarily responsible for 1 in every 4 deaths that are happening in the world today. IHME website, you would find that more than 100 can be directly ascribed to the environmental modifiable factors. So the environmental impact on our health, and if we discuss from an Indian perspective, so Indian state level disease burden was also done by, the studies were also done by the GBD group. for a period of around 20 years, from 1999 to 2019. And as per the latest GBD estimates, environmental pollution accounted for around 10.7 lakh premature deaths in India. So it's basically around 18% of all deaths that's being caused in 2019. So you can just imagine the impact of environmental factors in the, from an Indian perspective. Therefore, exposome is a very fascinating concept, which was introduced by Dr. Christopher Weld, who was the chair of International Association for Research in Cancer. He introduced this concept in 2005. Exposome basically relates to the sum total of all exposures that a human being experiences during his or her lifetime. Later in 2014, Miller and Jones somehow modified the very definition and gave a lot of emphasis on the biomarkers, the circulating bodily fluids, because those could be the real tools for going into the exposome analytics sector. So as I already said that exposome is an emerging concept, I primarily view exposome as the cumulative measure of environmental influences, associated biological responses, which not only takes into account the exposome of the exogenous and the endogenous factors, but behavior and diet also play a much major role in all these aspects. So if we look at the environmental toxic exposures that are happening from now and for years now, so they can be categorized broadly into acute and chronic type. Whereas acute are short-term exposures. So they can be the accident. The few examples could be the methyl isocyanate gas leakage that happened in Bhopal, or the Fukushima or the Chernobyl radiation accident that happened in Japan and Russian Federation. So wherein a large number of toxin materials is released into the atmosphere during a very short span of time. Where chronic environmental exposures, on the other hand, could be the particulate matter that is present in the air that we breathe, or the heavy metals that are present in the water that we drink every day, or the pesticide remnants and residues that are present in the food that we eat every day. So if we are exposed to these pollutants for a very longer duration time, together with nutrition factors, and they can have enough capability to modulate the genome, epigenome, and metabolome, and play a very important role in age-associated degenerative diseases, the non-communicable disease forms, including reproductive health elements. Now, this slide shows the temporal variation in exposure of a subject. And if a given individual, the lifetime can be compartmentalized into 4 different segments: childhood, puberty, adulthood, and aging. The very impact of environmental toxin begins as soon as the zygote is formed. Of course, the gamete carry their own information of the exposures. So apart from the unitary exposure, we have accumulated occupational exposure, clinical exposure, and seasonal exposure. So all these exposures basically are quite overlapping in life phases and occur throughout the life of an individual. So there is not an iota of hesitation in accepting the fact that Dr. Baker was fundamentally right when he postulated the Dohart's hypothesis. That's the development, origin of health and adult diseases hypothesis, famously known as the Baker's hypothesis or the Baker's paradigm. So early life environmental exposures can lead to later life health problems. We are precisely what our grannies were exposed to. So if genetics loads the gun, it basically the gene environmental interactions or the epigenetics which pulls the trigger. So as far as the effects are concerned, immediate, intermediate, and long-term, every acute or chronic exposure are going to have some kind of exposure response and dose response relationship. And for a particular type of toxin, if the dose exposure and exposure responses our relationship is well defined, then to categorize and to get into the exposure analytics becomes much easier, and biomarkers may offer a great help. So biomarkers could be the predisposition, early detection, prognostic, and predictive. Here, basically 3 things come into mind when we launch a molecular exposomic study: when, what, and how. So what is the best time to collect the samples and launch the study? What could be the study design, whether it is a case control study, whether it's going to be a cross-sectional study? what are the various biological matrices that you're going to include, whether it is urine, blood, or saliva, and what is the best method, So which platform can you use for the assessments? So there are 5 levels of distinct interrogations when the molecular exposomic study is concerned. That's the kind of exposure, biomarkers of exposure, biomarkers of early effects, biomarkers of disease, and death at tissue bank. So UK biobank studies have manifested that tissue repositories can be extremely useful for conducting molecular exposomic study. A lot of publications have appeared in NISM, and I'm sure all of you must have seen those articles. So I have tried to collate all the reproductive health elements in one slide, which starts with early pregnancy loss and ends with malignancies of the female and male reproductive tract. So almost all the diseases, all the disorders and diseases can be ascribed to environmental modifiable factors. So there is absolutely no doubt that epigenetics plays a fundamental role in reproductive health. As far as inter-individual epigenetic variability is concerned, it is extremely important because, this controls the gene expression, overall gene expression patterns, and they can really modulate the disease susceptibility. Whether mitochondria plays a role in the epigenetic modifications, we have been studying this aspect since I was at Tata Memorial since 2008, and it's almost around 20 years that we have been studying all these. It's almost more than a decade now that we have been studying the role of mitochondria in epigenetic modifications, and we have delineated a number of pathways that basically occurs in this arena of work. But having said that, I'm not going into the details of these modifications and the pathways because of the lack of time. So message from the part 1 of my presentation is that human genome that complements with the exposome analytics can be a viable tool for molecular exposomic study, and with a better exposure element in the risk equation, mitoepigenetics might play a fundamental role. And we can also use these circulating mitoepigenetic signatures for looking at various parameters and of human biomonitoring. So the fundamental question again remains that whether low-cost innovations involving nanoanalytical framework can help, because India is we are working in a limited resource settings. So we have to develop some of the techniques which are viable and which are point of care in nature. And having that in mind, we developed some nanophotonic assays as point of care tools for preventive health interventions. And nanobiosensors can be best defined as the frameworks that identify minuscule quanta of any biological and chemical analyte. And there could be several principles based on the detector that we use. The nanoconstructs can utilize electrochemical, mechanical, calorimetrical, or optical methods to convey the relevant information. So as far as the components of the nanobiosensor goes, so there are 3 broad components: biometrics, transducer, and detector. So biometrics can be saliva, urine, blood, but they should be stable under storage conditions and should get immobilized very fast. Transducer basically acts as an interface, measuring the physical change because it works on the principles of stoichiometry. The amount of energy that is being excited is the same amount of energy that is being captured and detected. So this transducer component only acts as an interface and passes on the signals. The signals from the transducer that are passed are processed in the detector systems and they get amplified. So basically, and they can be converted from the analog to digital signatures, and depending on the various platforms that we use, like flow cytometry or the luminescence platforms or the fluorimetry platforms, they can work in visible spectrum as well. So depending on the detector modules, you can have the amplifications and the other modules formatted as per your needs. We work using the nanoparticles that are carbon nanoconstructs and graphene nanoconstructs also we have used. We use a range of semiconductor nanocrystals, quantum dots, and carbon quantum dots, graphene quantum dots, metal silica-based nanomaterials, and magnetic nanostructures. So we use a broad range of semiconductor nanocrystals for framing the nanoanalytical frameworks of the nanobiosensors. So we started working during the Tata Memorial days. So we started looking at the presence of fetal nucleic acids in maternal plasma, and knowing well that fetal DNA would be around 10%, and they originate from the placenta, and they appear around post 10 weeks of pregnancy. So the quantum is extremely small. So we because those days in 2012, 2013, so we were basically using 3 kinds of commercial kits, but we did not get a lot of success in getting a good stuff of the fetal DNA. Therefore, we introduced the dialysing membrane and the tangential filtration columns into the kit formats. And basically, we isolated circulating DNA, microRNAs, circulating RNAs, and circulating mitochondrial DNA. So, and started looking at the characterization, working on the characterization parts of it. And basically, the circulating DNA were around 0.5 kb in size. And also, we looked at the various histone forms because we wanted to understand whether these circulating DNA remain in naked condition or in nucleosomal cores. So some amount of histone 2A, 2B, 3, and 4 could be detected by Western blot, but they were present in very less quantity. After that, basically, we started working on the microRNA characterization in collaboration with some Indo-Russian collaboration. And we are still working on microRNAs, and we have standardized around plexes for around 74 microRNAs as of now in our lab, using real-time PCR and the conventional PCR settings, wherein we use 1-step and 2-step PCRs for doing the microRNA analysis. And mitochondrial DNA that basically was isolated. We characterized them by doing the real-time PCR for ND1 and beta-actin. We found out the ratio between mitochondria and the nuclear DNA.
Dr. Misra, only 2 minutes left.
Yeah, thank you. So basically, we looked at the overall the ratios of all the mitochondrial DNA characterization parts. We also did a mitochondrial DNA 9-fragment analysis approach and sequenced the mitochondrial DNA. Then mitochondrial DNA methylation for 6 loops, that is D loop 1, D loop 2, 12STF, cytochrome B, and 16S were also evaluated at our setting. Considering mitochondrial DNA as an important element because it is passed through the maternal lineage, we tried to develop a dual nanohybrid assay for detection of cell-free circulating mitochondrial DNA. For the mitochondrial DNA, we had 2 kinds of semiconductor nanocrystals. One was the carbon nanodots having 1 aminopyrin stacked to it. Aminopyrin has an affiliation for the nucleic acids, all kinds of nucleic acids, and the semiconductor nanocrystals QD705, which are labeled with probes, and they were specific for mitochondrial DNA. We went ahead with the fabrication of the capture and the screen component, looked at the gel electrophoretic mobility assays by CQD, by passing them on to the agarose columns. Co-localization studies for all the semiconductor nanocrystals were conducted by multiphoton microscopy. We did a quantum-based nanocytometry because this is a very important tool.
Please wrap up.
Yeah.
It's already.
Yeah. So using the control and the test. So we are trying to develop integrated nanobiosensors in collaboration with Saratov State University, Russian Federation, Neufer Institute of Occupational Medicine, Ghent University, and Northwest University. The broader concept is EpiMito-beamed. It's a 3R concept, which is reduced risk, reduced cost, and reduced maneuvers. So I'm not going into the very details of the principles. The broad messages. We can basically capture the circulating mitochondrial DNA that is specific for the fetus, and whether same degree of accuracy can be obtained using biodegradable and environmental friendly approaches. Well, of course, we are going to see some of our publications from 2018 to 2021.
Okay.
To publish in Atlanta, we have been able to publish in Trends in Analytical Chemistry, which has an impact factor of around 12. Electronics and drug discovery today and nanomedicine. Thank you for the attention.
Very good, Doctor. Mr. It was an excellent presentation. And any question, only one question is allowed because it is already time is over.
Can I ask a question?
Yes, sure, sir. Looking forward.
How are you?
I'm doing good, sir. All your blessings.
Good talk. But I was just wondering, I understand that, keeping the environment clean is very important.
Sir.
But if you see the global health burden today,
sir,
if you see the global health burden for the last 100 years, we are better off today, despite having all those kinds of problems, all kinds of emissions and, environment being dirty. Still, we are better off as far as the health is concerned. Life expectancy, for example, child mortality, maternal mortality,
please come to your question. Yeah, Dr. Kumar, please come to the question.
Question is that. So what is your comment on that?
Yeah. So basically, environmental factors and its burdens are basically, they're dynamic in nature. So as far as I'm a little bit afraid about the air pollution factors because we are constantly looking at, and I'm sure you and Malini ma'am perhaps know that we work in close consortium with the IIT Kharagpur group to look at the particulate matters and its implications, transgenerational epigenetic traits we have evaluated. So I'm particularly worried about the air pollution, not because we can't do anything about climate change certainly, but yes, air pollution, a lot of things can be done, sir.
Right. Thank you.
Thank you.
Okay. Thank you, Dr. Mishra. So we'll move to the next speaker. Thank you.
Stop scaring. No, again.
Yes, I have the pleasure to invite Dr. Pradeep Mahajan. He is an MBS general surgeon and urologist from Delhi University. Okay, he is chairman and managing director of STEM RX Bioscience Solution Private Limited. With this, I request Dr. Mahajan to go ahead with his presentation. Dr. Mahajan, please. Dr. Mahajan, are you audible?
Can you hear me?
Yes. Go ahead, please.
Okay.
Thank you.
First of all, let me thanks to the organizers, ISSRF, Indian Society for Study of Reproductive and Fertility. What is more important of this today conference is that being a clinician in a non-fertility science as well as the reproductive science, but I'm a person from the regenerative medicine. Basically, by training, I'm a neurosurgeon. And last 10 years at STEMRX, I have started working on regenerative medicine. Currently, I have been appointed as an adjunct professor in regenerative medicine and surgery department at Indiana University in US, where I'm doing my lot of research in particular related to the stem cell technologies, how they can be translated into human utility from bench to beds like. The applications of regenerative medicine have been a wide scope, which are from every faculty from neuro to ortho to talk of a faculty, regenerative medicine has to play a role. So for me being here invited today, I'm really thankful to Dr. Lohia, Dr. Ansari, Dr. Barkha, as well as my name reference given by Dr. Deepa Bharti, whom I know for a long time working with NI, RRH, where she has done a huge amount of work on VACL cells, that's very small embryonic-like stem cells. The role I'm quoting here because in most of the talks which I'm going to continue, VACL cells are going to, or MSC are going to play a major role when I talk rejuvenation post-chemotherapy or onco, or in the aging population or primary failures, how do we use these kind of cell components, promising role of cell therapy and growth factors in reproductive medicine. In fact, my experience has taught me our body has been a bioreactor. As a bioreactor, repeatedly I'll be talking on this topic of bioreactor. At STEMRX, we have tried to work on various capacities from dedication to GMP facility. How do we convert all these products taking into a regulatory framework from autologous cells to allogenic cells and convert them into a therapeutic application. This particular 32nd annual meeting has given an opportunity for me, and really I'm thankful to present in a futuristic science down the line, where we have been talking 50 years on the same science. How do we improve our fertility, or how do you take care of reproductive medicine in their organs? In fact, if you ask me, what are and how do I look as reproductive medicine related to the newer science, I would say rather regenerative medicine is a part of reproductive medicine, is changing the science of reproductive medicine. Just to correlate, RM and RM are equal for me. Reason being that entire reproductive medicine is based on regenerative medicine. And we, fortunately, unfortunately, at our school levels, in medical school levels, we have been not taught on the science of regenerative medicine. We have been taught on the science of only working on how do we work on reproductive medicine to improve the fertility, to improve the, to understand the reproductive organs, how the reproduction takes place, and what are the challenges come in the case of infertility, and how do we change by using various hormones and drugs. So this is a big challenge where we find to take the body not as a bioreactor, but as an impact to deal with external resources. The entire situation starts when we understand the quantum of stem cells, which are the master cells of a body, which play a role. This is very important slide which I have shown you, which will indicate you as we grow older. I'm going to come to the dogma of oocytes in the young women and aging women, where we have been taught differently. With the aging different science, the entire dogma has changed. I call it science to be very dynamic and will be practiced in a different way. The medicine will be practiced in a different way, the way you are practicing today in the future, because I'm going to put everything as a bioreactor of human body, and what are the cell components and their products like growth factor, exosomes, or you can say Hitchcock proteins, or there are proteins which are called as xanthine proteins, which are important to improve the fertility. Now, as we age old, we see the ratio of stem cells going down in the body, that is representing the entire change in the microenvironment of the body, which affect the cell population in the body. This is very important, which we'll not understand for a regular understanding. How do we use this into a therapeutic application? The current challenges, issues of reproductive medicine, when we talk in the male and female, the lack of factors from safety, prenatal, all our trial and error, which we work on external source to manage hormone levels, which are very important, which are affected by the microenvironment of the glandular system in the body, with the decrease in the signaling factors, hormone factors, and the way response of the stem cells to reduce it, the way the aging process. And the issues which are unregulated for infertility, we try to put them in the system, contraceptive overuse of, then multiple pregnancy, maternal mortality, and socioeconomic. These are various issues in the current reproductive system. The classical dogma, which are taught to us, which were researched out 50 years before, I would say rather after 10 years spending into research in the labs, being a clinician, I could relate whatever is taught to me in the medical school is which is research 50 years before, 100 years before, 20 years before, which has come into textbook, and I'm learning it today without having connectivity of the science, which is dynamic, and it is in the laboratories where the things are changing much, much ahead. What is taught as a dogmas, particularly not only the ovarian factor, in the sympathetic system, has been changed. Cardiovascular system is changed. Neurological system is changed. And with my newer understanding, this dogma is now challenged, which was as a fixed pool, physiological decline in the follicular population, in the ovarian reserves get exhausted. Now, recently, OSCs, that is presence of ovarian surface epithelial cells, has been proved by Tilly and his group, whereas Zuckerman was one who defined in 1950s, which are still following, which I was talking to in medical schools, what has been taught, is today even still we follow Zuckerman's philosophy that postnatal mammalian ovaries don't represent to make new ovums. That is a big challenge, and that is why we understand we have a reserve pool and we lose that balance. But Tilly and his group has proved in murine models the availability of these kind of ovarian stem cells in the animal model. And this group has isolated these stem cells in the lab by using magnetic technology, using antibodies, which are antibodies of DDX4, which is one of the genetic representation, to show that ovarian stem cells are present in the aging people also. This was done as a ovarian biopsy taken in tissue and got into a what you can say lab procedure into smashing it, then putting antibodies, and magnetic beads were used to isolate them, microbeads were used, and then the enrichment of CDX4 cells, DDX4 cells were shown in the suspension, showing that embryonic, or sort not embryonic, but the ovarian stem cells are present in the ovary. That too we can see with the molecular studies, which show difference between ovarian stem cells and oocytes. Oocytes are adult and ovarian stem cells are the surface epithelial cells. We show the marker study also. If you see, I'll put it not much of them all, but OCT4, which is present in the ovarian stem cell, and oocyte, you will find it becomes an cytoplasmic. Whereas here it was in a surface epithelial cell, surface linings of the cytoplasmic nuclear cells. It is in the nuclear cytoplasm, nuclear molecules, OCT4, and here it comes to cytoplasm. Now, DDX4 and CSA4 molecules are in the cytoskeleton, cell membrane cytoplasm. This shows the isolation has shown that the ovarian stem cells do represent with the OCT4 going into a cytoplasmic molecule when it becomes an oocyte. Now, preservation of eggs in ovary may not be regenerating eggs after the toxic insult in the chemotherapeutic patients in the young. This is also one of the theories which will show that how the VACL cell and OSC cells in such ovaries, chemotoxic ovaries, are preserved. They are not killed by chemotherapeutic agents. And it has been shown very clearly, this clearly mentions how we have separated these ovarian stem cells from the surface epithelium and how these ovarian corticular cells get into folliculogenesis. Now, OCT4 and in the as a nuclear cytoplasm, nuclear marker study, we shown in VACL cells to be coming as an ovarian stem cell size. Now, what is different from OSC and VACL is VACL are very, very small, like cells of the size of 4 micron, and OSC are of 8 microns and showing cytoplasmic. In VACLs, it shows a nuclear. So itself, it speaks the change in level of OCT4 from the nuclear to the cytoplasm and surface itself speaks that VACL represent the ovarian stem cells in the primary stage and they are present in the adult tissues also. There are a lot of research papers has come which are showing in the cancer, post-cancer, showing the VACL present in this. These are the various papers which I have brought to you just to show a possibility to understand post-chemo. Still the fertility is present because the ovarian stem cells or VACL cells still persist, though the oocytes are targeted with the chemotherapy. So they have not lost the fertility. So how do we use the restoration of this OSC niche after chemotherapy? This particular niche is composed of vascular pericytes. These vascular pericytes nowadays have been defined to be mesenchymal stem cells. Now, pericytes and mesenchymal stem cells, they represent as an anchoring cells in the capillaries, in the all organs of the body, including ovaries, testes, and reproductive organs, as well as in the bone marrow or any other part of the body like fat, skin, everywhere. They are said to be primarily repairing cells of the body of mesenchymal origin, and they represent how they differentiate into oocytes later on. And they also represent the memory cells, which represent again a part of immune system and autonomic innervations. They play a major role of niche which maintains the ovarian stem cell niche and which is compromised as we grow older. That is why our niche in post-chemotherapy or aging ovaries is compromised, not taking signals, and the ovarian stem cells are not differentiating. That is why we feel ovaries are not ovulating. That's what is a theory speaks, or currently research speaks about it like. Improving microenvironment for existing stem cells to function properly is a challenge, which we try to manage by changing hormones, by changing lifestyles, by changing other factors, and see that whether we can change the with these singling factors of hormones or some kind of drug molecules, the entire environment will never change. So we need to see, how do we change? When I'm talking, again, I repeat my sentence, body is a bioreactor. If the body is considered to be a bioreactor, then I would say rather my hypothesis, decline of ovarian function with age is due to compromised niche. And as I spoke about the niche, how do we make this support stem cell differentiate into oocyte? This is a big challenge. And I believe if we come over this hypothesis, we can show this microenvironment can be changed using autologous or allogenic, depending on the source of our availability, source of your knowledge, source of your SOPs, protocols, how do we change it? There are spontaneous evidences we have seen many times. A 60-year woman has become pregnant. Itself shows an evidence that oocyte-like structures differentiate into oocyte, in spite of unfavorable atmosphere, sometime by overcoming that environment. But that cannot be a routine factor. So we need to work on how do we endogenous VCL cells or otherwise other source of stem cells to regenerate non-functional gonads. And that is much, much possible with my experience, which I have seen. So it's a new branch, new stem cell, old branch for new stem cells family, which is exhausted source of how we regain back. The theories of Zuckerman, which I told you, which was showing how it was shown that evolution is exhausted. But this theory of Johnson et al. In 2004 has proved epithelial germ cells, which are present in those, can get into and granulosa cells. Now, same way, the group has premarital germ cells as well as GSCs can be restocked if we collect the sample before chemotherapy and restock them and use them for the redevelopment. Various groups have done a lot of work on this, and particularly I'm insisting on bone marrow derived germ cells also, though they can be replenished in the post-chemotherapy aging population, where we should understand extragonadal source of ovarian germ cells are also present, which are coming from the bone marrow also. So we have a source primarily from the ovary, and we have a source which is coming from the bone marrow. Dr. Deepa Bharti was a primarily, which I have come across a lot of research paper, which she has proved it about these particular VACL cells which are present. Now, I have shown a little understanding for you. Embryonic markers, how do differ from VACL and OSC? So we conclude understanding, can we use these pluripotent VACL cells and progenitor cells which are present in the gonads as an alternative options of embryonic stem cells or iPSC for regeneration? These are autologous. And also using them to regeneration in spite of having the constraints of regulatory issues on allogenic source. But here we can use in one shot go, in one procedure, by using centrifuge technology, double centrifuge technology, to isolate these kind of VACL cell or progenitor cell from the bone marrow extragonadal source, which I already spoke to. Does our infertility depends on immune system? It is a very important. In all our theories, what we practice in the current scenario, which has been taught to us in schools, and most of the infertility experts are using this, we forget that entire infertility or ovaries or even the testes or even the uterus, everything depends on the immune system, which plays a major role in maintenance of fertility. We forget this part. And so as we understand there are unseen causes, unexplained causes of infertility during when we do manipulation with the hormones to treat infertility by using and various sources of art like IVF and IUI and other technologies, where we forget that infertility has to be related to the particularly immunity. The reason I'm telling you very important is for all of you to carry the message. Immunity plays a major role because when the baby is developing in the womb of mother, the first cell which differentiates in our body, particularly in the first 7 to 10 days, where you will find the blastocysts form, the first signal which gets from around 6 to 8 weeks, probably, the germ cells are formed by getting an external stimuli to the embryonic stem cells, that is totipotent cells, which are inner cell mass, a pluripotent cell inner cell mass. Now, which are the important cells which are important governing these monosaccharide derived cells, MDC cells, CD14A, and ovarian specific bone marrow cells. Again, these cells are extragonadal. And what is more important here, the autonomic nervous system, which is covering and governing the entire ovarian function. This we don't see, don't bother for it. Like if you understand this micro environment of the ovary, which represents the second immune system cells developing in the embryonic embryogenesis or ontogenesis, when the organs are developing, particularly gamete cells are developing, they are governed by immune system with what I'm showing, CD14, 8, and monocyte derived cells play a major role, which we are not aware. So in my theory, what I do always, MNCs use co-culturing with MSCs so as they take up the function with highest level of what you can say immune modulation, one, and second about the what you can call anti-inflammatory effect and regeneration effect. So we work on this kind of little modifications of the involvement of immune system.
Dr. Mahajan, only 2 minutes left. Dr. Mahajan, only 2 minutes.
I'll request you to give me 5 minutes more. Let me control, because this is what I want to talk to you today to understand. Okay. Otherwise, we will never understand this molecular science of infertility. My today's purpose is that to change the thought process where we are and where we want to go, where we want to practice. So these are the things which immune system in the ovaries. This also I'll show you one of them. If the young blood transfusion in the aging woman where we find infertility, total signaling factors change it. And the ovarian microenvironment can also be changed. There are a lot of applications which I have shown. Again, the effect of molecular biology in reproductive organs. In the males, I'll go a little fast. Reproductive medicine issues, I may not talk on this. All the research papers on ethical and social issues of the current system and the current gazette which is passed by the government of India in last month only, which shows the surrogacy is banned. Now we have a choice only to believe in body as a bioreactor. How do we use stem cell and growth factor or chaperones or proteins to use a final situation where we can in vivo convert these failing organs and change the microenvironment to get into promise of regenerative medicine to use stem cell therapies. So this molecular sense is over a period of 1940s to 2010 we have changed because it's going to make a next pillar of medicine, cell-based therapy for us. And in this particular, how the body is developed, this is the stage where I told you around 4 to 6 weeks where we get the first signaling pass, the inner cell mass to get into gamete cells. I have to talk a lot of things, but with the short of time, I'll be a little faster. This is where I'm showing you how the isolation of this can be done and used for the treatment germ cells. These are immortal cells. I will not go. The reproductive biology class relates to these pluripotent cells. And how do we use the stem cells for regeneration? Then it covers the entire regenerative, restore, replace, and repair system using the stem cells, growth factors, cytokines, chemokines, and Y stem cells in total tools to repair the entire system of our body. Let us, this is what is the change in current systems I showed you. Regeneration, repair does not manipulation of the hormone levels. Inner milieu changes. The entire hormone system from the pituitary gland to the ovary is changed completely with this. So we repair natural repairing system, which one of the example I told you that sometime random you will find 50 plus getting pregnant. Me shows there's a natural repair system present. Can we convert this repairing system into therapies by emerging science of regenerative medicine? Yes, it is very much possible. And which I have shown over a period of how do we use these treatments of thin endometrium and failing ovaries. How do we use them in Asherman syndrome? How do we use them? Mechanism of repairing, how it takes place using growth factors, MSCs in a thin endometrium or Asherman syndrome, where the entire fibrolytic action, we can get it from MSCs. Exospermia, regeneration plays a major role. So we have to think in a different platform, innovations when we talk from a proven therapies to unproven therapies, where I would say rather body acting as a bioreactor. So we have to think out of box. Stem cell therapy for infertility, sources which I have shown you in brief, in what are the indications where we can use it, various type of sources of stem cell, pluripotent, oligopotent, unipotent, pluripotent, totipotent. Keep on. The proof of concept has been proven on this, where role of MHSC, MSC, EPC, paracrine, and signaling pathways. Preclinical studies in animal model and stem cell resources have been worked out, paracrine factors have been worked out. These are various cell-based therapies used in various ESCs, MSCs, iPSCs, spermatogonal stem cells, used in various studies showing that the difference which we get in the management of infertility. Similar in ovarian failure, these are the various studies. Asherman syndrome, I have done a lot of patients in Asherman syndrome. How do we reduce the fibrosis? And even the capillary level where the pericytes, which are anchoring cells, pericytes, there is a fibrosis induced in Asherman syndrome because of any cause, can be reversed back. In azoospermia, in vivo infertility management, this is a very important issue where MNCs and T-regulated cells, as I told you, play a major role of immune roles. If anybody wants, they can always communicate me. I'll guide them how to use it. Like, what are the combinations we can use? Which are these cell combinations we can use? The cell combinations, growth factor combinations, transfusion of MSC, MSC activated cells, VACL cells, MSC, and progenitor cells can be used. In where, and each, when we use this technology, we have to give 4 to 5 cycles to wait the ovarian come into a regeneration. We cannot expect in 1 cycle to see the results. Proposed benefits, 3-way benefits, endocrine hormone environment completely changes. Ovarian function changes, immune system changes, and clinical benefit, POF, POC, PCOS, as well as anomalies caused because of the primary fertility of thin endometrium or Asherman's or any cause we can work out, including genetic. So over immune function, endocrine function, which some of the papers which you have done, this is a graphical presentation. How do you work on these cells to various relationships? The restoration post chemotherapy, how do we do it? Autologous PRP aspiration for this. But I have told
thank you, Dr. Mahajan.
Just 2 minutes, I'll take more, please. Because what I'm going to talk to you, nobody's going to talk to you afterwards. Rest of the talks are going to add to you more of things.
I wish we should have more time for your talk, but time is limited.
If we lose this, 25 minutes. There are a lot of molecular works which I am to show you how autologous stem cells, VACLs, and MSC.
I think I should request the organizer to give you more.
Anyway,
another
please
platform to talk. Yeah.
Dr. Mania, please allow him to have another few minutes. Let him complete.
Okay then. Okay, I don't have any problem. Okay, if the organizer wishes, then
I know you are conducting very well. Just a special request. Please continue. Complete your talk.
Okay, Dr. Mahajan, you can go ahead. Yeah.
Thank you for privilege given to me. The reason being that once we miss this, again coming back to this level will be a loss again, I'll tell you. Now, this is one of the study which we have done it is a clinical highlight study which we have done currently using the lyophilized platelet powder is one of the concepts which we have developed at our lab where we have done a complete animal studies. Now we are going into clinical studies of human being also, where the concept of having fixed concentration. Because when we use platelets in such kind of treatments, remember in a morbid patients, morbidity affects the platelet concentrations also, one. Second, this concentration also affects their secretome, which we expect VACL cell, PDGF cells, PGF secretomes, and VC vascular endothelial growth factors or various other cytokines are reduced. Secretome depends on the cell environment. If the cell environment is healthy in a diabetic patient, the secretomes are reduced, number of cells are reduced. So we don't expect the physiological and pharmacological effect from these cells. And we don't have a calculated control what number of cells to be delivered with platelets or MSC to be delivered. So we are coming from cell to molecular components, nanomolecular components like exosomes, growth factors of platelet, and these will play a major role for us to convert as a living drug molecule to target the organs with the ovary, whether it could be a round ligament where vasculature is where it comes to an endometrial thickening or a thinning, or it could be an autoimmune condition with the antibodies, autoimmune condition of uterine NK cells and uterine NK cells, mother NK cells, and placental NK cells interacting and giving a rejection in the first 1 month of the pregnancy. All these are rare causes, which probably we neglect them, saying we don't have any cause to explain. So this is what the research paper we have published, how we could do at a level where MSC exosomes or the lyophilized platelet, which are prepared in a controlled environment, is a regulated dose there are two concepts when we treat using this central technology. One is in pharmacological procedure for repairing, which I told you shown earlier, repairing procedures. When we convert repairing procedure into therapies, we have to also monitor what dose of cells are required from therapies, from a repairing system to therapies. That is what is done by this. Is a very, very critical situation here, where the same cells I'm using as a pharmacology molecule will increase 5 to 10 times concentrations in a morbid organs. Because of morbidity, infertility is there. If we use the same patient cells, same things from the same patient, the morbid conditions will not give expected outcomes in infertility. That is why most of the patients or doctors fail in the technology. Where here I want to show you how we can upcome the technology, use that in a functional way, in such a way, the body acts a bioreactor, the surrogacy or infertility issues which are there in the clinical practice can be overcome. So this is one paper recently is published. This is my manuscript again getting published. Now again the same thing is again one of the molecule which is already getting published, already accepted as a assisted reproduction journal. And this is one of my reproductive medicine where my colleagues like Dr. Bhuneshwari and Vandana Hegde are one of the pioneers. They are running their infertility centers in Chennai and Hyderabad, where I'm supporting these technologies to come up as one of the result-oriented to see the failing complicated cases like RPIs, like repeated pregnancy failures, RIPs, and those cases, how do we work up? Or resistant endometrium, not getting engraftment on the first phase itself, first day itself, or in the first day itself. Why? What is the immunological problem there? Why the adhesion molecules are not developing in the receptive endometrium? That we will have to work out with this. And with much possible, we can come over this problem and see that the future of all these science come out with the infertile couple getting their body acting as a bioreactor and proposing where the future breakthrough force that the science of stem cell technology is going to change the way we are practicing today in the future compared to any other engineering science, from tissue engineering to genetic medicine, are going to be our future. So my saying is that infertility in the future will be no more using stem cells to come to rescue. So all these things which you got as a body as a bioreactor, I'm showing some of the slides. So just understand how do we use using body as a bioreactor, just to understand you. Signaling molecule, exosomes, MSCs, then immunological factors which you are going to use to change. Body as a bioreactor, again, lyophilized platelet, which I spoke. How do we reduce fibrosis, anti-inflammation, immunomodulation? How do we use this molecule? In real sense, we assist natural facilitation or decrease regulatory environment in reproductive organ and endocrine system. That makes art of fertility using body as a bioreactor. This is a final message we would like to give you to understand. Let us work on the technologies which can give a body as a bioreactor and assist a natural repair system into the system.
Now, please conclude now.
Please, sir.
Thank you so much. Thank you.
Okay, thank you.
If you have any questions, I have a few more things were there, but let us have one more session. If you allow me next time, I'll take you to the research follicle level where we can see body acting as a bioreactor and we change our practice in future.
Okay.
Thank you for patient hearing to me.
Okay.
Thank you so much.
Okay, thank you, Dr. Mahajan. It was really excellent talk and we come to know so many things. I think it will be better to answer whatever questions they have through the chat. Now we can move to the next speaker. May I invite the next speaker?
My contact numbers and email address.
Yeah, that will be nice. Yes, that will be nice.
Management, so that those are your personal questions, they can always ask me.
Yes. Thank you very much.
Thank you, ma'am.
Okay, shall we move to the next presentation? This will be an oral presentation on reproductive and sexual health concern of unmarried youth. It will be presented by Dr. Dinesh Kumar, who is a professor of biostatistics at Department of Community Medicine, Government Medical College, Chandigarh. His research interests are reproductive and child health, adolescent health, modeling of disease of public health importance, survival analysis with concomitant variables, and Bayes and survival analysis dose responding model. He has got several awards, Best Research Award in Basic and okay. With this short introduction, I invite Dr. Dinesh Kumar to present his presentation. Over to you, Dr. Kumar.
Thank you so much.
Dr. Kumar, please.
Am I audible? May I know?
Yeah, yes, you are audible.
My slides are visible?
Yes, your slide is visible.
Thank you.
Yeah.
Thank you for giving me the opportunity to present my paper, Reproductive and Sexual Health Concerns of Unmarried Youths. Reproductive and sexual behavior of youths is posing a distinct array of reproductive health challenges. It may be due to rapidly changing lifestyle, exposure to internet and mass media, increasing stressful conditions, and absence of or lack of proper guidance and counseling. So, therefore, this study was conducted with the objectives to investigate reproductive and sexual health problems of youths.
Excuse me, Dr. Dinesh, your slides are not visible.
Sorry.
I'm unable to see the slides. Yeah.
Are you there?
Sir, I think you are sharing your whole screen. You just need to share your presentation.
Please go to your presentation.
Or if you want, we can share from here. We have your slides.
Please say.
Yeah, we'll do that. Just give a minute.
Yeah.
Sir, please go ahead now.
Okay, you go ahead. Yeah.
So, reproductive and sexual behavior of youth is causing a distinct array of health challenges. It may be due to rapidly changing lifestyle, exposure to internet and mass media, stressful conditions, and lack of proper guidance. Therefore, this study was conducted with the objectives to study reproductive and sexual behavior of youths, to investigate reproductive and sexual health problems of youths, and to explore opinions of youths regarding their sexual health concerns and barriers in consultation. Am I audible, please?
Yes, go ahead.
This study was, it is a part of a detailed project sponsored by Department of Health Research sponsored project for a period of 3 years. It was conducted in 8 states of India, including Punjab, Haryana, Chandigarh, Himachal Pradesh, Rajasthan, Uttar Pradesh, Madhya Pradesh, and Delhi state. There were 3 study groups actually. There were some clients attending the health facilities. There were some youths attending colleges and beneficiaries of NGOs. It was our target to include 640 health facility clients and 128 school college students in 8 states. 2 colleges were selected from each state. And in group 3, there were some NGO beneficiaries spread over 8 states. So this was a better representative of 8 states by using stratified multi-stage sampling. Multi-stage sampling, we were able to represent the whole state by this sample.
Sir, sorry to interrupt. Can you increase your volume? It's not very clearly audible to us.
Youths were interviewed regarding their reproductive and sexual health worries and some detailed information concerning their sexual behavior, taking proper consent from principals.
Sir, please unmute yourself. Sir, you have to unmute yourself.
You are on mute, please.
Yeah,
Dinesh. Yeah.
Yes, sir, please go ahead.
Please go ahead.
There were 3 groups. One group was of students from colleges. Second group was health facility clients. And third group were beneficiaries from NGOs. There was variability, significant variability as regarding to age. The problem.
Please go ahead. We are unable to hear from you, Dr. Dinesh.
Sir, is there any problem? Like,
I'm not getting slides. Can you hear me, please?
Yes, we can see.
We can see, sir. Sir, can you see it now?
Yes, now I am now.
Okay, sir. Please go.
So there were 32% males and 68% females we have covered. About 64% were studying currently. Next slide, please. I'm unable to change from here. About 12% were involved in premarital sexual activities, and about 15% reported contraceptive practices. There were about 11% who reported some sexual concerns were there. Next. Out of those who have reported sexual reproductive health concerns, the main concern was masturbation, reported by 24.3% participants. Next. Only 55 clients have consulted for their sexual health problems. About 47% of those who have consulted, they consulted qualified general physician. We have interviewed them what were the problems in consultation. Inadequate knowledge of consulting for sexual health problems was the main concern, and those who have reported for consultation, they were having lack of privacy or timing was not appropriate to them for consultation. And these are the presentation of opinions of youth regarding discussion on sex in the 3 groups. About 73% in first group were of the opinion that discussion about sex should be frank enough, whereas in second group restricted was preferred by 23% respondents. The project was a detailed project, but due to lack of time, we have reported only a part of the findings. So these are some summary findings. So there is some problem in sharing actually, so I could not present this in a proper way. So out of those 1,006 youths, including 322 males and 684 females, about 11% reported reproductive health concerns. Normalcy of sexual organ was a matter of worry, reported by 11% youth. Masturbation was the main worry, reported by about 24% of all those who reported sexual health worries. And only out of those who have consulted for their sexual health problems, out of those, the lack of awareness was the main issue, was the main perceived reason of not approaching for treatment. And for those who have reported for consultation, they they reported inadequate timing and lack of privacy as the main issues in consultation. So on the basis of these part of findings of a detailed project, we can conclude that there is a broad range of reproductive and sexual health concerns among youths which are emerging with time, and these issues should be addressed in an appropriate youth-friendly manner. We have to establish adolescent and youth-friendly health services which are appropriate to them, friendly to them. A holistic approach is needed, coordinating efforts at various levels. We cannot solve all the problems at the health facility alone. So we have to extend adolescent and youth-friendly services at schools and colleges level, and participation of NGOs is also required. So thank you very much.
Thank you, Dr. Walia, for the excellent presentation. And we can have 1 or 2 questions on this presentation. Any questions from the participants?
Sorry for the technical problem.
Any question? If no more question, then we can move to the next speaker.
Jayanti ma'am, I think next speaker is not there. So if you can just wrap it up and conclude the session, that would be great. Thank you.
Okay, then. Yeah. So thank you, the organizer, for giving me the chance to chair this session on fetal reproductive health. In this, we have 3 invited talks and 1 oral presentation. Dr. Nafisa talked about the paternal genomic imprinting, which are responsible for placental as well as embryo development. She described in details about the role of placenta in preeclampsia also. Then Dr. Misra, he talked about low-cost point-of-care nanobiosensor for predicting effect of environment on health and diseases. He used that word exposomes, which is a modifiable factor and which causes, means the environment factor can cause 1 in 4 deaths. So, but I could not understand which specific elements he is looking for. Then Dr. Mohammad, he talked in details about the application of regenerative medicines and its effect on reproductive health. He talks how stem cells therapy can help change the scenario of treating the different types of diseases, including reproductive health. Then Dr. Dinesh Kumar, in his oral presentation, he talked about the reproductive and sexual health issues of unmarried youths and gives that what is happening in them, how they are concerned about their sexual health and to whom they have to approach and what are the difficulties they face when they go for consultations. So with this, I request the organizer to wrap up this session and sign it off. Thank you very much.
Thank you so much, Jayanti ma'am, for wonderfully chairing the session and finishing it within the time. So, and thank you to all the invited speakers and our oral presenters. So we are moving to our next and last session of today's. It's session on reproductive health therapeutics. And the chairpersons for this session are Dr. Arun Chogle, who is Dean and Chief Academic Officer, SMS Hospital, Jaipur, and who gave a great talk yesterday, and we had his virtual birthday celebration. Thank you and welcome, sir.
Thank you. Thank you.
And the next chairperson is my mentor, Professor Krishna Mohan Medicherla, Head R&D, Birla Institute of Scientific Research. Dr. Krishna Mohan's research is mainly on microbial biotechnology. Welcome, sir. And I would request both of you to please chair this session. Thank you, sir.
Thank you very much, Dr. Nidhi Shukla, for the kind introduction and also the word of appreciations. My colleague, Dr. Krishna Mohan, it is a privilege to chair this 8th session of the ISSRF 2022 on a reproductive health and the therapeutics and the treatment, what will be there. In this session, we have one keynote address, 3 invited talks, and 2 oral presentations. The organizers have put a very beautiful, comprehensive program for this 3 days, very tight, and all the experts across the globe, they have tried to gather here virtually. The tips or the homework, I will make it here, because the keynote address, we are on time and we want to leave this session on time to the organizers back without delaying, so that our delegates can continue to take advantage and sometimes they leave because of the delay. So I know all the speakers, including the keynote, invited talks and oral, they are the expert in their field and they have huge material. One himself can talk for hours, but however, there is a limited time for our session. So I will request all the speakers, the keynote addressee will get about 25-26 minutes. So we have some time for question answer. The invited talks will be about 18 minutes. So we have about 2-3 minutes for the discussions, and oral presentation will have 12 to 13 minutes. So we have some 1 or 2 and then concluding remarks. So we keep the time schedule tight, and all the speaker, your PPTs will be on your desktop or laptop, wherever you just minimize it quickly. You can share them thing without losing the time and all those things. So it is the opportunity given by the organizers, thanks to Professor Lohia, Dr. Ansari, Barkha, and all entire team, day and night. I know very well how the conferences organization, even small or big, needs meticulous planning and all. They have done extremely well. So I take, with the consent from Dr. Krishna Mohan, I will introduce the first.
Sir, I would like to add that all the participants who have any question, please put it in the chat box.
Yes.
Thank you.
That we can pick up the questions while that thing, that's much better, and then put on muted so that so I introduce the first speaker. He's a keynote address and giant personality in this area of the work, and he will be talking on the future of stem cell therapy. Search for a safe and therapeutic efficient stem cell for organ presentation. Maurice Ratajek, I think I have pronounced properly. He is internationally known specialist in the field of adult stem cells, and his 2005 discovery embryonic-like stem cells in adult bone marrow tissue has the potential to revolutionize the field of regenerative medicine. And he is the editor-in-chief of the Stem Cell Review reports. A lot of reports he has published, over 575 publications, about 20,000 citations. You can just imagine the kind amount of work he has put in. So without wasting time, we want to listen him and his research. So I hand over the floor to Rahul Gadjah for his keynote address. Welcome, floor is yours.
Thank you so much for your kind introduction. And I would like to thank very much for invitation to this great meeting and express my gratitude to organizers and Dr. Deepa Bhartiya, who invited me to present my talk. I hope you can see my screen right now. And the question we would like to ask today is if there are pluripotent stem cells in adult tissues. This means pluripotent stem cells which could give rise to all three germ layers, to ecto, endo, and mesoderm. And I took this slide from one of the publications of Dr. Deepa Bhartiya and explains very nicely reasons why it is so sometimes very difficult to convince some people on the presence of pluripotent stem cells in adult tissues. Because first of all, it is very difficult to isolate these cells. Second, most of the previous evidence was based on indirect data and not on single purified cell level. It was also overestimated hope and enthusiasm that embryonic stem cells and induced pluripotent stem cells will move quickly to the clinic. Of course, it is also here a competition issue with embryonic stem cells and induced pluripotent stem cells lobby. And a lot of damage to the field was by false concept of stem cell plasticity. And actually, during this concept of stem cell plasticity, my team discovered these cells. As you remember, 20 years ago, it has been postulated that hematopoietic stem cells isolated from bone marrow can give rise to all tissues which are shown here at this slide. This, however, was not confirmed later by other investigators. And there have been proposed different explanations like cell fusion, but my group from beginning was postulating that in the adult tissues, there are present some very primitive dormant pluripotent stem cells. And we actually considered two scenarios. We know that pluripotent stem cells are inner cell mass of the blastocyst, like here in scenario number 1, and certain points they make rise to tissue-committed stem cells and disappear from organs, developing organs. However, we have considered another scenario that maybe it is not like this, that pluripotent stem cells give rise to tissue-committed stem cells shown here as blue, but they still survive and remain in the adult tissues in dormant state as backup population for tissue-committed stem cells. And by employing multi-parameter cell sorting, we have isolated such very small cells, first from murine bone marrow, from human bone marrow and human cord blood. Later on, other groups like Dr. Deepa Bhartiya and Irma Virant-Klun isolated such cells from gonads, female and male gonads. And here is shown electron microscopy picture of this small cell to the left. And as you can see, it contains very primitive nucleus, a very tiny rim of cytoplasm with mitochondria. These cells express OCT4A, NANOC, and also stage-specific embryonic antigen 1. You can see here, in contrast to hematopoietic cells, these cells are much smaller. They are diploid, they have normal number of chromosomes, and here is an evidence that exclude 7ADD. This means these cells are viable. And here at this slide is also shown picture on the top of such vessels, very small embryonic-like stem cells, isolated from human cord blood, and below from mobilized peripheral blood from young adults. And we perform a lot of molecular analysis of these cells. One of the examples is here. We have compared gene expression in our vessels, and in comparison to hematopoietic stem cells, mononuclear cells, and embryonic stem cell derived cell line D3. Data with murine cells, and as you can see, these cells express very highly many genes involved in pluripotency, epiblast development, germline specification, and germline development. And we have then proposed that germline, because they express many markers of germline, is probably a skeleton scaffold of stem cells in adult body. This is very primitive cells from very close to germline. We call them V cells, are deposited in adult tissues as backup of stem cells for regeneration. They remain in quiescent state, but could be activated during tissue organ injury and play a role in tissue organ rejuvenation. And as for today, more than 50 independent laboratories worldwide and different continents have confirmed a presence of the cells in adult human urine and in rat tissue. Here also, most recent papers, as you can see, this means these cells are right now widely acknowledged that they exist and they are of very important potential. Here, what we have also proposed long time ago, that these cells mostly are enriched in bone marrow, but also present in other tissues. They could be mobilized, egress, circulate in peripheral blood during tissue organ injuries. And as you can see here, there are some examples that indeed in human heart infarct, in urine model of heart infarct, in stroke, but also in several other clinical conditions like skin burns, intestine inflammation. Such cells are mobilized, circulate in peripheral blood, and markers of these different states. What is here also very important, as you can see, we have postulated that with discovery of these vessels, we can much better explain the hierarchy of adult stem cell compartment. The cells we believe are in dormant state, but on top of this stem cell compartment, and also tissue organ rejuvenation, aging, longevity, and origin of malignancies. First, role of vessels in tissue organ regeneration. The most important problem at the beginning, especially for vessels isolated from bone marrow, was that they were in a quiescent state. And we had first to wake up these quiescent cells that they will start proliferate and become specified in different tissues. And why they are so in quiescent state? They are in quiescent state because of erasure of somatic imprinting. It is shown at this slide, everything in red. It is germline, the most important germline, because it transfers genes and mitochondria to next generation. Of course, we developed from most important primitive stem cells, fertilized zygote. And here, everything in red is germline potential. It is still in a proximal epiblast, where some of cells are specified to primordial germ cells and give later on rise to gametes. But also here, what we believe in epiblast is some of the cells are specified to very small embryonic-like stem cells, which are precursors of other stem cells. And these cells are deposited in developing organs. And at least it was reported for germline that germline cells, primordial germ cells, when they migrate from epiblast to genital ridges, they erase somatic imprint, and it is mechanism to keep them quiescent and prevent from teratoma formation. And here at this slide, you see most important genes which are shut down and make quiescent because of this erasure of somatic imprint. These genes are involved, as you can see, in insulin and high growth factor signaling. This will play very important role in cell proliferation, but also initiation of embryogenesis and proliferation of pluripotent stem cells. And one of the most important tandem genes here is insulin growth factor 2, H19. Insulin growth factor 2, of course, stimulate proliferation. H19 is non-coding messenger RNA, which give rise to several microRNAs which inhibit proliferation. This means it's a kind of balance between expression of IGF-2 and H19. And here is a molecular mechanism which gives this parental imprinting and IGF-2 H19 locus. These two genes are separated here by the differently methylated region. Methylated here sequences are shown in black lollipops. When it is not methylated region on maternal M chromosome, because P is paternal chromosome, and maternal chromosome binds here insulator and make a boundary between both genes. Expression of both genes is regulated by distal enhancer. And as you can see here from maternal chromosome, because here is a boundary, is transcribed only H19. In contrast, because it's not boundary here made by CTCF on paternal chromosome, distal enhancer induce expression of IGF-2 from paternal chromosome, but it is a balance. But please pay attention here to this methylation sites, what happened during erasure. This erasure occurs in primordial germ cells, but also in V cells. Both loci are demethylated, both here differently methylated regions bind CTCF, and as a result of this, from both the genes is expressed inhibitory H19 messenger RNA, giving rise to inhibitory microRNAs. And it explains why these V cells, like primordial, migrating primordial germ cells, are quiescent. And here is a molecular evidence that it is true. We have isolated very small embryonic-like stem cells and hematopoietic stem cells, and we look for methylation and this differently methylated region between IGF-2 and H19 locus by sulfide modification and sequencing. And as you can see, V cells have erased here this loci, in contrast to hematopoietic stem cells, which have 50-50 of methylation. As a result, V cells have high expression of H19, very low expression of IGF-2, in contrast to normal hematopoietic stem cells. This means from beginning, it was for us clear that we have to do something to remethylate this erased loci to force V cells for proliferation and employ them in the clinic. And here is shown a mechanism, how this erased loci are again methylated. It is a job of 3 different de novo methylotransferases. Most important here is DNA methylase 3L, which not alone but in cooperation with 3A and 3B can again remethylate erased locus on IGF-2 H19 and also on other differently expressed parental regulated genes. And what we have found that this DNA methylase 3L is chaperoned by SIR2-in-1. And when we add nicotinamide, this complex is released. DNA methylase 3L is released from SIR2-in-1, can aggregate with 3A and DNA methylase 3B, and again remethylate erased locus. We have described this phenomenon to occur in murine and human cells, and then we were able to develop a protocol, what is very important and breakthrough for potential application of these cells to use in the clinic. And as you can see here, you can see this very small embryonic-like stem cells on the top. You can barely see them after isolation by multicolor staining and FACS sorting. But if we put the cells in medium with artificial serum and in presence of nicotinamide, and we stimulate them with sex hormones, we add here folliculo-stimulating luteinizing hormone, but also a mixture of mesodermal growth factors like BMP4, FGF2, we can expand these cells up to 3,000 times. And as you can see here on size, we can get what is very important for stem cells, asymmetric division. We still have very small embryonic-like stem cell likes and more differentiated cells which express a lot of germline markers. Now, what is implication of these cells for aging? Again, as you can see here, our V cells somehow downregulate expression of shown here in the red genes, which are involved in insulin-like growth factor signaling. And it is very well known in animal world whenever we have a defect of insulin-like growth factor signaling, genes can have different names, pending if this is bacteria, yeast, if it is C. elegans, Drosophila, or mice. They can have different names, but one common feature is that always is smaller size of such affected individuals, where is defect in insulin-like growth factor signaling, but also is a longevity. All this, here shown species are living much longer where it is defect in insulin-like growth factor signaling. And looking, in humans, we know that right now probably the best way to extend longevity is caloric restriction. What is doing caloric restriction? Down regulates growth hormone, insulin-like growth hormone, and insulin level. And this leads to extension of lifespan and also lower risk of cancer. But it is also a reversal of this equation, that high caloric diet upregulates growth hormone, upregulates insulin-like growth factor and insulin, and then we have decrease of lifespan and higher risk of cancer. And to address this question, that our V cells somehow downregulate expression of insulin-like growth factor signaling genes, we went to mice, long-living mice, and we have found that several murine strains, like Laron dwarf mice, Ames dwarf mice, which have defect here, for example, undetectable low plasma IGF-1 level in peripheral blood, are living much longer, up to 4 years, in contrast to control mice are living only 2 years. In contrast, we have overexpression IGF-1 of growth hormone, we have short-living murine strains. And here we have reported already, and we have shown that these long-living murine strains, here is shown Laron dwarf mice, much smaller than control animal. They have a much higher number of V cells in bone marrow and different organs, and living much longer. And in addition to this, we have been also looking, in ovaries, and as you can see here, we have found that ovaries from Laron dwarf female mice at age of 2 years have still active ovulogenesis, in contrast to wild-type mice. These mice are about to die. Laron dwarf mice, they have still 1 or 2 years to go. And we got even pregnant Laron dwarf mice at age of 2.5 years. You can appreciate this when you know how quickly reproductive age in experimental mice stop. And here, to confirm this, there are excellent papers from Dr. Deepa Bhartiya and also Irma Virant-Klun from Slovenia, showing that in ovaries we have a population of very small embryonic-like stem cells, and they have very nice, exciting data that they could be precursors of gametes. This means we can conclude here, looking for longevity, that very small embryonic-like stem cells are gradually during our life burned out in metabolic fire of insulin and insulin-like growth factors. This means if we look here on number of vessels in murine bone marrow, as you can see here, number of these cells decreases with the age. And now all anti-aging strategies should be targeted to slow down this decrease, to extend lifespan, because these cells are our policy for life and play very important role in tissue organ rejuvenation. And actually we have already some data showing on effect of positive effect of caloric restriction on number of these cells in mice model. And also that endurance exercise, regular exercise in mice, they were running every day on treadmill, has also beneficial effect on these small cells in adult tissues, and it is also effect on insulin-like growth factor signaling, because all this here procedures decrease level of insulin-like growth factor signaling, and has beneficial effect of longevity and number of vessels in peripheral tissues. Last here a few slides. Possible role, if something is going wrong, of the cells in cancerogenesis. And again, here is insulin signaling. We know that in the T cells, this signaling is somehow damped because of erasure. But what happened if it is upregulated? It suddenly, this signaling is upregulated. Then we have more cancer. And if we look in the history, 100, 200 years ago, it was proposed in many pathology books by Rudolf Virchow, Julius Kornheim, embryonal story of cancer development. These pathologists had some ideas that in adult tissues are very primitive cells from embryonic development. At the time, nobody was calling still stem cells, but they had some ideas or some remnants from development which give rise to cancer. And we believe that our vessels are right now explanation of this vision these pathologists had in the 19th century. And what is that data supporting that some cancer can develop in germline compartment? The best presence of classical germline tumors, which can be in gonads, in mediastin, and even in brain. Second, many cancers, type of cancers, which on first sight don't have any connection with gonads, express cancer testis antigens. Like we can detect these cancer testis antigens in lung cancer, in stomach cancer, in different type of cancer. This mean also indicates on germline origin. And in fact, our vessels have very high expression of this cancer testis antigens. Second, expression of some markers like chorionic gonadotropin or carcinoembryonic antigen, which is very often used in cancer diagnostic, also indicates link to germline, and expression of OCT4 by several tumors. And generally what we believe that these cells have three different scenarios how they can contribute if something is going wrong. These very precious cells, but you know, if they go on this another side, dark side, they can become, you know, like Jedi, you know, unfortunately, bad warriors. First scenario, they can fuse probably with somatic cells to create aneuploid cells, and then also to generate tumor. And third scenario, vessels could be mobilized into peripheral blood if it is a growing cancer, because they have false impressions that it is here probably some organ which is hypoxic, and they provide vessels and stroma for growing tumor, but it is also in case of tumor, just tumor promoting effect. This means we can summarize here that in steady state condition between vessels and insulin growth factor signaling should be a balance. When insulin signaling prevails, is accelerated senescence and tendency to cancerogenesis. But when this insulin signaling is low because of caloric restriction, strenuous exercise, maybe some drugs like metformin, resveratrol, Dr. Deepa Bhartia had very nice data showing that resveratrol increases number of vessels in adult tissue. We have prolonged longevity, lower risk of cancerogenesis. And now, at the end, what is very important in science, we have beware of dogmas. And as Albert Einstein said, blind belief to authority is the greatest enemy of truth. And also what Max Planck said, one rule is important in science, only courageous people win. And we have to ask courageous questions. This means a time when we are a little bit at stem cell war, which cells we use in the future as pluripotent, embryonic induced, we know there are a lot of problems with these cells, genomic instability, and also teratoma formation. We should focus on using, and studying this adult tissue derived pluripotent stem cells. And one of my last slide here is, this very famous, all this very famous gentleman here and politician, which very well fits to all these people who can just ignore presence of pluripotent stem cells in adult tissues. In conclusion, the quest for pluripotent stem cells that would be widely accepted from ethical point of view and safe for clinical use still continues. And evidence accumulated that adult tissues, my group focused on bone marrow, other groups like Dr. Bhartia and Virant Klun has shown presence of these cells in gonads, that such cells exist. And in particular, our new vessel expansion strategy will allow to employ these cells in clinical settings. And also an important aspect of anti-aging strategies would be to make these vessels happy in adult tissues. They have to survive in the best condition during our lifespan, because these cells are important in tissue organ rejuvenation. And we have also to think here about pharmacological means to modulate not only metformin, but probably better maybe drugs or resveratrol to keep the cells quiescent, but also diet and physical activity. And I would like thank you for your attention, for invitation to this great meeting. I would like to thank people who are working with me or were working at the University of Louisville in stem cell program, and also my collaborators worldwide here listed, Dr. Radajca, Kucha, Dr. Kakar from Louisville, David Smadia from INSERM, of course, Dr. Deepa Bhartia from India, and many other investigators. Thank you so much for your attention.
Thank you, Professor Radajca, for an excellent talk and overview of the stem cell and potential of the stem cell, but also you have given some tips that how to search for the safe and efficient cells, stem cells, and also carcinogens and the stem cells. And also you nicely quoted Mahatma Gandhi's things. Are there any questions from the participant?
Yeah, can I ask a question?
Yeah.
So, fantastic talk, Dr. Radajca. My question is, by any chance, could you look at the genome integrity of these VS cells in terms of DNA repair enzymes and telomerase activity?
Yes, it is a very good question. Yeah, it was, of course, no time, to present all our data. Yes, they have very high expression of telomerase, and also what is, I was showing this, the de novo metylotransferases are at very high expression. They have also, resistance, to the many cytostatics. They are somehow resistant, more resistant than other cells to irradiation. This means they have very robust repair mechanisms.
Great, fantastic. Thank you.
There is another question. Somebody has raised their hand.
Can I ask the question? This is Dr. Malini. Yeah, wonderful talk, Dr. Razak. I had 2 points. One is, since you connected it with NAD metabolism, do you think that one could potentiate VSELs by giving, modulating the NAD metabolism?
Yes, yeah. Actually, metabolism plays a very important role in these cells, and even, because many of participants here are dealing with infertility. That one of important also strategies to treat infertility, especially in obese women, is to decrease body weight, to go on some diet, use metformin, and this everything modulates insulin-like growth factor signaling. This means it fits very nicely how to, for example, increase robustness of the cells in gonads, that we can maybe in the future will use these cells to treat infertility.
So again, just continuing that is what I was thinking, that in POF kind of disorder, looking at VSELs could be interesting. That is, would they have low VSELs?
Number of the cells decreases with the age. We are born with high number of the cells, and we age with time. It is why all this regeneration we see is much more robust in young people than in older people, and it could very nicely explained here by number of the cells in adult tissues. This means definitely it is here a correlation between the number of the cells, regeneration potential, and metabolism here plays a very important role to keep these cells robust and somehow to slow down a curve of elimination of these cells during our life from the tissues, because they are a kind of policy for life. We believe that they are in dormant state in adult tissues, but they can give rise, in particular in emergency situation, to tissue-committed stem cells.
I think from the admin there is a question. Prash, yeah, what is?
Yeah, thank you, sir. Thank you, Dr. Marius, an excellent talk. I was just wondering, post-COVID times, hematopoiesis has been making a big merry out of patients. In bringing up the build of hematopoietic stem cells, where do we see the future of extracellular vesicles in lieu of therapeutics? Where are we going here in this direction?
Yes, it was also you ask about potential of these cells in hematopoiesis. I understood.
Right.
We don't have so. I didn't have so much time, but we already published several papers showing that in fact these cells isolated from the bone marrow, they could be specified into hematopoietic stem cells. And also we have right now a paper which will appear probably this week in Leukemia, showing that these cells give rise also to endothelium. This means definitely this we envision here that these cells are on top of the hierarchy also of hematopoietic stem cell compartment, and they are the best candidates for hematopoietic stem cell expansion. As you know, right now there were proposed many different types of hematopoietic stem cells. Different investigators are using different phenotype, but the major problem is that still we don't have efficient expansion protocol of hematopoietic stem cells, because usually these cells become very rapidly specified to progenitors, progenitors expand, but is decreased in the primitive stem cell number. We believe that V cells are on top of the hierarchy. They give rise to primitive hematopoietic stem cells, and they are the best population to employ in hematopoietic expansion. And we are working right now on this, and we believe it will be very important strategy to have expand, a source of stem cells for hematopoietic transplants.
Thank you. Then there is a question from Dr. N.K. Lohia, I think.
It's not a question. I thought I give my observation comments, and couldn't resist complimenting for a wonderful talk. And at the same time, I was wondering whether Dr. Deepa is available and would like to.
Yeah, I'm very much here. Thank you so much.
I know you cannot miss this, and I appreciate your inputs also on behalf of the society for making this possible to arrange his presentation, which we greatly value. And in case you have any comments, I thought that maybe it is the right time, though we appreciate the time constant, but you can give the comments and your observation on his presentation.
Yeah, thank you. Thank you so much, Marcius, for a wonderful talk. Really wonderful listening to you. And we have your article also in the newsletter. So all my colleagues can go back and read your article there. And we hope these cells will soon come to the clinics. And we will be also able to manipulate them to treat cancer, manage cancer in near future. Thanks so much for a wonderful talk. And thank you so much for being awake early in the morning to give the talk.
So there is a question in the chat box from Dr. Sudipta Panda. Do VSCL cells play a role in spermatogenesis?
Yes.
Yeah, actually,
so
it is the best question to ask Dr. Bhartiya.
Yeah, yesterday also I showed some part of the data. They have a very important role, and we can share that. We can discuss further. Sure.
Yeah, just one question.
I'm going to discuss in my talk about spermatogenesis.
Okay, just one question to Marcus. Now, these stem cell therapies, what are the practical and ethical issues to make it as a routine and available technique? Just in short, what you see in the future and how long it will be going to take it to make it into the clinics?
Number of cells.
Yeah, it was a question to me. Yeah, first of all, we need to have, we know very well that, hematopoietic stem cells, mesenchymal cells are employed already in the clinic. But we want to have pluripotent stem cell, which can differentiate in all three germ layers. And, thinking about clinic, I mentioned, and maybe I don't want to play advocato diaboli, but embryonic stem cells and induced pluripotent stem cells have a lot of problems. It's a lot of effort, a lot of money put here in this research, but we know that they have genomic instability and they give rise to teratoma. We have to look for cells isolated from adult tissues, and these cells are such candidates, but need definitely more brains working on these cells, more hands, more experimental involvement. And right now, because we developed this strategy for ex vivo expansion, what is very important by modulating genomic imprinting, we believe that we are coming to the moment that we will have enough of these cells for therapy. Because before, these cells were very rare, isolated from adult tissues. It was very difficult to employ them, for heart infarct or maybe stroke or other problems, health problems. But now with this expansion strategy, we believe we will have enough of the cells to start first clinical trials. And I think that in the next years, we will witness a lot of developments here in this field.
Yeah.
Thank you very much. Excellent.
Can I just say one thing?
Okay.
Moreover, these cells, they differentiate into the adult counterparts, whereas embryonic and iPS are failing to differentiate into adult counterparts, and therefore they don't have that regenerative potential. So these are the cells that really have the potential to treat adult cell types.
Can I have a little additional talk on this regulation and this issue? How to take to the clinic? I mean, the
just in short, because we have to keep up the time. Just in brief.
In brief, I'll explain you. When we talk of ACL cells or embryonic stem cells, I'll brief an idea about it. Like when we look into a clinical practice, we need to focus on two areas. One, we look into an autologous origin and allogenic origin. When we ACL cell we are talking here, we have to look into area of autologous origin. And the embryonic character, which we have seen throughout the process, having an embryonic cell as an embryonic character and VACL cell, there's a big difference. VACL cell is present in the adult. Embryonic cells are not there, but those are the markers. So the potential of getting into a tumorigenicity or malignancy is very less compared to with VACL compared to embryonic stem cells. And when we work of them into one set go by a double spin technology, which one of the Deepa Bhartiya's paper publishes, how to isolate them in the clinic and how to proliferate them. Probably if we can work up, I don't find any problem in a single go, as a surgical procedure, we can still use VSCL cells into rejuvenation of many of the autologous organs also. I believe Deepa Bharti will agree with me.
Yes, sir, yes. Sir.
Okay. So once again, thank you, Marcus, for the excellent talk and overview. And now I request Dr. Krishna Mohan to take over, introduce the invited speaker.
Thank you, sir. We'll move on to the next invited talk. This talk will be given by Dr. Om P. Sharma. He is an Executive Director, Clinical Development Oncology at Hungary Pharmaceuticals, Princeton, USA. His research interests are, he's a physician scientist, and his laboratory has a multifaceted research program with long-term interest in placental biology, reproductive immunology, pathogenesis of pregnancy outcomes, and utero-immunoprogramming of these diseases. So without wasting much time, I would like to invite Dr. Om Sharma to deliver his talk on emerging role of PRP inhibitors as precision treatment option in prostate cancer, patients with prostate cancer. Dr. Sharma.
Dr. Mohan, thank you very much for the. Okay. Sorry. Okay, I was just trying to see if my slides are visible.
Yeah, it should be the.
Okay. So thank you very much, Dr. Mohan, for the introduction. I would like to really take this opportunity to really express my gratitude to organizers, especially for Professor Lohia, Dr. R.S. Sharma, Professor Ansari, Dr. Barkha Khilwani, and Dr. Chogle. Thank you very much for chairing the session and for the opportunity. So I will briefly talk about the emerging role of polyadiporipose polymerase inhibitors as a precision treatment option for the patients with prostate cancer. I will start my talk. Okay, I think let me see if I could do it. Is this size is visible or should I?
You can go to the presentation mode. It is,
okay.
But yeah, it's okay. Fine.
Yeah.
Yeah. Okay. Thank you. So I'll start with a brief background of the prostate cancer and its prevalence, even though it is pretty much very well known to all of you. But briefly, I will start with that, and we'll review the current status of the treatments what we have available as of now, and why do we need additional treatments, for example, in the going in towards the precision medicine. And in order to that, there are molecular pathways in the prostate, such as polyadiporipose polymerase and homologous recombination repair, and how these pathways, molecular pathways, are responsible for the cancer in prostate, and how we could really exploit those molecular pathways to develop for the treatment. And then I will briefly just talk about the one of these pathways inhibitors. Inhibiting those have resulted into the treatment of prostate cancer, and will end up summarizing with the opportunities and challenges with prostate cancer research. So regarding the background, as you know, that androgen receptor is a ligand-inducible transcription factor that plays a key role in the initiation, growth, and the progression of prostate cancer. Therefore, the obvious target is this androgen deprivation therapy, which has been exploited in the past, and that what it does is inhibit the androgen signaling axis, and that provides the first line treatment for the advanced prostate cancer. However, despite androgen deprivation, progression and to castration-resistant prostate cancer has been still very common due to the restoration of androgen receptor signaling. Yeah. So androgen receptor participates in tumor progression via these three ways or mechanism. So expression by activation and the upregulation of receptor activity, point mutations, and ligand independent activations. Yeah. I hope you can see my cursor. So the prostate cancer is still globally the second most diagnosed cancer type in men, and lifetime probability of developing prostate cancer is approximately 12.5%, and obviously it's higher in the older population, more than 70 or 70 years, older than 70 years. Approximately 268,000 new cases and more than 34,000 deaths are estimated in the US for this year alone. So far, the incidence rate has stabilized for the local stage disease because of the development of early detection as well as a lot of treatments, but it has increased by approximately 4% per year for regional stage and about 6% per year for the metastatic stage disease. Therefore, the prostate cancer diagnosed at metastatic stage increased from 3.9% to 8.2% over the last decade. This to just give you a brief idea of the different trends in the different cancers. Prostate cancer has gone down, but in the last almost a decade, it started going back again. But that is where it is going higher is if you look at the 5-year survival rate. So normally for localized and regional cancer, it is pretty much more than 99%. But if cancer is diagnosed at the later stage or metastatic stage, this is pretty high. The survival rate is only about 30%. So what we have as of now for the advanced prostate cancer, including the metastatic and even metastatic cancer stage, we have androgen deprivation therapy, which is most of the, even the early stage cancer, they will start with that. And then we have first generation androgen receptor axis targeting agents, flutamide, bicalutamide, and nilutamide, which have been in use for decades. Then we have next generation androgen receptor axis targeting agents, which are relatively new, abiraterone, enzalutamide, apalutamide, darolutamide. Some of those have come out of my own group's research. Also we have taxane-based chemotherapies, docetaxel and cabazitaxel, radiotherapy, for example, radium-223, and immunotherapy, sipuleucel-T. So although all these drugs have improved outcomes in the past decade, but metastatic prostate cancer remains invariably fatal. Therefore, new therapeutic strategies involving genetically stratified approach to develop personalized treatment options are really needed at this point. So there is, as I mentioned in the beginning, that molecular pathways which we can really exploit. Two of them are here, poly-ADP-ribose polymerase and homologous recombination repair pathways, which are responsible for the prostate cancer, and how we can exploit them to develop treatments. So we know that cells are constantly subjected to DNA damage, and those could be either due to endogenous or exogenous environment resources. Inability of cells to repair DNA damage, or even damage is repaired but it is faulty, that result into genomic instability, the accumulating mutations, and that will eventually lead to cancer. So therefore we know this, that genomic instability is a hallmark of cancer. To maintain DNA integrity, cells have evolved multiple execute mechanisms to repair DNA damage. And here just an example in this cartoon, that DNA damage could be of a different type. For example, single strand breaks, double strand breaks, bulky adducts, and mutations. And these are just standard ways which DNA repairs itself. So single strand breaks are repaired by base excision pair, and double strand breaks are repaired by either homologous recombination repair or non-homologous end joining. And the bulky adducts are repaired by nucleotide excision repair, and mutations, they are repaired by multi-match repair. Now these polyadiporipose is a post-translational modification and signaling molecule that regulates many of the aspects of human cell biology, including the DNA repair. It is synthesized by polyadiporipose polymerase enzymes, and one of the earliest events in DNA damage, what happens once the DNA damage happens there, whether it's single-strand DNA damage or double-strand DNA damage, this PARP1, which will rush to the site and will bind to DNA, and it will result into the activation of and the synthesis of polyadiporipose chains. Those could be single chains or those could be multiple chains, and will repair the DNA damage. Now this mechanism or this pathway, how it could be exploited for the treatment development is the current focus. So we know that in the prostate cancer population, about 20 to 25% of cases are with DNA damage repair genes. And most of them, out of that, the BRCA2 is the most common one, which is approximately 8 to 12% of cases. Now this DNA damage repair defect can induce tumor-specific vulnerabilities that can be exploited to treat cancer using drugs that interfere with DNA damage repair mechanism, and will this mechanism causing cancer cells to stop replicating and they will die. So BRCA1 and 2, as I said, those are the main, or I will say most common or prevalent enzymes where genes where you see the mutations. So dysfunction of BRCA1 and 2 will normally sensitize cells to inhibit PARP enzymatic activity. And because of there is no PARP enzymatic activity, it will result into chromosomal instability and eventually cell cycle arrest and subsequent apoptosis. Therefore, inhibition of this PARP will result into persistence of DNA lesions, means DNA lesions will remain there, will not be repaired, which would have been done in the normal situation, and that will result into genomic instability, and prostate cancer can be utilized to guide more precise cancer therapies, such as incorporating this PARP to inhibit the DNA damage repair in metastatic castration-resistant prostate cancer to usher in the era of precision medicine. That is what the goal of this talk is. So this is just to give you a background that, as I was saying, BRCA2 is a most abundant mutation in the prostate cancer, and this is very well characterized, and it is involved in the DNA damage repair mechanism. ATM, another enzyme, or sorry, another gene functions as DNA damage checkpoint, and it's indirectly activate homologous recombination repair. So PARP proteins are DNA damage, as I alluded earlier. They are sensor and signal transducer. So they bind to single strand breaks and synthesize polyadiporipose chains on target proteins. This process is also called polyadiporibosylation in the vicinity of DNA breaks, and itself means they are also free from after the DNA damage repair has been done, so they can go back and in the normal state. In normal cells, these breaks are repaired by homologous recombination repair mechanism, which is another pathway, as I mentioned earlier. However, in the homologous repair deficient cells, these single strand breaks will lead into double strand breaks because those are not repaired, and failure to repair these breaks result into cell death. So mutations in the BRCA1 or 2, ATM, and other genes, there are maybe other 14, 15 other genes. They are either directly or indirectly related to homologous recombination repair mechanism. They are associated with the aggressive growth in the prostate cancer, metastatic castration-resistant prostate cancer. So alteration in this DNA damage repair genes that confer sensitivity to PARP inhibition in prostate cancer. The response to PARP inhibition may occur through two different distinct complementary mechanism. One is the catalytic activity and another is PARP trapping, which I will talk a little bit later. Okay. So this cartoon is just to show that there are PARP inhibition, how it really get into the cell death. So any of these mechanism, whether it's PARP1 or BRCA by itself, is not a synthetically lethal. So this is here to show the concept of synthetic lethality. So if PARP1 is active and BRCA1 is active, means they are not mutated, then the cell repair will be a normal process. But if one of them is, for example, in this example, if BRCA1 is mutated, but PARP1 is still normal, then still cell will repair the DNA damage. Same thing if the BRCA is normal and PARP1 is mutated or is inactive, and using like sequence, the drugs being developed, still the cell will repair. However, if the cancer drug, which is affecting the PARP1 or inhibiting PARP1 activity, at the same time, if this cell has a homologous recombination repair defect, that cell will die. Therefore, these drugs which are being developed to inhibit the PARP1 activity, if they are DDR DNA damage repair deficient cells, then these drugs will work. This is the mechanism again showing in this cartoon that how PARP1 PARP inhibitors they act. So PARP inhibitors will inhibit the PARP1 and stop the single strand DNA damage repair. And this works via two pathways. One is the base excision repair. It will inhibit that, as well as it will also act through PARP trapping, which is a physical mechanism which stops the replication of PARP, and that will lead to double strand DNA double strand breaks. They will remain they will progress to from single strand break to double strand break, and in the patients who have homologous recombination system is still active or non-mutated, that will still continue to the DNA repair. But if those cells are deficient in the homologous recombination repair, those cells will die, and that's how these drugs are being developed to take advantage of this molecular mechanism. So these inhibitors have been developed. A couple of them are already in the prostate cancer. And so these, I want to briefly mention that currently olaparib and rucaparib, they were approved in year 2020 in May, almost a couple of weeks apart. So first of them was rucaparib, that is about 600, not about, that is 600 milligram BID dose. It received approval by FDA for patients with metastatic castration-resistant prostate cancer harboring deleterious or suspected deleterious germline somatic BRCA1 or BRCA2 mutations, and who had previously received therapy with novel hormonal agents like enzalutamide or abiraterone, plus one taxane-based chemotherapy. And within a couple of weeks, another drug, olaparib, was approved for 300 milligram BID for the same patient population for deleterious or suspected deleterious germline or somatic homologous recombination repair gene mutations in at least one of the 14 genes. And this is, I'm reading because these are the indication in the approval of these drugs. And these patients were also previously treated with enzalutamide or abiraterone. These are the next generation androgen receptor inhibitors. But olaparib is not recommended to be used in the patients with PPP2 or 2A mutations because these mutations did not show efficacy in clinical trials. With that, I will summarize with opportunities and challenges in this area of drug development. So with the current deeper understanding of molecular makeup of tumors has brought opportunities to develop more precise treatments targeting tumor vulnerabilities. PARP inhibitors are example of this step towards precision medicine. And this also has a big advantage that these are sort of targeted therapies. So you will spare the normal cells. So reducing the toxicity significantly. And these mechanisms are also being explored for the combination therapies, because as you know that androgen receptors signaling is very much involved in the both generating prostate cancer as well as controlling that or treating that. So combining these PARP inhibitors with androgen receptor antagonists is another way to explore this, which is currently being done. I know a few trials are already in progress. This is an example of phase 3 trial, which is including olaparib, which is a PARP inhibitor, and with abiraterone acetate, which is the next generation AR inhibitor, is in progress. And we have a similar trial ongoing in the company where I'm working currently. So we with that, it's not that we have already got to the smooth surface. Still, we have challenges, and some of them I have listed here. So important is to develop validated, better predictive biomarkers, which is we do have biomarkers, but not so precise. We need better than that, and so patients can be stratified easily in clinic which patients should receive these PARP inhibitors and which should not. So that is needed. The other thing is that DNA repair deficient tumors need to be identified more precisely. Again, that is being done, but still there is a room to make improvement there. And then physicians should have access to these technologies to support their analysis of genomic data and their interpretation, because making that easier for them in clinic will be helpful to select the right patients for the PARP inhibitor therapy. So to summarize my talk is that we have successfully developed PARP inhibitors, and that has resulted in effective therapeutic option as a precision medicine in prostate cancer. But of course, it's in the beginning phases. And these treatments exploit tumor vulnerability that in normal conditions make these tumors more aggressive and constitutes one of the prime examples of success in the precision medicine to date. With that, thank you very much for your attention, and I'll be happy to take any questions.
Thank you very much, Professor Sharma. We can take 1 or 2 questions from the audience, if there are any.
This is Nafisa. Can I ask one question?
Please.
Good talk, Dr. Sharma. I just want to ask whether this PARP inhibitors will work only when there is a BRCA1 or 2 mutation?
So yeah, that is very good question, because one of the things is we are currently going through is we are saying beyond PARP. So these are initially, because as you know, the PARP2 is about I showed 42%. Over 42% compared to all other genes. So that is one of the reasons was the first target. However, we are finding that, like I can tell you, currently we are doing phase 3 clinical trial, and I think another trial is going to declare results on 17th of this month. These PARP inhibitors are, if not equally, they are still working for even beyond not only the homologous recombination repair gene deficient patients, but also to the normal population. But we don't know those results yet, but that's the direction we are going. We means the entire group who are developing these PARP inhibitors.
Second question is, will this not affect the normal cells?
That is the main objective here, not to affect the normal cells, just to work on that is why it is targeted therapy. And that is why I have used the word, which is from the literature also, precision medicine, because that is the goal. Go to precision medicine, because a lot of cancer therapies, in my different therapeutic areas like breast cancer, lung cancer, etc., we have these chemotherapies, and a lot of the chemotherapy has so many of side effects. So idea is to have two things to achieve. Is one, to precisely identify the patients who are really candidate for this PARP inhibitor therapy, and to reduce the toxicity, means the normal toxic, generalized toxicity as much as possible.
So the drug delivery will be targeted?
No, drug delivery this is orally active. So that is the beauty, because
okay. Thank you.
Professor Sharma has a question. Professor Lohia has a question.
I think I wanted to compliment Dr. Sharma, Dr. O.P. Sharma, for excellent presentation. And we know that prostate cancer is a big problem, and specifically in metastatic situation, when the prostate becomes hormone resistant or castration resistant. In that situation, we hope that your team efforts in times to come, we would be proud to say that Indian US citizen has come out with a solution of hormone-resistant prostate cancer treatment. Compliments, and thank you so much.
Thank you very much, Professor Lohia Sahab. One thing probably for the audience is that I am product of Professor Lohia's laboratories. Professor Lohia is my mentor in 79 to 1984. I spent really wonderful years with Professor Lohia, where I learned how to investigate. And that's what I have been following that and continuing my profession as of today.
Great. So if there are no more questions, I would like to thank Professor Sharma for an excellent talk. Then moving on to the next speaker.
Thank you.
Next speaker is Professor Shyam S. Kasur. He is a professor of Department of Physiology, University of Louisville. He is a PhD in biochemistry from National Dairy Research Institute, NDRI, and an MBA entrepreneurship from the University of Louisville, USA. And he is the founder and editor-in-chief of Journal of Ovarian Research, and a founder and executive director of Proceedings of Stem Cell Research and Oncogenesis. His research interests are in cancer, drug discovery, molecular mechanisms of disease development of novel combination therapy for ovarian cancer, targeting cancer cells and cancer stem cells in ovarian cancer, securing and cancer stem cells in regulation of tumor growth and progression. Professor Shyam.
Let me share my slides.
Yeah.
Can everyone see these slides?
No, not yet.
Not yet. Okay, let me try again.
From the desktop, you have to minimize, and then when you go to the share screen, the screen will come, and then that PPT.
And that's what I'm doing.
Nothing is getting shared.
Can you see now?
No, not yet.
Maybe you can present the slides, because I sent the slides to Deepa Bhatia.
Yes, the organizers have your presentation.
Yes, sir. We are doing that. Just give us a minute, please.
Okay. And while slides are being projected, I would like to thank you, the organization committee, especially Dr. Deepa Bhatia, for the invitation I'm really very, very thankful to share my thoughts about it. So what I'm going to provide is an overall view of infertility and what techniques are being used and how we can get rid of this infertility problem. So as it's shown in the first slide, this is the University of Louisville, and this is one of the building we have known as a Clinical Translation Research Building. I had my research lab and office there. Next slide, please. Okay. So as I mentioned that I'm going to give an overall view of the infertility. So in clinical terms, the infertility is defined as a disease characterized by the failure to establish a clinical pregnancy after 12 months of regular unprotected sexual intercourse due to an impairment of person capacity to reproduce either as an individual or with her partner, his or her partner. Infertility condition could be attributed by male as well as female or both. Approximately 12 to 15% of the reproductive age couples, representing about 28 million couples worldwide, and approximately 72 million people are affected by this disorder. Next, please. So there are several reasons where couple can end up in infertility. And if we start at the chromosomal pairing at the time of fertilization, there are several reasons the couple can or individual can end up in infertility. If there is a normal pairing of X and Y chromosome, we can get male as well as female, depending on the chromosomal pairing XY or XX. However, there is a defect in pairing of chromosomal, like if X chromosome pair with some other chromosome or truncated form of Y chromosome or mutated chromosome, it can end up in Turner syndrome, which has a streak organ. It doesn't have ovaries or testes, and Mullerian duct will develop, whereas the Mullerian duct will develop, which represent the female reproductive organ, whereas the male organ will regress. So the child born will serve as a female and will never get any menstruation and will be infertile. And there could be other case that there are androgen receptor on X chromosome, which is essential for the male or female. So if these androgen receptors are missing, the gonads will be testes and child will be born as a female and will be infertile. And if there is a deficiency of testosterone synthesis due to mutation in the synthesis of testosterone, this could be male or female, depending on the deficiency of the testosterone. Another defect could be that there could be mutation or deficiency of 5-alpha reductase, which converts testosterone to dihydrotestosterone. The organ may not be fully developed, and the child born could be male or look like a female. Then we have Klinefelter syndrome, which is XXY. In this case, the testes are non-functional, and the child can be born as a female. And then we have XX androgen missing 21 or 11 hydroxylase, which will result in large amount of production of androgen, which could be causing Malaria in case of female and precocious puberty in case of male. Next, please. So as I said, there are several causes of infertility, and some of these are listed here. I didn't list all of them, but the major one are, in case of female, we have abnormal menstruation. That menstruation could be irregular. It can happen anytime. And then ovulatory disorder, that there may be disorder in ovulation, that ovulation may not take place or may take too early. There is a decrease of secretion of gonadotrophin, that gonadotrophin level may be low, such as FSH and LH, and there could be high level of androgen, which can result in PCOS, polycystic ovarian syndrome, and there could be ovarian failure, that ovaries may not develop fully and unable to ovulate. In case of male, the major defect or azoospermia, which is not having enough sperm in the production, then mutation of androgen receptor, hypogonadism, that gonads are too small, lack of synthesis and secretion of testosterone, or sperm abnormality. All these factors can contribute to infertility. Next, please. So if we look here, put together in case of male and female, some of these things we have talked, but in addition to what I talked in my previous slides, that infertility can be contributed by cystic fibrosis. There could be blockage in the fallopian tube, Ashman syndrome, which could be a scar in the uterus, and POF, endometriosis, and PCOS in case of female. In case of male, we could have pituitary carcinoma or adenoma, Kalman syndrome, hemochromatosis, obstruction, absence of vas deferens, absence of epididymis, azoospermia, small testes, the lack of descending of the testes out of the body, because the testis has to descend out of body to have optimum spermatogenesis. Next, please. So if we look the overall tragedy, how this regulation, the reproduction is regulated. So we have the hypothalamus, which has a neuron, which secretes GnRH, gonadotropin releasing hormone, which is delivered to the anterior pituitary, where it binds to its high affinity receptor called gonadotrop cells, and they secrete and synthesize two gonadotropin, FSH and LH, and both these hormones have receptor on in testes as well as in ovary, and regulate the production of gonadal hormones as well as spermatogenesis in case of male and oogenesis in case of female. And on the right side is a structure of GnRH, which is decapeptide, and based on structure, the position 6 is important, and a lot of analog has been made by changing the position 6 glycine to other amino acid, and some of them are 10 times or 100 times more active and have higher half-life compared to native GnRH. Next, please. So if we look how this GnRH activates the LH as well as FS excretion, what are the downstream signaling? In the past, before the molecular biology became prominent, there were 3 mechanisms known. One was the activation of adenyl cyclase, which produces a cyclic AMP, which could activate the transcription of several genes. The other was PLC, activation of phospholipase, and which could increase IP3 inositol triphosphate, which is responsible for the increase of intracellular calcium. And the third mechanism was known as the activation of PKC, as well as the opening of the calcium channel. These were the 3 major mechanisms known for G protein coupled receptor. So activation of G protein coupled receptor here, GnRH, by GnRH caused these 3. And if there is any defect, which we have seen abnormality or mutation in the GnRH receptor, which could be leading to partial or complete infertility. And when we did the gene array, these are some of the downstream genes I'm showing, but there are several, there were 200 genes which were upregulated or downregulated. So it's a complex mechanism by which GnRH induce its interaction with GnRH receptor and induce the downstream signaling. Any defect in these signaling pathways or the molecules or receptor can cause to partial or complete infertility. Next, please. So several techniques are conventionally being used or have been used in the past, which include, in case of male, improvement of sperm quality, surgical correction of varicose seal, anti-estrogen and gonadotropin therapy, antioxidants such as vitamin E or zinc, along with assisted PCOS. Previous slide, please. And ovarian stimulation, where we can increase ovulation, oocyte retrieval, in vitro fertilization, embryo culture, and embryo transfer. So these are the techniques which have been used in the past to modify the fertility. Next, please. So the new technology which have been come into play for the last couple of years, at least 15 or 20 years, the use of stem cell technology to improve the infertility. So if you look at that stage of fertilization, we have the embryo or blastocyte, which contains two types of cell, outer layer and inner layer. The inner layer forms embryo and the outer layer forms placenta. And the inner layer differentiates and amplifies to primordial germ cell, which can lead to sperm or eggs, depending on male and female. And somatic cell, they just convert into the different types of cell in the body to form a full-grown fetus. So the stem cell, in embryonic stem cell, and there are other techniques which have come into play, is that we can take somatic cell and make them embryonic cell by expressing few genes which are called induced pluripotent stem cell. So those cells can be differentiated into primordial germ cell, which can form gametes. And if you have the gametes from male as well as in female, they can do in vitro fertilization and can be transplanted back to the female to give a birth to a baby. Next, please. So it's easy to say, but hard to achieve. We can get embryonic stem cell or inducible pluripotent stem cell, but their differentiation into primordial germ cell is a big step, which is very hard to achieve and is a bottleneck technique which all of us are facing. And if we get over this one, since we do not have complete knowledge how this germ cell or this stem cell differentiate into primordial cell, we don't have the culture condition or in vivo condition where we can generate gametes. Therefore, we are not fully successful to achieve this step. Lots of scientists worldwide are working at this step to achieve what is required to gain fertility in infertile couple. Next, please. Next slide. So if we take the cell, collect somatic cell, which could be from fibroblast, blood cell, muscle cell, adipocyte, epithelial cell, they can be reprogrammed and express different types of gene, which could result in pluripotent stem cell, and which can be differentiated into primordial cell, which can differentiate further to oocyte-like cell or spermatid-like cell. And if this oocyte and spermatid-like cell, which could be sperm, in vitro, we can do fertilization and then transplant it to female and overcome the infertility in case of the couple which is suffering at the infertility case. Next, please. So there is other reason where as we grow, in case of females especially, the oocyte quality goes down, which can be improved. The egg quality and IVF outcome largely depends on the number of mitochondria, energy producing batteries in the eggs. We know mitochondria produce ATP, which serves as a source of energy. The fertilized egg has only maternal mitochondria, no paternal contribution. Decreased number of mitochondria with age result in increased defect during cell division, early development, and implantation. So if we take the early eggs and extract the mitochondria and inject into oocyte, it can improve the quality of oocyte, and which could be capable of fertilization and give rise to a healthy baby. Next, please. So there have been cases where the mesenchymal stem cell, which are the cell which are present in every organ and every tissue in the body and commonly used, there are 700 clinical trials going on using the mesenchymal stem cell for different disorder in human. So the assumption of these cells can be collected from menstruation, blood or whatever. Pregnancy after 11 months has been established, and the healthy baby was born, named as Zainab. Next, please. So if we take this mesenchymal stem cell from bone marrow or adipose tissue or ubiquitous cord blood, and these can be differentiated into endometrial stem cell, and activation of these cells can result into pluripotent stem cell, which can differentiate into oocyte or the sperm, and then they can be used for fertilization purpose to overcome the infertility. Next slide, please. So there are several very good articles, if somebody likes to read, how we can use mesenchymal stem cell for recovery of fertility and making gametes from alternate source of stem cell. What are the past and where we stand right now, and ovarian stem cell resolving controversy by Bhartiya. And these are very good article, and anybody interested using the stem cell technology in generation of gametes can go to these articles and read more about it. Next, please. So making gametes from stem cells, so they can be collected from the embryonic stem cell, or we can induce pluripotent stem cell by induction of some of the genes in somatic cells, and those cells can be converted into gametes. However, there is a problem, and it has been over 15 years that we are still not fully capable of converting the somatic cell or using the embryonic stem cell to convert it to gametes to further advance to the fertilization. Next, please. So there is other technique we can use which we can use the embryonic stem cell. At the time of fertilization, we know blastocyte is formed, which forms two layers, outer layer which forms placenta, and inner layer which are called embryonic stem cell. We can take these embryonic stem cell, culture them to amplify, and then we can differentiate it to sperm or oocyte by treating with FSH as well as several other growth factors which can be used for implantation. In case of female, we can produce iPS cell, and these iPS cell can be fertilized with the sperm coming from the male, which are also taken from the somatic cell and just converted into iPS. So we can form fertilized zygote, which can be transplanted into female who have a defect or maybe surrogate mother, and can be used for production of babies offspring. Next, please. So my colleague has talked a lot about the V cell, and here are some of the information I'm providing. That this is a paper from Ermaklan from Slovenia. What she did, she took the stem cell or total cells from ovarian surface epithelial, which contain number of stem cells, and by changing the culturing condition, she was able to show that these stem cells present in the OSC could be converted into oocyte-looking cells. And later on in her work, she reported that these oocytes are biologically active and capable of undergoing fertilization. Next, please. So there's another paper from her. You can easily see that these are the stem cell or OSC cells, which contain very small cell. This is stem cell or V cell. And by differentiating and culturing, within few days, they could convert into oocyte-looking cells. And these oocyte-looking cells have the nucleus and the cytoplasm, and these cells are functionally active and can be used for fertilization purpose. Next, please. And this paper is from Dr. Bhatia. She also shown that the OSC cells taken from the ovary can be converted into the oocyte-looking cells, which could be capable of fertilization. So these are the V cells she used, and Dr. Maurice Radachek, who is my colleague and next door worker, our colleague, investigator, we collaborate quite a bit. And he invented these cells and talked a lot about in his lecture. These cells are excellent and can stay in the body forever and can be used for various regenerative medicine, including production of oocyte as well as sperm. Next, please. So using mesenchymal stem cell is a common procedure to overcome the infertility, but these mesenchymal stem cell initially were considered as a pluripotent stem cell, but later on, a lot of investigators found that these are not pluripotent stem cell, but they secrete the growth factor and chemokine, cytokine, and those, the factors secreted by mesenchymal stem cell activate the stem cell in the body or in tissue, which can undergo growth and differentiation and result in the formation of the cells which are used for repairing of the tissue.
Yeah, there's an internet issue, I think.
Excuse me, sir. We are unable to hear you.
I think there's an internet issue.
There is an internet
video also has got frozen.
Yeah, it's disconnected completely.
No, he's still there.
We can wait for some time, I think. Is there any way that you can contact him, WhatsApp or something like that?
Yes, sir, we are doing that right now.
Okay.
He's changing the slides.
No, I think we are doing that, sir.
Okay.
Yeah.
We cannot hear you, Dr. Kakkar.
Somebody has to WhatsApp him and then talk to him.
No, but
Yes, sir, we are doing
he can
that.
hear.
Actually, we don't have his number, but we are messaging him. We are trying to message him.
Dr. Deepa Bhartiya may be having.
No, I don't have his number.
Oh, Dr. Deepa, you don't have?
No, mobile number I don't have.
Okay.
Should we proceed to the next? Yeah, because I think we are running late on time. So
Yeah,
it's maybe, sir, so you can decide and we can go to the next speaker.
Yeah.
Dr. Marcius,
please do. Yeah,
Dr.
please.
Radzak is calling him on phone.
Okay.
Just a minute.
He's saying next
Yeah,
slide,
just
but we
wait.
cannot hear him. Yeah.
Wait for a few minutes.
Yeah, sure. Actually, he's messaging that next slide, but we cannot hear him.
Dr. Radzak is talking to him on phone. Let's wait.
Sure, ma'am.
No, I think we should move ahead.
Yeah, I think. Yeah.
Let
Sir,
the chairperson.
Sir, maybe you can start the next lecture.
Professor Chogle, should
Yeah,
we?
I think we should go for the
should
next
we move to the next speaker?
Yeah. I think so. Because already lost complete contact.
Yeah.
Sure.
So let us move to the next speaker.
Sir, just
Next
one
speaker.
second. Rupert Ecker's talk will be a recorded one, just to let you know. So you can go ahead introducing him. Yeah.
Please. Rupert, he is a co-founder of Tissue Gnostic Group in Austria, Romania, and USA. And he is the Chief Executive Officer of Tissue Gnostic Austria and Romania, Vice President in USA, as well as Area Manager for the China. He is the co-inventor of the tissue fax technology. And Rupert has graduated in cell biology from the University of Vienna. He has more than 20 years of experience in microscopy and image analysis. And since August 2021, Rupert holds an honorary appointment as adjunct professor at the Faculty of Health, School of Biomedical Sciences, Queensland University of Technology. And
I think now Dr. Sham has got connected. Can you listen to us?
Yeah, Dr. Sham has connected. Can we?
Yeah. So now I think.
I've been disconnected for a long time.
Yeah.
Okay.
So I like to I just like to go my last slide acknowledgement and stop it here because his time is over.
Barkha, could you share his presentation?
Yeah.
Last slide, please. Go to the last slide. Yeah. So I know we had a problem go to next slide.
Go to the last slide.
Go to the last slide because all these slides are available if somebody likes to see. And we have different techniques which I cannot talk. Just go to. So anyway, so I know there have been problem in communication and presentation of slides. It's because of the media we have. We can't help. It's not the same thing what we have face to face. But I like to acknowledge my collaborator, Dr. Deepa Bhartiya, who is present there, and she has been great help. We have been publishing together on FSH receptor and so on. And Maurice Radachek, who is my next door colleague, I interact with him quite a bit on stem cell and cancer stem cell. And Sarama Saw, she's MD and faculty at All India Institute of Medical Sciences in Rishikesh. She has been helping me in writing the manuscript and review article. Arma Clan, I associate with her, and she has been great help. And of course, nothing can be done without money. The funding is provided by NIH. With that, I appreciate everyone for your attention, especially Deepa Bhartiya for her help as well as contribution and invitation. Thanks a lot and have a good day.
Thank you, Professor Shyam.
So, yes. Any question you have, I can answer, but if you don't have time, I can answer by email.
Maybe we can take one question or so.
Sure.
If there are no more questions, so I would like to thank Professor Kakar, and I'll request Barkha to proceed with the Rupert's talk.
We are not getting the audio.
Yeah.
The organizers, please check the audio.
Yes, sir. We are just playing it. Just give us 1 minute.
Okay, no problem, no problem.
Yeah, Nidhi and Barka, I can do it from here. I can try from here.
Yeah, Prashant.
Yeah, please, Prashant. So Barka, you can stop the screen share.
Sorry, was it audible? Yeah.
I am a adjunct professor at Eastern University of Technology, as well as co-founder.
Excuse me, was this audible?
No, it is not.
How about now, sir?
Yes, Prashant. Yes, Prashant.
Yeah.
Sir, is it audible, right?
But it is not clear.
It is not clear.
Yeah.
This is a method for quantitative single-cell analysis.
You have to increase the volume.
Yeah.
What is the highest?
I'm sure you are familiar with flow cytometry.
How about now? Yeah.
Let's see.
Namaste from Brisbane in Australia. Greetings to all
Yes, better.
Paternal 2022. My name is Supadeka. I am a adjunct professor at Eastern University of Technology, Brisbane, as well as co-founder and CEO of Crosstalk in Austria. It's my great pleasure to present to you about.
It is not clear.
No, it is not clear.
It's not clear. We can't hear, understand.
It is not clear.
Yeah. So if that is not too much asking you all, maybe I just upload this in ISSRF YouTube page, if that is okay with the chairpersons.
Yeah, I mean, can everyone watch it now?
Yeah, you can move to the next page, sir. I mean, you can move to the next speaker, please. Yeah, thank you.
Okay. So we'll next will be the oral presentation by Dr. Sachin Kadam. He is a PhD in biotech. He is an associate professor, Manipal Academy of Higher Education in Manipal. He has received Outstanding Achievement Award in the fields of stem cells, regenerative medicine by Society for Bioinformatics and Biological Science, and Distinguished Scientist Award from the Society for Bioinformatics and Biological Sciences, YW Loke New Investigator Award by Elsevier Publication Group, and also a DBT International Travel Fellowship. He has 42 peer-reviewed papers and 4 book chapters and 2 Indian patents. And his research interests are in stem cells, biomaterials, tissue engineering, and bioartificial organ development. So this talk will be of 10 minutes and 5 minutes for discussion. So, Dr. Sachin, please come to
Yeah. Can you see my screen, please? Hello? Hello?
Yeah, we are able to listen to you. So now,
please upload your presentation.
No, Barkha, you have to.
Yeah,
now good.
Yeah.
Can you hear me now?
Not yet, because I think internet speed is less, so it is not getting uploaded. Yeah, now it is.
Yes.
Okay. Okay. So you can hear me also, right?
Yeah.
Yeah. Okay. So, good evening. First of all, let me thank Indian Society for Study of Reproduction and Fertility, and also the organizing committee members of the International Conference on Reproductive Health for inviting me and giving me opportunity to speak on this platform. I would like to thank for giving me this opportunity. I'll be discussing where we stand today in terms of effect of platelet-rich plasma on female reproductive health and menstruation. As we know, like we have already seen the definition of infertility. The exact definition of infertility is the clinical indication or a disease of the reproductive system wherein there is a failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. Infertility can affect both men and women. The majority of research on this topic is generally focused on women. If we see the percentage also is more in female in case of infertile problems than male. There are various reasons why infertility affects and be from age to lifestyle related issues to even medical issues. Available data indicates that at least 50 million couples worldwide experience infertility. And an estimated 15% of couples will have trouble conceiving. If we see the USA scenario, in USA alone, about 9% of men and 10% of women aged 15 to 44 reported infertility problem. I hope I'm audible to everybody.
Yes, it's audible.
Yeah. So if we see the infertility statistics worldwide, 9 to 10 countries with the highest total fertility rate are in Africa, followed by Afghanistan. Southern Europe, Eastern Europe, and Eastern Asia have the lowest fertility rate in the world, with an average of 1.5 children per woman. Sweden has one of the highest fertility rate in Europe, close to 1.9 children per woman, and 1 in 4 couple in developing countries is affected by infertility. If we see the global infertility treatment market size, it is projected to grow from today's $1.5 billion US dollar to $2.2 billion US dollar by 2026. Growth in infertility treatment makes in this particular market is primarily driven by factors like declining fertility rate, rising number of fertility clinics worldwide, technological advancements, etc. However, these high technological oriented infertility treatment like IVF or ART comes at a marginally high cost. In 2021, the female infertility treatment segment commanded for share of infertility treatment. In environmental exposure and infectious diseases have been linked to infertile risks. We have already seen all these factors in our previous slides. I won't go much in detail in this particular slide. If we have to see the treatment of infertility, there are like when it comes to the treatment based on the cause, treatment is administered to the patient. There are treatment like hormonal stimulation, where doctor prescribe hormone to stimulate women's ovaries, which is most effective fertility treatment for PCOS. Then IUI, where a specialist delivered washed sperm to the uterus, and is the best treatment for women with hostile uterus, and effective conception way for men with low sperm motility. IVF, we all know IVF is it takes place outside the woman's body, where the sperm and egg are fused, and then the fertile embryo is transferred to the uterine cavity. There is a new treatment method which is arising, which is a cell therapy method, where people have started using stem cells or platelet rich plasma for infertility treatment. So when we say platelet-rich plasma and stem cells, the stem cells we have already seen in last lecture, like, there are many hurdles arriving with this particular therapy. Also, when we talk about stem cells, like, there is an expertise required. So doctors have automatically shifted their focus on PRP, which is platelet-rich plasma. And the reason of this shift in focus is because this is a quick method. It is easy to prepare and administered. Very minimally invasive. You just have to draw blood from patients and centrifuge. It's a proven in repair and regenerative medicine methods. Alternative for natural regeneration of residual stromal cells, which helps in rejuvenation of poor ovarian reserve, triggers stimulation of oocyte production. Generally, functional properties of the PRP are mainly based on the synthesis and secretion of multiple growth factors that are secreted after platelet activation. These factors are essentially stored in thrombocytes granules, and they have key role in regulating cellular process, including chemotaxis, mitogenesis, and differentiation. Secreted growth factors directly stimulate local mesenchymal stem cells and epithelial cells to migrate, divide, and repair or regenerate. If we see this particular table, every growth factor secreted by platelet has a specific role or effect in treating various elements of infertility. So, coming to the PRP's application in ovarian regeneration, if we see the effect of PRP in ovarian regeneration, the autologous use of platelet-rich plasma offers significant protection from ROS through an increase in the secretion of vascular endothelial growth factor, or VEGF. More recently, direct infusion of autologous PRP in ovaries of perimenopausal women confirmed the resumption of menstrual cycle. The study has further been considered the benchmark for utilizing PRP in treating perimenopausal women. The pro-angiogenic effect of autologous PRP on ovarian follicle was explained with the increased expression of VEGF, further indicating good ovarian response post stimulation and progressive encapsulation of follicle in the capillary network. Platelet-derived growth factor, or PDGF, is another vital release responsible for delayed follicular aging, vessel formation, and follicular development. Thus, infusion of autologous PRP can be a unique way to treat ovarian insufficiency, reported as one of the primary cause of infertility in women. In case of regeneration of endometrial lining, PRP improves the endometrial receptivity through the improvement of cell proliferation, vascularization, anti-inflammatory properties, and the reduction in the degree of fibrosis with the help of concentrated peptide and a cascade of growth factors like PDGF, VEGF, and many more, and also cytokines present in the PRP. Multiple studies have demonstrated the role of GCSF secreted by autologous PRP in cellular proliferation and increased differentiation of resident stem cells to decidual cells to maintain interaction between the endometrium and embryo. Studies have further confirmed that implication of autologous PRP have improved success rate of pregnancy and reduced incidence of miscarriages. Multiple reports generated from various preclinical and pilot study confirm that intrauterine autologous infusion of PRP promoted endometrial regeneration in women with impaired endometrial growth and delayed menstruation. At the same time, more in-depth analysis is required scientifically, without which widespread implementation of PRP treatment for addressing various complications associated with delayed menstruation is difficult. If we see, no treatment comes without limitation or potential risk. So in PRP, clinical studies, the efficacy of PRP in improving uterine endometrial function remain controversial. most studies suggested that PRP treatment resulted in positive reproductive results in patients with thin endometrium, recurrent implantation failure, chronic endometriosis, etc. However, the best dosage and timing of PRP application are still unknown. Few studies assess the underlying mechanism of PRP treatment, but PRP have shown improvement in the endometrial receptivity through the improvement of cell proliferation, vascularization, anti-inflammatory properties, and the reduction in degree of fibrosis with the help of concentrated peptides, growth factors, and cytokines present in the PRP. But for its potential clinical application, further detailed study of the mechanism is required, though that the possible value of PRP treatment on the endometrium of infertile women, more carefully designed study on the larger scale are required. Further, the standard PRP preparation procedure or protocol and strict indication of PRP treatment is more essential, because there are 3-4 different protocols which can create a confusion between clinicians and researchers. Then the most importantly, studies and follow-ups are needed for the long-term health and complications of the resulting child, which is absent so far. So from this talk, the take is therapy is very effective in treating multiple elements associated with delayed pregnancy or scientists are still struggling to understand the activation switch of the platelet. As discussed, platelet exhibit the capacity to secrete multiple growth factors, cytokines, and inflammatory markers upon activation that may respond in rapid healing, regeneration, and tissue-specific regeneration of resident stem cells. However, studies have also shed some light on the activation status of platelets. They have confirmed that the activation status of platelet differs remarkably from that of platelets in their resting state. So activation is very important. With the critical information of activation switch in the body, scientists are looking forward to manipulating and exploiting therapeutic application and treating several elements that cannot be treated with conventional medicine so far. So with this, I would like to end my talk, and I again thank the organizers for giving me an opportunity to present this particular talk at this forum. Thank you so much.
Thank you, Dr. Sachin. We can take 1 or 2 questions if there are any. So if there are no more questions, then we will move to the next speaker of the session. The next oral presentation is by Dr. Vikas Chandra. He is from IVRI Aizat Nagar. Dr. Sachin, could you stop presenting your thing? Yeah. So Dr. Chandra is presently working on mesenchymal stem cells secretome for regenerative therapy and strategies to enhance quality buffalo embryo production in vitro. And he has completed 5 institutional and 2 outfunded projects as principal investigator. And he has mentored 6 MVSc and 4 PhD students as major advisor and published more than 50 research papers in peer-reviewed journals and published edited books, 3 books. He has been awarded with prestigious awards like Young Scientist Award, Bharat Excellence Award, SAPI D.N. Malik Award, API Mid-Career Award, etc. And he's also the General Secretary of Animal Physiologists Association. So I would like to invite Dr. Vikas Chandra to give his presentation on in vitro culture interventions to enhance oocytes and embryo developmental competence in buffalo. Dr. Vikas.
Good evening to all. And first, I would like to thank the organizers of the ISSRF-2022 for giving me the opportunity to share my work in this great platform.
A little increase your volume.
Your voice is a little bit low.
Yeah, loudly.
I will be talking about the in vitro cultural interventions to enhance the oocyte developmental competence in case of buffalo. As when we do the IVF in case of buffalo, when we're driving the oocytes from the starter house, so we see that most of the embryos are arrested at the 16 cell stage. And we think that it is because of the embryo culture conditions are not proper. But in our study, we have found that this oocyte quality is very important as far the IVP outcomes are important. So at the time of renewal of the oocyte from the ovary, it determines the fate of the embryo or its further development. So not only the nuclear maturation is important, but proper cytoplasmic maturation for IVF is very important. What is the oocyte developmental competence? Is the ability of oocyte to completely mature.
You can go to the next slide. It's only the first slide we are able to see, I think.
Your slides are not moving. I mean,
I think the slides is not working. I can work like this.
No, you can.
Yeah. You go to the presentation.
Presentation, same only. Just click on those slides. Yeah, in the sidebar.
It will be okay in this mode, sir?
Yeah, it is okay. It is okay.
His volume is also very low, I think.
I have tried, but it's not including, sir. So may I go like this, sir? So during oocyte growth, it attains cytoplasmic maturation, and during that period, it accumulates sufficient mRNAs and proteins, and also the number of mitochondria. Because the number of mitochondria multiplication is stopped at the time of ovulation, and it's not getting increased till the blastocyst stage. So that cytoplasmic maturation time is very important. And when we are culturing the oocytes, we screen the oocytes on the basis of some morphological parameters like number of cumulus layers and compactness, homogeneity of ooplasma and maturation in terms of first body release. But all these parameters are not found reliable to solve criteria to solve the problem. And other criteria to select the competent oocytes are biochemical markers like BCB staining, bloom to soluble staining, and on the side of follicles and molecular markers, zona bifurcations, dielectrophoretic migration. Here we studied this simple biochemical assay, bloom to soluble assay, which depends upon the G6 activity of the oocytes, which goes down during the development of the oocytes, which are fully grown. They have lower BCB activity, so they remain BCB positive, and those are less competent are BCB negative. On that basis, we found that it stain works well and selects this competent oocytes, and the selected oocytes are producing good cleavage rate as well as the quality blastocysts. Then certain molecular markers from the cumulus cells can be used as markers like GREM1, EGFR, S2, and TNFI6. And it has been shown that this expression of these markers is higher in case of BCB positive oocytes. Then we can screen these oocytes from the quality itself, and using the larger follicle derived oocytes gives the higher cleavage rate as well as the blastocyst rates. Another marker is the zona of hyperfringence, which determines the thickness of zona pellucida and its uniformity. So this assay can be used in association with other biomarkers to increase the competence of the oocytes. Another is the dielectrophoretic migration. When we migrate the oocytes under the electromagnetic conditions, the faster moving oocytes are more competent compared to the slower moving oocytes. So how to improve the competence of the oocytes? One way is the questing to induce the competence. Before oval pickup, we can do questing in the live animals, then screening of and culture of the oocytes, screen maturation of the oocytes to give more time for the cytoplasmic maturation, and then culture of these oocytes and embryos in the oocyte secreted factors and supplementation of some growth factors like lectin and amino acid, L-carnitine, progesterone, etc. So questing means to when culturing giving the oocytes or follicles the starvation of the gonadotropin and sufficient LS stimulation. So it gives this section pressure in the ovary. So most of the large follicles are available for the ovum pickup. So this study in case of cattle has shown that more than around 90% cleavage and 80% blastocyst after the 48 hours of the questing in case of cattle. So another technique I have told you, biochemical staining, BCB staining has been proven.
Increase your volume because hardly audible. Speak loudly or increase your volume.
Or come closer to the mic.
Yeah.
I'm trying, sir. So when what we
Still, it is not good.
Sir?
Come a little bit closer to the mic.
Yes, sir. I am closer to mic. So what we can do for the those oocytes are lesser competent. So we thought that let us give some time for them to extra pre-maturation time. So we can culture these less competent oocytes derived from smaller follicles in the meiotic inhibitors like roscovitin. Suppose roscovitin binds with the ATP binding domain of the CDK2 and it maintains the germinable cycles state of the oocyte. And we standardize that concentration of roscovitin at 25 micromolar to inhibit these oocytes at the JVBD stage, and after releasing it, spontaneous maturation is also occurring. And we found that after treatment, the expression of these markers, molecular markers, is increased in the tumuluses. Most of the markers are increased. So we can say this works. And the quality of the blastocyst produced was also good in case of roscovitin treated groups in some blood 1 and OCT4. Then another treatment is if you supplement the oocytes with the oocyte secretory factors, either endogenous means denuded oocytes also secreting the oocyte secretory factors, and from outside GDF9 and BMP15 can be supplement. So if you supplementing both growth factor GDF9 and BMP15 are indigenous growth factors, so if they improve the competence of the oocytes derived from the small follicle or larger follicle growth. And in terms of the molecular markers, also we found that expression of these molecular markers was increased in when we supplemented the oocyte secretory factors and the indigenous one also. And in our intervention, we made that because we see that the stem cell condition media contains several growth factors. So we thought why we cannot supplement this stem cell secretome to this culture media of further maturation or culture of the embryos. So we found that 50% of the, when you supplement 50% transition media to the modified synthetic proteolytic fluid, it enhances the blastocyst rate as well as the quality of the blastocyst produced. Another thing is when we supplement the leptin in the maturation media as well as the culture media, it is significant to improve the cleavage rate as well as the blastocyst stage development. And it proved that so the different molecular markers they were increased in the treatment group. Similarly, the quality of the produced embryos were also improved. Then another problem in case of buffalo is that intracytoplasmic lipid droplets, which hinder the cryopreservation outcomes of the embryos also. So we thought that how to reduce the lipid content in the buffalo embryos. For that, we supplemented the L-carnitine amino acids, which affect the beta oxidation process and lipid biosynthesis also. So when we supplemented the L-carnitine, we found that lipid synthesizing molecules were expression were decreased, like GG1, CP2, and DAG1 and MP gamma 1. While the beta oxidation process involved the molecular markers were increased, beta oxidation were increased. Ultimately, the lipid content was decreased in this, and the quality of the blastocyst produced was also increased in the 1.5 molar supplement L-carnitine supplemental groups. Then we see that when the embryos growth, the progesterone level also increasing in the circulation. So we thought that it might be having some role also in the embryo development. So we supplemented the progesterone in the culture conditions. So it also improved the cleavage rate as well as the blastocyst rate. So in summary, we can say before oocyte collection, we give the questing period before ovum because it increases the population of larger follicles for the available for the fertilization. And whatsoever the low quality oocytes of the smaller follicle derived oocytes are there, we can further culture them in the roscoitin like nuclear inhibitors to give more time for the cytoplasmic maturation. And otherwise, we can supplement the oocyte secretory factors or denuded oocytes as the indigenous oocyte secretory factors and enhance the oocyte developmental competence. We can supplement these growth factors and amino acids in the culture media or stem cell condition media to further improve their competence. So this biochemical markers, this will be proven to be used as a screening markers for the screening of these competent oocytes to increase the competence of the oocytes. This is the summary for my presentation. Thank you, sir.
So, thank you, Dr. Vikash. Now the talk is open for discussion.
Oh, there doesn't appear any questions.
Yeah. So, if there are no more questions, I would like to thank Dr. Vikash for an excellent presentation on the various strategies to improve the developmental competence of the embryos in buffalo. May I now request Dr. Arun Chogle to summarize the session?
Thank you very much, Dr. Krishna Mohan, for introducing and doing the job of the invited talks and the oral presentation. In this session, that is the reproductive health therapeutics, we had a keynote talk that from the Ratajak from University of Louisville, Kentucky, and he talked about the future of stem cell therapy, search for safe and therapeutic efficient stem cell for organ regenerate, and that generated a lot of questions and discussions. And the invited talk by Om Pri Sharma, who is again the student of Lohia, worked with him and running a pharmaceutical company. He talked about the emerging role of PRP inhibitors as a precision treatment option for patients with prostate cancer, because prostate cancer is one of the leading cancer in advanced countries, Europe and USA, and in India too, it is picking up and number is increasing, and he has said that the things will be rolled out soon. The another invited talk was from the Sham S. Kakkar from University of Louisville, Kentucky, on stem cell for infertility treatment. He talked in details, though we lost connection in between, but he could connect again with us. Because of the time, variation in Austria, in India, the Rupert Ecker has given his talk as a recorded one. Unfortunately, it could not be played because of some technical problem, but organizers quickly put it into YouTube and it is available. Chat box also they have given. Also, I see the WhatsApp also group, they have put that link, so you can listen to it as and when you like and want it. Then there were two oral presentations, one from Sachin Kadam and another from the Vikash Chandra. Sachin Kadam talked about the effect of platelet-rich plasma factors in female reproductive health and menstruation, and Vivek Chandra talked about the in vitro culture interventions to enhance oocytes and embryo development competence in buffalo in animal, because this conference we know we are dealing with the human, animals, all kind of studies, basic research, lab research to clinics and all those things. It is the wide range of researchers, clinicians we have got. So with this thing, without wasting time, because already we are almost half an hour late running, and thanking the organizers, thanking on behalf of Krishna Mohan to the organizers for giving us the opportunity, all the speakers for sparing their time and making us the knowledgeable about the work they are doing and the contribution. With this thing, thanking each one of you, I hand over the floor back to the organizers who have done the extremely good job of doing this, sitting across the world. We are able to connect. Yes, technology has sometimes limitations, sometimes nothing is fail-proof, it happens, and it is not a personal this thing, but yes, they have done this thing. With thanking each one, I take leave from you. Thank you very much.
Thank you very much.
Thank you so much, Ogle sir, for appreciating us. Thank you, KM sir, for wonderfully chairing this session. I thank, on the basis of ISSRF team, I thank all the chairpersons for chairing the sessions. I thank all the invited speakers, keynote speakers, oral presenters for their time. We know there was some technical glitch, but we apologize for that. Now I invite our president for general body meeting of ISSRF. Thank you.
Thank you so much, Nidhi. And it's a great pleasure to extend a cordial welcome to all distinguished senior colleagues, scientists, members of the society,